surgery, you're able to take in the longest possible screw. You're able to take in the fattest possible screw accurately without having the risk of blowing out that, especially true in thin Indian osteoporotic women, where this is required. You are able to see real-time screws going in. It is a system that will allow you to use non-Medtronic screws also, but Medtronic screws are seen the best because each one has its own digital footprint in this navigation. Also, it retains memory. This is very important in multiple levels, especially when you're doing scoliosis. So you can actually see the horizon of the screws that you put in. You see which screw is a little superior as compared to the curve that is going in. So you can alternatively take them, put them in, put them out, so that your reduction and your rod goes in much better. Well, it is also useful in anterior work where you're putting in a cage. You can actually see your trials go in, your shavers go in, and you can see your cage going in. That can be navigated. So the chances of keeping a cage proud, being I'd say looking into the spinal canal or too far into the anterior space is avoided. These are important things. It may not happen every time, but when it is going to happen, these are the things that will prevent those tragedies from happening. These are anterior surgery images. So how does it start? I'm just going to run through how it goes through a case. You have taken a CT scan image of the patient on table, and that is fed real time to the system. How does it work? So in this case, you're looking at the screen while operating, not at the patient. It is something that you get over in a couple of cases, but you have to keep the navigation part, the navigation screen in the front, and look at it and operate. So this is how we do it. So this is where I'm trying to mark the optimum entry point of the screw in an MIS case. I've already finished this work. So this is me marking the skin. And this is what is happening on the screen real time. So the blue mark is the pack needle that's in my hand, and the yellow is the projected trajectory it's going to take. So once I have marked my entry points, I know where to take my incisions. This has enabled us to take more lateral entries. It has enabled us to put in a more medially traversing screw and longer and fatter screw. So that's the cut. As I'm putting my needle in here and the picture, you can see this traveling real time into the patient. And as I'm going through the deep fascia, now I'm going to push through the deep fascia. That's where it's going in. You can see it in 3D. That's where it has landed. Once it has landed, I've just checked the projection of the length of the screw I'm going to put in. And then I started hammering in. As I'm hammering this in, I can see it real time where it's going. I can correct the way where this needle is going. So there are no errors in putting that inside. It is as simple as that. This is other projections that you see. That's sorry, that's an in-house hospital announcement going on in the background. So you can see your instruments being going in. This is at tab going in. That's a real-time screw that's going in. So it's very comfortable knowing where you're going without having to open up a patient. This is what keeps it simple, and this is what keeps it safe. Does it extend only to MIS surgery? Here, there are two other options. One, what you're seeing here is a lateral mass screw insertion. This is, I'm drilling through a lateral mass. I'm seeing in all three planes that I'm getting in at the correct place. So you know the exact length. You don't have to worry whether your screw is too proud or if it is too small, because a small screw in lateral mass is useless and a long screw can go and hit a lot of other structures. This is a classic Lenke maneuver. This is an ankylosing spondylosis patient, as you can see. I'm going to start this video from the start. This is a thoracic 2 pedicle that I'm trying to reach. You can see there is hardly any pedicle. It's completely corticalized. So my Lenke is now facing outside. I have just crossed the pedicle border. And now I have reversed the Lenke and I'm going in again. So while I'm going in again, I know exactly where I'm going in, because here, using just your local anatomy, you're not going to be able to feel the pedicle give. So this is a place where you have to actually hammer it in, and knowing that where you're going is seen in front of you, it's a safe way to do it. So this is how cool it goes. So that's a Lenke facing outside. I'm going through a pedicle that is completely corticalized, going through it. And then here I have reversed the Lenke and going in. This is what an O-arm does to your surgery. It makes it that safe. This is another case where it is very important. You can see here, This is an high-grade listhesis, grade 3. I'm trying to get a bicortical S1 screw. It is impossible if you have done it. When you do this, you have to actually ram it through. Now, osteoporotic bone in the start, the very sclerotic end there. So this is my Lenke probe, which I am taking exactly to get a tricortical purchase there. Once this is gone, I know exactly what is the length of the screw that's going to be bicortical. That is where this makes a difference. It's in the difficult cases where this is going to make a difference. Another thing, it's not just for instrumentation. For example, this guy, this is an osteoid osteoma. We couldn't fulgurate it with a radio frequency device because, as you can see, it's quite close to the cord. It's in the dorsolumbar junction. And to reach here, ideally, we would take the facet out and then fuse it with screws up and down. We didn't do that. What was done here, I'll just show you. This is an O-arm image. That's my probe. I have drilled around the osteoid osteoma through the bone here. And once I have drilled around the bone there, it is just easy pickings for you to take it out. And that's the post procedure image where I have drilled that hole, and that's the osteoma taken out in total. That's not the only one case wonder. This is another case about an 18, 19-year-old teenager. That's what we did for him. That was an O-arm projection where the osteoid osteoma is. That's where my first navigated dilator. We put in a 16 mm tube, and through that 16 mm tube, you can see the focus and the post-op imager. That's what we took out. So this is the dramatic difference. That's a small tube scar you can see here between the patient's posture before and after the surgery. This is a giant cell tumor, 38-year-old paralyzed lady, quite big, had to do decompression with stabilization. That's what we did. That's what we went from behind, put in those screws, then took out the tumor, took out this whole two-rib construct here to take out the tumor as much. And then we went in from the front. You can see the aorta, the lungs, and the heart there. And what is important here is while removing the tumor, this is the projection of what I'm doing from the microscope on the navigation. And that's my probe. You can see this probe. This probe is seen as this blue line. So this is telling me how much have I removed for the tumor. So I'm just moving it through to see that I have removed and excised the tumor as much as possible. So that's another extension of this capabilities. This is where we do it in degenerative care. This is a fracture, sorry. This is a fracture spine. That's an elderly lady with kyphosis there, a lot of pain. That's what we did on the other side, right-hand side. You can see this is conventional C-arm images that you see. But what OHAM enabled us to do is that green line is what I'm tracking. If you can see here, we have put this cage in the front from the side without having taken out the outside of the pedicle and put in this cage inside without opening up the canal. This dramatically reduces the chances of a neurodeficit and also makes it safe because I'm not in the thoracic cavity, nor have I compromised the canal. So this is another way of improving safety. Of course, the visualization of your surgery on table is also excellent. You can actually see the amount of bone graft. You can see that the screws are adequate. It's much better in 3D compared to 2D. You can do far more complex cases like this, where this gentleman with a failed back syndrome with the kyphosis we could restore and put in screws. This is a mid-70s patient, or this gentleman who had a previously failed surgery for lumbar canal stenosis, where we had to redo. I have retained the name and age with the permission of the patient. You can see the date of birth is 1939. This is an 80-year-old guy we operated, and that's his clinical photo post-surgery. This is now more than 2.5, 3 years post-surgery. So this, my friends, are advantages of using an OARM and navigation, not just in conventional, but in minimal access surgery. Also, I thank you for a patient hearing. And if there are any questions, I'll be very happy to answer them. So I think we are in time.
Yes, we are in time.
Yes. Thank you, Dr. Vishal. It was a wonderful talk from you. My question to you is, how about pre-operative planning in with navigation? Do you use any of your difficult cases? You do a CT scan pre-op and plan accordingly?
So, see, most of the times when you do a thorough preoperative planning is high-grade listhesis or a bad scoliosis or a kyphoscoliosis. Of course, the planning is done, but we have stopped doing pre-op CT scans anymore.
Okay.
Unless it's a congenital complex scoliosis high-grade, where we want to have a better idea by printing a 3D model or something. But slowly and surely, as we use it more and more, I have personally crossed more than 350, 400 cases now. We are now stopped doing our pre-op CT, this thing, but this is a CT scanner. It tells you where you are in real time. So except for planning the level of instrumentations, there's no other planning that I think we are anymore doing there.
Right. You have shown cages as well as olives with the help of navigation. Is it what other implants or cages it is?
So you can navigate all Medtronic cages. The only problem is with their newly introduced 18-degree cage, where the navigation projection isn't there. But they have come up with a very beautiful titanium nano-coated cage, which we just used some time back. And that actually, the trial and the cage can be navigated. You can navigate the screws. You can see for vertebroplasties and kyphoplasties, you can navigate the initial part of your needle inside. So you don't have those 30, 40 X-rays, C-arm shots you take to put in your vertebroplasty or kyphoplasty needle. So what happens, a lot of patients say, oh, it's too much of radiation to do a CT scan of the patient. You have to understand the patient is probably going to get operated once in a lifetime, but you and your OT staff are going to do this for at least 3 to 4 decades. So the radiation exposure to the surgical team is zero. So that's the biggest advantage. If you see both my hands, I have no hair on this palm because I used to hold my needle while passing percutaneous things. So this is one thing that is this thing. I'm outside when this O-arm goes on and gives me the image, and when I'm doing it, it's all on the navigated images. So eventually, you have to think about you and your team's safety, because anything going wrong with them will discourage people from doing good surgeries. And a lot of people say, "Arey, CT scan ka radiation hai." So I mean, even in a conventional C-arm, the amount of radiation taken for percutaneous screws is phenomenal. So it's a better way of lessening it. And I mean, open surgery, I would not like to go down that discussion, because only fools defend open surgery better than minimal access surgery. Yeah.
Thank you, Vishal. I was just checking my hairs, and I'm losing my hair. I think I should be moving to arm and navigation.
Absolutely. It's one thing I would recommend is it's okay not to drive a Mercedes. But in your OT, you should be where you spend majority of your day, you should have the top end equipment at your disposal.
Yeah. So thank you again. I will invite my next speaker, Dr. Devanand Degulmadi. He is a spine surgeon from Stabby Hospital. And he's been speaking on the cage you mentioned about the nanotechnology cage for spine fusion. Over to Dr. Devanand.
Yeah, good afternoon, everyone. You're able to see my screen?
Yes, Devanand, we are able to see.
You're able to see my screen, sir?
Yes, Devanand, we are able to see the screen. Please go ahead and start your talk.
Yes, sir. Thank you. So, sorry for that. I am Dr. Devanand, consultant spine surgeon at Stabby Spine
Devanand,
Hospital.
we are not able to see your screen. You are just able to see your video camera. You have to share your screen.
I have shared my screen.
Technical team, you can help Dr. Devanand.
While Dr. Devanand is getting his screen sharing done, there is a question from Kshitij. Where do you put the tracker on the cervical spine? See, if you are doing a lateral mass screw, usually it's from C3 to C7. In such cases, I put it at the C2. If I am doing a C1, C2 fusion, I will still put it on the C2 spinous process, because that is where it usually gets the most dangerous. A C1 screw is usually safer to pass than C2 in my hand. So I put it on C2. So even if there is a movement because of instability, the C2 vertebra remains accurate in its projection. When you are doing an occipitocervical, then, again, it remains at C2. You have to remember the more difficult tracking is going to be when you're doing a thoracic and a lumbar surgery, when you're doing a long scoliosis, because the thoracic vertebrae will come up and down with the ventilation of the lungs. So that's when a minor error margin creeps in. So in such cases, the further you go away from the tracker, the chances of error become higher. So there you should put one tracker in the lumbar spine and one tracker in the thoracic spine. Take 2 scans, and then you have more accurate imaging. I hope that answers your question, Kshitij.
Yeah, we are able to see screen of Dr. Devanand.
Yes, Dr. Devanand, we can see it now.
Okay, sir.
Yeah, thank you.
So I'm going to talk about this adaptive interbody system, which the Medtronic have recently launched in August. This is a titanium nanolac surface technology. So as we all know, the interbody fusion techniques have been evolved from bone graft alone to titanium cages, and then to the PEEK cages, and now probably we are back to the titanium cages again. There are various fusion techniques. As we can see, the fusion techniques of the interbodies, it can be done with the bone graft alone or with the OLIF, the bigger cages with anterior approach, retroperitoneal nowadays, open TLIF system with the kidney cages, or with the bullet type of cages in this MIS system. There are a variety of cages available with the shapes, sizes, and the angles, and even the overcoated cages are also available. And all these cages have been tested time since. I have recently come across this 2021 European Spine Journal review, which shows that the titanium cages may be superior to the PEEK cages in lumbar interbody fusion. This was a systematic review concerned when comparing titanium versus PEEK cages. So after this nanolock system has come in, we have gone through the literature, and we have dug out the literature, and the Spine 2012 journal, it compares the osteoblast-like cell response, which they have compared with smooth titanium, rough titanium, and the PEEK cages. And they have come out with this conclusion that the osteoblast, they exhibit more differentiated phenotype and also increased BMP production on the titanium alloy substrates than the PEEK cages. The osteogenic environment and the osteoblastic maturation is more in the rough type of titanium or when compared to the smooth type of titanium. The other journal in 2013, Spine, which shows that the osteogenic angiogenic responses were high in the titanium alloy when compared to the PEEK. And they have seen this increased bone formation, enhanced integration, and improving the implant stability. All these factors are because of the surface regulated expression of the integrins, which are important in the collagen recognition, thereby increasing the angiogenesis support and reducing the osteoclastic activity. The next journal was in 2015 in the Society of Biomaterials, and they have studied the hierarchical structure of the titanium implant surfaces. They have done this using the scanning electron microscopy, in which they came to the conclusion that appropriate microsurface and nanosurface, it yields a highly desirable surface for rapid integration of the bone and implant interface. So this was one more journal. So all these journals, they say that the PEEK cages have an advantage because it has the modulus similar to the bone and also fluorovisibility. But this journal in the Spine, it says that it has a disadvantages of fibrous encapsulation. So the PEEK cages, it promotes fibrosis, thereby causing micromotion, subsidence of the cage, and also non-union. All these things are overcome with the titanium cages, which promote the osteogenic factors. So the new implant system, the new cage system, which is promoted by the Medtronics, it has the following features. It has a smooth dolphin nose, which will cause the distraction of the interbody space while it is inserted. So it is quite easy to insert. And it also has a honeycomb structure, as you can see, the nano surface seen. And it also has a lot of area for the bone insertion, thereby increasing the surface contact area with the end plates. It minimizes the stress load on the end plates, decreases the subsidence chances, and the osteoclastic pits, I mean, the pits which you are seeing because of this nano surface technology, they resemble the osteoclastic pits. Thereby, they increase the angiogenesis as well as the bone formation. So this has been released by Medtronic in India in August, and we at Surgery Spine Center, Ahmedabad, we have operated nearly 5 to 6 cases. And this is a case one example of a 45-year-old female who has 4-5 retrolisthesis, and she was in a lot of back pain and bilateral leg pain. We have operated using my MISS TLIF. And this case, we have just called her up for the follow-up. This was just 2 days back, and we got the CT scan done in the OM, which we have. So this shows a very good bone. I cannot say that it is through and through, but the bone formation and the new bone seen on the CT scan post-op, it is quite good. Patient is doing quite well and is able to carry on her daily activities at the end of 8 weeks. This was a case 2 example, a similar case, L45, which is, we have used the nanolock system. Case 3, similar case of L45. In case 4 of L5S1 Crocs lesion, which has been treated with the nanolock system. All these cases, post-operatively, they are absolutely happy. And one more advantage of this nanolock system is it's clearly seen on the post-operative X-rays, and even the post-op follow-up X-rays, we are able to see the bone graft clearly. And all these cases, they require a follow-up of at least 6 months in order to say that the bone union is good, or we can compare it with the PEEK cages or the other titanium cages. Thank you.
Yeah, thank you, Dr. Devanand. It was a very informative talk from you. My question to you is how we compare tantalum cage with this nanotechnology? And
the nanolock system which they have come up with, they have that surface changes which they have made it, and the data says, or the journals, they say that the osteoclastic pits, they resemble the osteoclastic pits, and you cannot make it in the other, which is not seen in the other cages which are introduced till now. And this promotes and increases the osteoblastic activity as well as the fusion or the bony fusion, which is seen normally at the end of 3 months or 6 months at the other cages. They say that it is seen earlier in these cases, probably 3 to 4 weeks.
Okay, Dr. Devanand, there is a question. Is there any change in the bone grafting protocol since you have started using Adaptix?
So till now, of all the MISS cases, we have used this nano system, or 5 in the last 5 cases, and we have used the local bone graft. Probably one case we have mixed it with iliac crest. We have just aspirated the iliac crest and we have put in some iliac crest bone graft. Otherwise, we use the regular locally available bone graft in MISS.
Okay. So is there any advantage of this case? It has a particularly snub nose. Sorry, it has a very, how to say,
a type of nose, which is, yes.
So are you able to put a larger cage as compared to, say, a capital in the previous one?
Yes, sir, absolutely. Especially in alpha S1 MISS cases, when you see the anterior disc space is opened up and the posterior is usually collapsed. So in these cases, especially, we struggle to put in a bigger cages. Okay. If you put a smaller cage, it goes in anteriorly and it becomes a sort of loosened. So in these cases, we can just introduce it, and once we keep hammering it, it goes in very snug fit. And we have not yet used it under navigation, but we are yet to get the navigation supported cage insertion part. Probably in that we will be more accurate in putting this.
Okay.
Thank you so much.
One of my last question.
Yes, sir.
You mentioned about minimizing the stress on the end plates. How is it different from other cages?
If you see the surface of the cage, they have very nano pits. It's not roughened surface, not the smoothened surface. So the amount of pits they are there on the superior and inferior surfaces, they cause minimal damage. It's like, it's not smooth, not neither it is very rough. It causes minimal damage when it is entering and it goes flush to the end plate, and it doesn't cause much of abrasion of the end plate.
Okay.
So what he essentially means is there are other rough coated edged cages, but they have a larger grain size. So when you're ramming such cases inside, they are likely to damage the end plate more. Whereas here, the size of the grain, or rather the pit that is there, is so small, nano. That's the reason nano. It resembles the porotic structure, the structure of a cancellous bone. So while getting in, the chances of this ripping into the end plate is less.
Okay.
So I think we should call the next speaker. Thank you so much for that informative talk, Dr. Devanand. Dheeraj, the next one.
The next speaker, Dr. Amit Sharma, is a spine consultant in Saifi Hospital. He'll be talking on anterior cervical tips and tricks.
Thank you, Dheeraj. So, as we know, the ACDF is one of the favorite surgery of every spine surgeon, and the reason behind that is it's a truly minimally invasive surgery because of the minimal soft tissue dissection, and the patient's morbidity is quite less, and the results are very predictable compared to those complex lumbar spine surgeries. So in the past, when we used to see these kind of pathologies, the main option which used to come to our mind where we had to do multiple levels anterior cervical discectomy and fusion was doing a discectomy, putting out these either metal cages or PEEK cages and an anterior plate. So most of the time these grafts were also kind of used to be removed from the iliac crest. First, two major changes which have happened, at least in my practice, that instead of using the plate and cage construct, I have gradually moved to standalone cages, even for the multi-level pathologies. And rather than using the iliac crest graft, most of the time I am using the locally available bone only. So these are the examples of these like 1 2 level and 1 3 level pathologies being treated by standalone cages. So it's a really minimally invasive surgery because we require minimal dissection in proximal distal dimension as well as mediolaterally because we are not inserting any plate. There is no implant irritation to the throat in the post-operative period, and all these things ultimately leads to faster recovery and early discharge of the patient from the hospital. So if you look at so I'll just quickly go through the procedure part quickly. So this is the typical position which we use. Being a orthopedic spine surgeon, we tend to go from the left side of the neck using an anterolateral approach. So the tube will always, the endotracheal tube will always come out from the right corner of the mouth, so it does not interfere in your functioning during the surgery. If required, you can insert an RT or Ryle's tube for better palpation of the esophagus. Nowadays, we have moved away from it because many times we tried to feel it, and most of the time what we were feeling was a thyroid cartilage. So nowadays we don't necessarily put it, but if one wishes, they can put an RT also. You can see that both the shoulders are kind of pulled down because what happens that especially in these kind of stout patients, and if you are operating on a lower level, especially C6, 7, then you may not be able to see that level very well on a lateral C-arm shoot. So you have to pull these shoulders down. When seen from the lateral side, you can see that there is a roll of sheet placed under the neck. So this is to give neck a little bit extension, so this space will open up a little bit more anteriorly, and while operating and while fixing the spine, the cervical spine will be in a little bit of lordosis. So you fix it in a more physiological position. I don't use the tongs anymore, either garden well or any other kind of traction. Even for multi-level pathology, if required, I'll use intersegmental distraction using those Casper retractors. We use one of these naturally available creases of the neck, so post-operative scar will look better. Draping is kind of limited. The exposure part of the draping is limited to the area of interest, and just the incision part need to be exposed. We don't have to necessarily have the full neck exposed. So the rule of thumb is that at the level of the thyroid cartilage, if it is around C4, 5 or C5, 6 and cricoid cartilage around C6, 7 or C5-6. If you are operating at a higher level, then your incision obviously will be at slightly higher level. After the exposure, the first step that we put a straight needle in the disc space and we keep it in position and take our first lateral shoot to confirm the level of the pathology. In this case, we were targeting C6-7 and the needle is at C6-7. It's very important to see from the occiput down to the index area, because if you are not counting from the top, then you might miss a level and then you might be operating at a wrong level. Regarding the retractors, so there are multiple kind of retractors available in the market. For multi-level pathology where our incision is bigger, we would use commercially available routine retractors. But what we have done that we have devised these new retractors which are like this. So this is like typical Makala retractor, but instead of these wider blades which you see on the sides, we have made these thinner plates, because what happens that sometimes especially for single level pathology, incision is so small that these bigger plates will not go in for retraction. So we have created these thinner as well as narrower plates for proper retraction. And if required, you can this window which is open by retracting both the blades, you can put a small narrow right angle retractor to position the window in the midline. This is a Casper retractor in place, and that's how it looks. So both the pins will go inside the vertebral body adjacent to the disc under concern, and then you can open it. So here we can see that on the left hand side of the screen, the pins are in the body and it is in the non-distracted position, but on the right side you can see after distraction how much the disc space can open up. So it will make your surgery go a little smoother and discectomy will be easier. Regarding the bone graft, so you can see that how much bone graft are we able to retrieve just by removing the anterior superior osteophyte, anterior inferior osteophyte to the superior vertebra and the posterior superior osteophyte to the lower vertebra. So most of the time we are able to retrieve enough graft, and it's been a while since I have taken out the iliac crest graft for a simple degenerative disc pathology. So you can see on the right side that even after filling up the cage, we still have a lot of bone graft remaining. So there is no dearth of bone graft from the operative area itself. Two instruments very important are these angled drill and angled screwdriver, because with that small opening you are not able to insert the screws in oblique trajectory unless you have these kind of instrument. Otherwise it's a big struggle and you will have a tendency to kind of go parallel to the end plate when you are inserting the screw rather than going oblique to the end plate. So this is how these drills will be drilling, and the screws ultimately need to be at this angle if you want to be in the correct trajectory. And that's one example of how the screw goes in with the right kind of screwdriver. Now after you have done the discectomy and spinal cord decompression, your sizer goes in, and after the sizer, as you can see on the right side, your cage is already in. With the angle drill, you go through the cage and make your screw trajectory. And once on the right upper side, you can see how the screw is going in the drill path. The other option is that you can, because the screw provided are mostly self tapping and self drilling, so you can directly put the screw, as we can see in the lower image, without even drilling the screw trajectory. And this is how the final picture looks like. Do you have 2 minutes time, Dheeraj, so you can go through the video?
Yeah, sure.
Okay. So the incision is mostly horizontal in the neck ridge. Even for the 3-level pathology, we are able to kind of deal with using this horizontal incision only. So once you cut the platysma, you come across the investing layer of the fascia, and by staying on front side of the sternocleidomastoid and like lateral to the trachea, then you do blunt dissection with the help of your fingers and with the help of a peanut swab at the very tip of the Alice. Once you feel the spine, you dissect the prevertebral fascia. After confirming your, so this needle is going inside the disc space. Once you confirm your level, then you mark this without moving too much. You mark this. It's very important to mark the disc. Otherwise, if your window of exposure will move, then you might lose your disc which you had put the needle in. With the help of the cautery, you will expose the surrounding anterior surface of the bone. With the help of a routine curette, we will remove the disc, and before doing that, we take out that anterior-inferior osteophyte of the upper vertebra, so that we'll be using as a bone graft. So that's what is we are doing right now. The other advantage of doing this step is that you get a straight access to the disc rather than that fish mouth closing, which might impede your full dissection of the disc and thorough decompression. And now we are removing this posterior superior margin of the lower vertebra. Again, this is to retrieve the bone graft as well as for the proper decompression of the spinal cord. Once this is done, then depending upon your pathology, you need to see whether there is any extruded fragment. So in this case, there was a big extruded fragment on the left side, which we squeezed out using a nerve hook. And once this is done, then with the nerve hook only, I tend to go posterior to the PLL and then take a nick in it, and then through that nick we will so this another big piece of the disc coming out. For these fragments are tiny, but they are quite big for cervical spine to create enough symptom. So through that nick in the PLL, we insert our 2 mm kerrison and then remove all the PLL fragment, and we can see that the dura is now visible through the PLL excision which we have done. Depending upon your pathology, you will have to check the right as well left foramen. One word of caution that if you go too lateral, then you might encounter bleeding. No, so this is the sizure going in, and then once the sizure is in, you know what size, then you put this bone-filled cage inside and then insert your screws. That's it. Thank you very much.
Yeah. Thank you, Dr. Amit. It was nice to listen from you. My question was, though the screws are self-drilling, which cases you prefer to use the drills?
So that was just actually this picture which I showed you with the drill. This case was done today itself.
Okay.
So I just inserted that image just to show that we have that option also available. Otherwise, okay. I don't use the drill.
Nice, nice. I prefer the same. Yeah. Any other questions?
So, Dheeraj, we don't have any other questions, and for lack of time, we're just on time right now. Can we go on with the next talk?
Yeah. We'll call Dr. Ayush Sharma from Central Railway Hospital. So he's a master in OLIF surgery.
Thank you, Dheeraj, for such a nice introduction. And continuing with the session, let me start with the talk on OLIF, which is the oblique lumbar interbody fusion. So I'll start with a small video technique just to show how we do it, and then maybe go to a few cases. So this was a single position OLIF. Single position means we did everything in one position. So she was a 49-year-old female presented with back pain, and you can see L34, there is significant amount of lumbar stenosis happening as well. And you can see the CT scan showing part slices and significant disc degeneration. There was a scoliosis and a mismatch in the lumbar alignment as well. So we took the left lateral decubitus. This is how the skin incision looks like. You go roughly 3 finger breadth anterior, but that can depend upon the patient which you have. In a thinner patient, you might be slightly near, and in a fatty patient, you might have to go much further. So we have marked the cranial and the caudal end, and this is the incision. If you see this incision, just 1 to 1.5 or maximum sometime up to 2 centimeter, and that is the only incision you will take. You can see from the finger I'm using, that is a pretty small incision. And only thing you will see I'll cut here is the skin, and rest everything will either split or will go through. So there is a fascia over external oblique. Of course, we cut the fascia as well, and that is how it is. So this is the fascia over external oblique, And as we go to the abdominal muscle, we'll just see the muscle and we'll keep splitting the muscles. And there's nothing, absolutely nothing, which we'll cut. And that is what makes it a minimally invasive approach. So you see, as we are going in, we're going through the layers, which are the external oblique, the internal oblique, and then after this, we will go through the fascia transversalis. And you see, you can appreciate the change in the direction of the muscle as we go in. So even if you, for some reason, you don't want to remember them, you just keep looking the way they split, keep looking at the way the fibers change, and you go splitting it. And that's what we have been doing. The last layer, which is the fascia, this is the transversus abdominis. So again, this is the next layer. Again, you can appreciate the change in the direction, and that is what all you need to do. Just look at the change in the direction. And the last layer is a very thin, flimsy layer, which is the fascia transversalis, and you can use your finger to just break it. So I'm using, because it's a very, very thin layer, so I'm using the finger to break the layer, and this is exactly what we do. So once we go in, we palpate the psoas. So psoas, is a very big muscle, so you cannot miss it. So basically, use your finger to palpate the psoas. And as I'm just dissecting it using a finger, this is what I'm doing. I'm palpating the psoas, and over this, I'll put the handheld retractor. So I use these special retractors, which are conical in shape, and they exactly go over my finger. So what it does, it allows that muscle doesn't creep in. This is what I use. So once I have palpated the psoas, I know my psoas is at the tip of my finger, and then I have slided that retractor just on my finger. So at this, again, I'm making sure that I am right where I want to be, which are the psoas. And then once I have taken out the muscle, I'm exactly directly looking at the psoas muscle. And this is what you see. The other retractor goes in, and you can see the psoas in front of you. So what we do, we do the whole surgery under 360-degree vision. We don't go by the C-arm approach, which is classically taught, and that has really, we feel that has made our surgery safe. So now I'm sure that there is psoas and nothing else, because sometimes there could be so many things. As I'll show you just out here. So here you see it, just to the anterior border of the psoas, you can see a white structure, which was a genitofemoral nerve. If you don't do it under direct vision, you can really, really damage some very, very important structure. And that's why it is very, very important to do it under direct vision. You can see under hugging to the anterior margin of the psoas, there's a cord-like white structure, which is a genitofemoral nerve. So that's why we now prefer it to even dock our tubes directly under vision. We don't do it blindly as recommended traditionally. So this has really helped us avoid the complications. Sometimes you can get a aberrant vein, aberrant artery, everything. So what we do, once we know there is something, we use this hand retractor. We just push the psoas and then put our handheld retractor back in. So we know that there's nothing but only the disc space which is there. I'm just again reconfirming everything. And once we have reconfirmed that there is no other vital structure around there, that is the time we'll we just reconfirming the same thing. And now once we are sure that 360-degree nothing is happening, there's nothing at all, that is the time the first docking of the tubular system happens. So docking is not blind, it is completely under vision 360-degree. And that makes it very, very safe. And once the dilated system goes in, and this is how the dilator goes in, and it will sort of dilate and give you a space to work. And then this is the final dilator which goes in. And this is the time when my handle retractor comes out. And then we confirm the level. This was it. Before you can see the listhesis, which is still there. And then you start doing your disc work. So there was an osteophyte. Again, so many people ask, how can you remove the osteo? You can see everything. Once you can see, it is same like doing a ACDF surgery. Now everything is under your vision. You know there is nothing else, and you do whatever you want to do. The most important thing is to have a very good, secure corridor, and that is the thing. Then we use the shavers. and you can see the shavers going in. So this is what you have to do, which is a orthogonal maneuver to make sure that you are orthogonal to the disc space. If you see, I'm always I'm like the way I am going. It is not. I'm not going perpendicular to the tube. I'm going slightly anterior, and just this is what we call as orthogonal maneuver, because you're going through the oblique corridor, but basically you want to put your cage perpendicular to the end plate. So this is what we call as orthogonal maneuver. And as we go in, we slightly, gradually distract the disc space. And this is the final cage you can see, which is going in through the window. And this is just to show that the final placement of the cage. And this is how it looks like. You see already the listhesis has completely reduced. We didn't even have to do anything. And this is the cage going in. And then this is the cage, and once you remove your retractor system, everything will fall back, because basically you have not touched anything. You have just been splitting the muscle. The muscle layer simply falls back, and that is your OLIF surgery from anterior. And then in this particular case, of course, we augmented with the posterior screws, and you can see there's already the reduction. Even before you have put the screws, it is completely reduced. In this case, we did single position. That means in lateral only we could put the screw. So that was the advantage. Now almost all one level, even sometime two level, we can do it in a single position lateral, so that in the lateral position we will put the screws from behind. So that is what it is showing. The whole thing is done in a single position. It literally reduces your time of the surgery. And this is the post-operative MRI showing the good axial decompression. And you can see there is a good decompression in the coronal plane as well. And this is your post-operative X-ray. So, and this is the post-op again showing good realignment. So this is basically, they say it is an indirect decompression, but I think this is a direct decompression, because the pathology was there was a listhesis and there was a buckling of the disc, which was causing the compression on your spine. So once you have put the cage, you have solved the primary problem, and this is what happens when you do that. You can see we have completely achieved our balance. And this is 6 months follow-up. This is CT scan showing good solid bony trabecular fusion in 6 months, because the size of the cage really allows for a very, very good bony surface or bony contact for fusion. So this is what the OLIF is, and this is and this is how it looks like, the final X-ray picture. And this is the skin incision, as we told you, it's between 1 to 1.5. Do I have time to show a few cases, Dheeraj?
Yes, you can take.
Okay. So just to show you, so why OLIF? And this is the cases where we feel it does make a difference. A case like this, if you see there is a focal scoliosis, focal kyphosis, there's a post-laminectomy defect, and there are many ways to skin a cat, and you can do something. But I think the best and the least invasive way is a OLIF surgery, because it really allows you to get more out of single level, and that is how I see it. So this is what you can do. You can correct the scoliosis, you can restore the lumbar lordosis, and you can get the indirect decompression. And this is what all that you give the patient. And this, now we have a 3-year follow-up, and with a solid bone infusion, and patient has really done very, very well. Again, another case where I think OLIF was the best solution, because there is adjacent segment disease in a previously instrumented case. Now, if you do anything else, you need to exit the implant and then do something. But one patient was really, really painful. She was really literally wincing with pain with every step. And so, but what we did was we did a standalone OLIF. So we put the cage, and then we put the plate along with the cage. And there is, you can see, this is the only blood loss which happened with the revision surgery. And again, you can see the plate which is there on top of the cage, and this is all we did. That's it. And this is how it looks like. Again, we have our almost 3 years follow with her, and she has really done well. So this is a previous scar from the primary surgery, and this is the only thing which you have done in a revision case scenario in an adjacent segment level. So that's how the OLIF is in selected cases, it could be really, and this is how she's walking post of day 2, because they are really comfortable. And as we have gone in, we have tried to extend the boundary. We have started doing degen scoliosis. This is a 2-level degen scoliosis. You can see the correction just by the cage, even before you put the screws. And this is the final correction. And again, as you do more, you try to put more and you include more. And this is a post-laminectomy kyphosis in a 78-year female. Normally, no one will touch it, but we did a 3-level OLIF, and this is how she looks like. And you can see the alignment, and this is the alignment with the OLIF. The moment you correct the lumbar, the thoracic simply goes back. And now yesterday she came with a 1-year follow-up, and she's 78-year, and she has really done well. And look at this. This is a 1-year follow-up. Exactly yesterday, 19th/11, she came, and already there is a good fusion, solid bony fusion. I couldn't get the CT scan. Maybe it will come by next week. But looking at the X-ray, I think she has almost fused. So these are the cases we think OLIF is a good option, and it does give you interesting option compared to a resistance surgery. Thank you so much.
Hey, thanks, Ayush. That was an excellent presentation. There are a couple of questions for you, and we have the last 3 minutes here to go. So, but the question, one question is from Dr. Devanand. What is your bone graft substitute that you use? Second question is again by Dr. Devanand. He's asking you what is the plate that you have used in this OLIF, and the third question. We'll come to that. Can you get through these two first?
Yeah. So what I'm using is I'm using calcium silicate. That is what I have been using. You have many options. BMP is the ideal and the best option, but BMP is a really expensive option. Maybe Vishal Peshettiwar can use it, but the railway hospital won't afford it. So calcium silicate is it has some unique properties, and it is like a paste. So it really goes in, fits in very well in your OLIF cage. So that is what we have been using, and we have got very good result. Even at 6 months, we are seeing some good bony fusion. And it comes at around roughly 11,000 rupees, and you can use it for up to 2 levels for 11,000, which is pretty decent for Indian market. And so much so that I was in Global Spine, and Depu is coming big way with calcium silicate. They have just internationally launched calcium silicate at a very higher price. But what we have been using is from Nov Hall. I think it's an Indian company which which gives it, and that was something we thought is for Indian scenario is a decent option. So this was one. What was the next plate?
What plate have you used when you did the adjacent level?
So it is a Pyvox plate which comes with the cage. They have Medtronic's Pyvox cages. They come with the plate. They are inbuilt plate. You just need to put it. It comes with the system itself.
Before we wind up, Ayush, the last question I want to ask is, when you are using that plate, how good is the grip, considering that a pedicle screw gets 60% of its purchase in the pedicle? Now we are using it in cancellous bone, majority of it adjacent levels, osteoporotic and in elderly patient. So what is the size of the screw you use? How long do you put the screws, and how secure is the purchase?
So you have to be, this is not something I recommend for all my cases. Be I will be very categorically about it. Of the 4 or 5 cases I showed you only one case where I put this. So you should be very selective, because for the various reasons you said earlier, they are not as good as a pedicle screw. They don't have good strength. But in adjacent segment disease, where it is not a traumatic, there's no list stresses, the stress is very low on the segment, I think you can get away with this. And that is what we have used in very selected cases. And you can direct the screws, and they come in various lengths. But whatever length or whatever you use,
you try to get a bicortical purchase.
No, I don't. I don't try to. Okay. I get whatever I could.
So much. I think Dheeraj should wind up. We have just been in time.
Yeah, thank you everyone. On time. My last question to you. Thanks for showing me genitofemoral nerve. I have seen first time. And just in brief, can you tell me how we can have an advantage over a MIS TLIF?
So for example, when you have already a posterior laminectomy and everything, even a MIS TLIF could be an issue. because again you need to go through the scar. And MIS still, if because the footprint of the cage, it doesn't give you that much of lordosis which can you go we can go by go anterior. And that is where I see when you need to do more, it is like a sledgehammer which I showed you. When I need to get more out of a single level, that is the time I use it. Otherwise, MIS still remains my workhorse. Thank
Okay.
you.
Thank you, everyone. Thank you very much.
Yeah, over to Dr. Kshitish.
Thank you very much, Dheeraj, for moderating this session. And I would like to thank our sponsors, Medtronic, who sponsored this workshop, and they are also part sponsors of this entire conference. Do visit their stall in your conference app. And with that, we'll end this workshop, and I'd like to invite the organizing secretary and the secretary of the Bombay Spine Society, Dr. Satyan Mehta, to welcome all of you and introduce this conference. Over to you, Satyan. Are you there?
Hi, I'm here. I'm actually looking at both the screens. So I invite everyone to come into Hall A for now, where we'll be doing our inauguration session. We will be running the same thing in Hall A and Hall B simultaneously. And after this, we will be again breaking out back into the two halls for the abstracts. So I'm concluding the session in Hall B. We've had a very good meeting there. Thank you, Dr. Devesh, over there, and thank you, Vishal, here. Thank you to all our delegates, all our participants. We've had a very good meeting right from 13th, 14th, where we had very good operative sessions, operative techniques. We've had very good participations and a lot of delegates who came in, and a lot of questions were asked. A very good surgical techniques which were discussed, and there was a lot of a discussion right from the basic level to the very advanced and very senior surgeons also, who had a lot of questions and were had learnt from these techniques. We continued that into our main conference here, which is being held virtually. Now we have two halls, Hall A and Hall B. We've had our first company sponsored session in Hall A, where Medtronic had sponsored this session, which was a very good one. And I thank Medtronic on behalf of Bombay Spine Society for this. In Hall B, we had a very good session sponsored by Solco. Again, I thank Solco for this. And I thank all our sponsors and these times of pandemic, where we are coming out of the pandemic, that we are able to have this conference. Let's hope that we can do it as a very good, big level physical conference next year. In this meeting, we have different ICLs. We have a different instructive series. You can go through the series and see where you want to attend, what you want to do. We have some very good abstracts in both Hall A and Hall B, where young upcoming spine surgeons are going to present their work. So you are welcome to see their work. Tomorrow we have a very good gold medal section, where the best of these scientific papers are being presented, and you must have a look at them. As I said earlier, the presidential session is something to die for. Each talk in the presidential section is actually worth 1,000 rupees, which has been the entire amount paid for this whole conference. So you must attend that, and it is going to be hosted by our president, Dr. Srivastav, which is going to be a very good session, and I'm really looking forward to such exciting topics which are being presented. We have got posters as well, and I encourage all our delegates, all our faculty, to go through the posters. You can visit it in the main lobby. You can go into the poster section and see them. People have worked very hard to do these studies, and they are presenting them. You must have a look at them. And you must go into the exhibits and see all our sponsors where they are demonstrating their products to encourage them. And without the help of the sponsors, we will not be able to have any of our conferences. So please, I request you all to have a look at the products, and it may help to improve and improvise your practice. So this is how we are going about it. Without further ado, I would like to invite our esteemed president, Dr. Srivastav. Srivastav sir is a senior person, is a mentor for all of us, and he has been encouraging us to keep breaking boundaries and keep going ahead. If there is any issue, he just encourages. He doesn't ask us to go around it. He encourages us to break through the barrier and get more things done, get it better, get the conference better and better. So without further ado, sir, I would like to invite you to please say a few words and inaugurate the conference.
Thank you very much, Dr. Satyan. A very good afternoon to all of you. Dear friends, I, Dr. S.K. Srivastava, President of Bombay Spine Society, on behalf of Bombay Spine Society, its respected patrons and organizing team of Bsscon 2021, welcome all the national, international faculties and delegates to this very promising and academically rich annual conference of Bombay Spine Society, that is Bsscon 2021. As described by Dr. Satyan, we had a very fruitful pre-conference workshop BOSC on 13th and 14th of November. Next 2 days are going to be very informative with full of important and advanced developments in spinal surgery. Our very dynamic organizing secretaries, Dr. Satyan Mehta and Dr. Chitij Chaudhary, have left no stone unturned to provide a very rich academic program. A very active organizing team has structured the different sessions of program very meticulously. BSS is glad to have a plethora of stalwarts in this academic journey. On 21st of November, we will be having active participation of CSRS AP members. Do join us for this academic session. I am more than sure that all of us will be immensely benefited by being a part of this academic journey. Do attend this conference in toto. I declare Bsscon 2021 open and invite all of you for national anthem. Thank you.
We are the spinal scientists and spinal surgeon specialists, folks with heart full of empathy, who practice patient care with integrity. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine Society. Talented, innovative researchers we are. Academic ambassadors of India we are. Talented, innovative researchers we are. Academic ambassadors of India we are. Technology model embracing we are. Technology model embracing we are. Lauded by academic community. Will be futuristic till eternity. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine Society. Visionary pioneers and world-class teachers, motivated members and vibrant leaders. visionary pioneers and world-class teachers. Motivated members have vibrant leaders. Pathfinder, we find no hurdles. Pathfinder, we find no hurdles. We love the mark, we have no enmity. We are a strong bond fraternity. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the spinal scientists and spinal surgeon specialists. Folks with heart full of empathy, who practice patient care with integrity. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine Society. We are the Bombay Spine Society.
Thanks a lot. Thank you, all of you. Now, again, I hand over the proceeding to Dr. Satyan.
Thank you, sir. Again, I welcome all of you again for the meeting, and we will start off with our abstracts, the papers. So we have some very good papers which are going to be shown here. We had received almost about 88 papers, if I am not mistaken, and we've had to get them evaluated by independent judges who did not know where it was coming from, who had marked them, and we chose the papers based on that. So these are the best of these best papers, and I encourage everyone to see these papers being presented, and you are free to ask your questions as well. For that, I would like to invite in Hall A our moderators of this session, which is Dr. Nishant Kumar, Dr. Tanay Prabhu, and Dr. Amit Jain. Dr. Nishant, please go ahead. The session is all yours.
Thank you, Dr. Satya. Right now we've got lots of interesting abstracts lined up for you guys, and I would like to now welcome Dr. Abhinandan Reddy to present his paper on verifying S1 pedicle screw placement using modified pelvic inlet view, a technical note. Can we have his presentation on?
Good morning, everyone. So as we all know, sacral pedicle screw fixation with good purchase still remains a challenge, and the bicortical purchase of the sacral anterior cortex adds additional biomechanical benefit to the lumbosacral construct. However, anterior sacral penetration of the screw and drilling of the anterior cortex carries additional risk for the neurovascular injury. Complex neurovascular structures and visceral structures lie anterior to the sacrum. As you can appreciate in the image, there are external and internal iliac vessels along with the L5 nerve roots anterior to the sacrum. And because of the unique anatomy of the sacrum, conventional anteroposterior and lateral radiographic views are relatively less reliable in determining the screw depth. So as Mirkovic et al. Have described, there are medial safe zone and a lateral safe zone, but we as spine surgeons generally use the medial safe zone with bicortical or tricortical purchase for the better sacral screw fixation. However, the literature about the pedicle screw misplacement rate is relatively high, and it ranges up to 30%, especially in the S1 pedicle screw. And confirmation of the accurate screw position within the S1 is essential to avoid these neurovascular complications. And literature shows that lateral fluoroscopic imaging routinely used in the operative setup using intraoperatively is inaccurate for determining the actual penetration of the anterior cortex. Our objective through this technique was to elaborate the morphological features of the S1 segment, to define the bi or tricortical screw placement in the S1, and to describe our intraoperative technique of a modified pelvic inlet view for the evaluation of the anterior sacral surface purchase and penetration of the S1 screw placement, and to describe our clinical experience for visualizing the anteroposterior extent of the S1 pedicle screw. It was a single center prospective study with the approval of the review board and the consent. And we analyzed the accuracy and safety of the pedicle screw implantation in the S1 using the modified technique in T-lift patients of L5 S1. For the screw position in relation to the vertebral body, existence of the anterior cortical perforation and risk to the of injury to the neurovascular structures was assessed. The study has developed a novel approach for assessing misplaced S1 pedicle screws, and the study shows that patients may not need revision procedures for the misplaced S1 pedicle screws. And this modified pelvic inlet view was to assess anterior-posterior extent of the S1 screw placement, specifically determining the screw position in relation to the anterior cortex or the promontory. This view is obtained by directing the image intensifier 20 to 25 degrees cephalocaudal, 0 degrees mediolaterally, with adjustments aligning to the patient's pelvic rim. This aligns the pubic symphysis with the second sacral vertebra, providing visualization of the superior boundary of the S1. We totally assessed the 50 patients for L5 S1 tail lift, and no breach was observed in at the S1 level using this technique described. And out of 100 S1 screws, we were forced to reinsert 9 screws for excessive anterior cortical breach, which were benign on the normal lateral fluoroscopic view. Through this technique, we were able to achieve bicortical purchase in all the 100 screws, and there were no cases of symptomatic radiculopathy or neurovascular injury at the S1 level, and there was no return to the operating room for any of the cases. This purpose of the study was to employ a simple and fast method to evaluate the intraoperative pedicle screw placement and provide a clue for the necessity of the postoperative revision surgery. Therefore, the decision-making procedure regarding revision surgery is not based on spine surgeon's subjective perception, but on a objective evidence. So the bicortical anchoring, though desirable, should be careful because there are a lot of anatomic structures lying anterior to the promontory, including great vessels. The position of the image intensifier for the modified pelvic inlet view allows a perpendicular view to the superior sacral end plate. Therefore, there is no specific degree at which the inlet view is taken. Rather, it is specific to each patient's sacral slope. And even with the techniques to assist the surgeon in a screw determination and intraoperative guidance, this simple technique is widely feasible and reproducible. Irrespective of whether the screw is placed by open or minimal invasive technique, the assessment of the screw tip position with respect to the anterior cortex is essential. So our technique incorporates each individual patient's anatomy. Superior sacral surface will allow visualization as tangential as possible to the proximal part of the anterior sacrum. In addition, assessment of the anterior medial angulation can also be performed using the same view. There are few limitations, as all the 100 screws were from 50 patients of consecutive L5 S1 tail lift, and we did not include any of the deformity patients. And though it is a 50 patients, it is a small study population. Hence, it could be done on a larger population to determine much more feasibility of this technique. So, in conclusion, our data shows that a bicortical and a tricortical positioning of the pedicle screws is achieved using this fluoroscopic technique in nearly all the S1 pedicle screws. And this technique may lead not only to less complications and revision surgeries, but also to a biomechanically superior fixation. And it is a simple, fast, and reliable method to evaluate the misplaced screws. It has an application in deciding whether to reposition or resize the screws intraoperatively. Thank you.
That's very interesting paper. Do we have any questions? We can take one question. Dheeraj?
I was not able to see your the exact trajectory on C-arm views. I was not able to understand it properly.
Sir, it was mostly
on the CT trajectory, but on C-arm, how does the trajectory has to be decided?
So it is only about the length of the screw and having a bicortical purchase, because we are always looking at a lateral view while putting S1 screw.
Okay.
So we might be not able to actually get hold of the length of the screw. We might be thinking we are approaching the promontory and taking a larger length of the S1 screw, but on an axial view, it might be much larger.
Okay. Okay.
So when we take an AP view with this new technique, we might as well get the mediolateral angulation also, and we might see how much anterior it is to the sacral promontory.
Okay. Okay. Thank you.
Okay. Thank you, Dr. Reddy. That's an interesting paper. So next, I think Dr. Akash Shakya has a presentation. He's presenting on functional outcomes following MIS spine surgery with patients with or without preoperative epidural steroid injection. Can we have his presentation?
My name is Akash Shakya, and I will be presenting the findings of our study, which investigated whether a preoperative lumbar epidural steroid injection affects the functional outcomes following minimally invasive spine surgery for a prolapsed intervertebral disc. To begin with, a bit of introduction and context to our study. Epidural steroids have become a mainstay of modern spine practice. However, the patients who obtain an insufficient or no pain relief following an epidural steroid injection do proceed to surgery. The functional outcomes following surgery for these patients have been widely studied. However, most of these patients were operated by an open approach. With minimally invasive spine surgery gaining popularity over the past decade or so, we tried to compare the functional outcomes post minimally invasive tubular discectomy in patients who have had a lumbar epidural steroid injection in the past 1 year to those who have had no such intervention. We conducted retrospective analysis of patients who were operated by minimally invasive tubular discectomy over 30 months at Dr. B.M. Central Railways Hospital, Mumbai. We used the Orthopaedic Disability Index, VAS scores for leg pain and back pain as a functional outcome criteria. We included all the patients who were operated by minimally invasive discectomy, aging between 18 to 65 years. We excluded patients having a history of previous spine surgery, a history of significant spine trauma, tumor, or having history of spondyloarthropathies. This flowchart depicts our study protocol. We screened for all the patients who were operated by minimally invasive tubular discectomy. As per the inclusion and exclusion criteria, we divided the patients into two groups, those having a history of epidural steroid in the past 12 months and those who did not have such a history. Those having a history of epidural steroid injection were further subdivided into three subgroups based on the duration of time interval between the surgery and the epidural steroid injection. These were less than 3 months, 3 to 6 months, and between 6 months to 1 year. This table depicts the results of the demographic variables. As can be seen, these were all comparable, as with the exception of duration of symptoms, which was significantly higher in the patients having an epidural steroid injection. Similarly, the perioperative variables was comparable across the two groups. However, further subgroup analysis revealed that the duration of surgery and blood loss was significantly higher in patients who have had an epidural steroid in the past 3 months. In patients who have had an epidural steroid injection between 6 months to 1 year also had a significantly high duration of surgery. With respect to the complication and outcomes, the return to work, resurgery rates, and complications were comparable across the two broad groups. The ODI scores were also comparable across the two main groups. However, on further subgroup analysis, the ODI scores at 1 month in patients having an epidural steroid injection less than 3 months of surgery had a significantly poor ODI score. Similarly, the VAS scores for both leg pain and back pain were comparable across the two broad groups. However, further subgroup analysis revealed that the post-operative 1 month score for VAS leg pain was significantly worse in patients who have had an epidural steroid in the past 3 months. To conclude, minimally invasive spine surgery within 3 months of an epidural steroid has an inferior functional outcome up to 1 month of surgery. However, similar difference was not seen at a subsequent point of assessment. Complication rates remain similar across the two groups, and patients do need counseling if surgery has to be undertaken by minimally invasive approach with a history of an epidural steroid in the past 3 months. Thank you.
Thank you, Dr. Akash. That was an interesting paper. I think we'll have 2-3 papers, abstracts, and then I think we'll open the house for discussion. That way we'll have more thoughts on it. So I'll invite the next speaker, Dr. Amaya Ranganekar, to present his study on spinal anesthesia versus general anesthesia for MIS TLIF. Can we have his presentation on board, please?
Hello everyone, I am presenting on efficiency of spinal anesthesia versus general anesthesia for minimal invasive single level TLIF, a retrospective analysis of 178 patients. The aims and objectives were to evaluate the efficacy of spinal anesthesia in patients undergoing MIS TLIF and to compare it with the results of that of general anesthesia. The parameters compared were VAS, blood loss, duration of surgery, time from entering OT to incision time from bandaging to exit time of stay in PSU, nausea, vomiting, urinary retention, duration of stay in hospital, and perioperative complications. Lumbar spine surgeries can be performed either in general or regional anesthesia, of which endotracheal general anesthesia is the most common technique. Advantages of GA being it gives a secured airway, whereas spine anesthesia offers rapid onset, less thrombotic events, less neurological complications, and it offers the patient can spontaneously breathe and can reposition themselves, avoiding compression injuries during the procedure. But despite encouraging results in favor of spine anesthesia, there is no clear evidence to delineate between the morbidity between the two groups. The methodology included, it was a comparative and retrospective study conducted at Bombay Hospital. Inclusion was patients aged between 20 to 70 years undergoing single level MIS TLIF at L3, 4, 4, 5 or L5 level, not responding to 6 weeks of conservative treatment, and having mechanical low back pain with radiculopathy, with claudication, with or without neurodeficit. Exclusion was patient who had undergone revision surgeries requiring multi-level surgeries, having tumor, infection of pathological causes, or requiring surgery at higher levels like L1, L2, or L2, L3. All surgeries were performed by a single surgeon in a single institute, managed by a single anesthesiologist with similar surgical anesthetic techniques. After counseling for surgery, the patients were offered both choices to choose between the spinal and general group. They were thoroughly considered and explained pros and cons associated with each technique. The choice lied with the patient and not the observer of the study. 178 patients were deemed fit for the criteria. Of these, 92 patients chose spinal anesthesia group, while 86 were under general anesthesia. The results for age and gender were comparable. There was significant difference in time of entering OT to incision time, time from bandaging to exit, and PSU time and hospital stay in the spinal anesthesia group. The VAS scores were compared in both the groups, and urinary retention was found to be higher in spinal anesthesia group. There is still controversy on the influence of these two techniques. Therefore, we considered the lacuna of literature. We undertook this study. The mean pre-op and post-op was comparable between two groups at immediate post-op, 3 months and 12 months. Mean blood loss as well as duration of surgery was comparable in the both general as well as spinal anesthesia group. There was shorter operation theatre to incision time and also time from bandaging to exit in our study in the spinal anesthesia group. This highlighted higher efficiency with quicker operation theatre time and turnover rate, and in turn cost effectiveness. The longer duration of general anesthesia was because of the pre-induction anesthesia medicines and post-op reversal time. The patients of the spinal anesthesia group required lesser PSU time and provided excellent post-operative pain relief, which gives the advantage of early shifting of patients from PSU to ward. Early ambulation, early start to oral fits, early bowel function return, and less neurocognitive changes ensured early discharge from hospital. However, we found significantly higher incidence of urine retention in spinal anesthesia group, which may be due to because of bupivacaine and prolonged analgesia effect. The flaws with the study were there was intraoperative hemodynamic changes were not recorded, satisfaction rate was not seen, and time constraints in the spinal anesthesia group. The conclusion being the spinal anesthesia is very effective alternative technique to general anesthesia, which can be considered for elective lumbar surgeries at lower lumbar levels. Thank you.
Thank you, Dr. Amaya. Can we have the next speaker's presentation, Dr. Anuj Yadav?
Good evening, everyone. I'm Dr. Anuj Yadav, Junior Resident, Jail in HRC Bhilai. I did a prospective study to evaluate the efficacy of caudal epidural injection in degenerative spine of elderly. Degenerative disorders in lumbosacral spine of elderly patient can lead to chronic low back pain and or radiating leg pain with or without neurological deficit. The lifetime prevalence of radiculopathy is around 4% in females and 5% in males. Epidural injection are the most commonly performed intervention for chronic low back pain in US. It involves placing a needle through the sacral hiatus. Anatomy of sacral hiatus. Sacral hiatus is located at the distal part of sacrum, and at its lateral margin are formed by two sacral cornu. Sacral hiatus is covered by a sacrococcygeal membrane, which is an important landmark in caudal block. Material and method. Study site is Jail and Hospital and Research Center, Bhilai. Study population, all patients of low back pain satisfying the inclusion criteria. Study design is prospective observational study. Sample size is 60 patients. Study period is 1 year. Inclusion criteria has patient over the age of 60 years, patient with diagnosed case of spinal stenosis, patient who have failed to improve with conservative treatment, patient with history of chronic functional limiting low back pain of at least 6 months duration, patient who are competent enough to understand the study protocol and give voluntary written informed consent. Exclusion criteria: patient who are medically unfit for surgery, patient which they have received previous injection in the lumbar region within past 6 years, patient with lumbar surgery within past 2 years, patient with history of lumbar fracture, patient with acute disc herniation, and patient with any malignancy of any malignancy or infection which can negate the functional improvement with the injection. Technique includes the spinal trolley, the position of the patient which is supine, and the position of the needle which is at the 45 degrees to the sacrum inside the sacral hiatus. Follow-up is done immediately post-injection at day 1, that is after 24 hours, at 1 week, at 3 months, at 6 months, and patients are assessed according to visual analog score, modified Osworth disability index score, and the straight leg raise test. Results are in the pre-procedures and post-procedures, straight leg raise test has increased substantially. VAS score has decreased significantly in patients with pre-procedures and post-procedures. Modified Osworth disability score has also decreased in this patient, as you can see in this graph. Complication we faced are nausea, vomiting, dizziness, infections, nerve root injury. Conclusion is there is a significant difference in pre and post injection SLRT, PAS, and ODI score. Mean SLRT has increased at 3 and 6 months compared to pre-injection SLRT, and mean VAS and ODI score has decreased as compared to 3 and 6 month pre-injection VAS and pre-injection ODI score. Caudal epidural injections seem to perform well in terms of pain alleviation and functional improvement in our study. Now the references. Thank you.
Okay, I would like to now have these last 3 papers open for discussion. Do we have any questions from the house?
So
okay,
I had questions. Yeah, you can ask. Yeah.
Yeah. So
Go ahead.
I have one question for Dr. Anuj Yadav. Did you encounter any issues with patients having some severe scoliosis or kyphosis deformity in your cases while doing anesthesia, giving anesthesia?
Hello, sir. There was no, there were not severe scoliosis or kyphosis. Yeah, mild scoliosis were present in those patients. They were elderly patients. So yes.
And one more question I had was, any particular spinal needle is your preference while giving in these elderly patients a caudal epidural?
No, sir. We used not any. We use a 20 ml syringe, and we did it with the same needle.
Okay, thank you. Yes, Dr. Kshitij, you have any questions?
Yeah, so I had a question for Dr. Akash. I mean, I just want them to speculate what do they think is the reason, because it's a little surprising result in their paper. And I wonder, is it because of the number of cases in there, or although they did find a difference, so maybe it's not just the power of the study that's a problem, but what according to them is the reason why they had inferior results, the ones who got an epidural within a month. And do they have any other studies who have corroborated or have similar kind of picture, or have reported similar kind of picture? That is for Akash.
Good afternoon, sir. I think one of the it's a mere speculation actually, but we think that the reason was the altered tissue biology, which was left because of a recent steroid injection. Over 3 months, probably once the actions of the steroid on the local tissue wears off, it could probably lead to a much better healing as compared to when it was done within 3 months. So that is probably one of the reasons. With respect to the studies, yes, we did find a few studies, but they were mainly around the complications. That is around that is based on the dural tears that the researchers observed. So yes, but it's a mere speculation on our behalf. We're not very sure of the reason, but it probably requires some other study as well. With respect to the power, yes, it is a bit underpowered, but since it was a retrospective analysis, we could not have done much more than collecting the patient's data.
Thank you, Dr. Akash. And another question for Dr. Amey. It's a very interesting study, and as we are moving towards more minimally invasive and more daycare surgeries, this area is one thing which we should explore. But I wonder, how did you keep the anesthetists the same for your 178 cases? Well, I mean, did you exclude the cases done by other anesthetists? And if so, why did you do that? And did you ever encounter a situation where you're doing a surgery and the spinal anesthesia wore off and you have to do something more, or give the patient sedation or some GA or something like that? Did that ever happen? This is for Dr. Amey. Is Dr. Amey there?
I think we'll keep that question on hold. I think he's not there. We'll try to get him.
Okay, no worries.
Yeah. So meanwhile, I think we'll get on with the next paper if anybody does not have any questions. I would like to invite Dr. Atif Naseem to present his presentation. Can we have his presentation on?
Hello everyone, my name is Atif Naseem. I'm here to present my study on minimal invasive versus open TLIF in overweight and obese patients in terms of methods. Coming to the introduction, transforamen lumbar interbody fusion by both minimally invasive and open techniques have been found to have similar clinical outcomes, though both the approaches can be challenging in patients with high BMI or when they are overweight and obese. So in this study, we have tried to answer the same. We investigated the outcomes of following an open and minimal invasive TLIF for degenerative lumbar spondylopathy in patients with BMI more than 25. The study was a randomized prospective study, was undertaken over a period of 4 years of duration and includes all the patients with BMI more than 25. A total of 72% were enrolled in the study, out of which 63% patients were available for the final analysis. Various demographic, clinical, and radiological criteria were noted preoperatively and at postoperative day 1 month, 3 months, 6 months, and 1 year. Post-perioperative variables like operative time, duration of stay, blood loss were also noted. Functional outcomes were assessed by visual analog scale and osmotic disability index. Return to work and radiological fusion at 1 year were also recorded. Coming to the results, out of 63 patients analyzed, 30 underwent open TLIF and 33 underwent minimal invasive TLIF. There were no statistically significant differences in the demographic variables found, though the VAS and ODI scores at postoperative day 1 month, and 3 months were better in both the groups. The difference was significant in minimal invasive TLIF group. Both the scores were comparable at 6 months and 1 year. There was also lesser blood loss, surgical time, and hospital ICU stay in the minimal invasive TLIF group. When we see the fusion rates in 1 year, which is comparable in both the group, but the return to work is significantly earlier in minimal invasive TLIF group from the open TLIF group. Coming to the complications, the most common complication was durotomy in both the group, but when we see the overall complication, which was significantly lesser, occurred in minimal invasive TLIF group. Coming to the discussion, both the open TLIF and MI TLIF have been studied in great details and have demonstrated that if it is not better, if the MI TLIF is not better, but definitely it is superior in obese and overweight patient in terms of intraoperative and postoperative variables. Coming to the conclusion, though both present surgical challenges of their own, The others conclude we conclude that the given we have given the minimal invasive group with the improved outcomes until 3 months. Therefore, minimal invasive TLF can be considered for all such patients, as the return to work was significantly early in this cohort and the complication rate are significantly less. Thank you.
That's a very interesting paper. In fact, I think nothing was quoted one of my papers which I have published and on the effect of MIS versus open TLF. So I'll invite the next speaker, Dr. Anand Bagul, to present his presentation. Can we have his presentation on?
Good evening. Good evening, respected chairpersons and all my dear colleagues. It's a great pleasure to share you one of the unusual cases of the spinal cord transaction in today's topic. My topic is use of the spinal scaffold in spinal cord transaction, a case study. 22-year-old soldier who got admitted with a bullet injury, T1 to T3, with a spinal cord transaction. He presented with both lower limb weakness and a complete paraplegia and loss of sensations below the clavicle line. As you know, the spinal cord transaction is a very, very untreatable condition, and we decided to fill the gap with a bioscaffold with the extracellular matrix impregnated with a platelet-rich plasma and mesenchymal cell with a neuronal growth factor. And this encourages the axonal regeneration as shown in the slide. I would like to come back to the case. The patient is conscious, oriented, with a total paraplegia below C7 level. Power is grade 0 in the lower limbs. We had decided to undergo laminectomy and spinal cord ends were refractioned, and bioscaffold is used to fill the gap between the ends, and in the bioscaffold is impregnated with a no growth factor, mesenchymal cell, platelet. We have also started medical treatment, physiotherapy, and rehabilitation. I would like to just show few of the slide. This is the operative picture, prone position. We undertook the laminectomy, and during laminectomy, as I told you, all the spinal cord ends were refractioned, and we have used this particular bioscaffold, which is essentially done by the extracellular matrix impregnated with a platelet-rich plasma, growth factor, and mesenchymal cells. This is a scaffold being in the place in the gap, and we have completed the procedure successfully. This is a closure slides, and after closure slide, we can after the completion of the operation, patient's rehabilitation started successfully. After 8 months of the operation, patient showed early signs of regeneration in the L1 section. The patient shows very promising improvement and recovery in the form of regeneration, the signal from the brain controlling the muscles travel down through the spinal cord. The MRI suggests that the gap in the cord has been closed and this graft is incorporated successfully. So this particular case, we try to postulate that a bioscaffold is a very good option to treat the spinal cord injury with gap very successfully and will definitely show the promising result in near future. Thank you very much, sir, for your patient hearing. And I suggest your comments or suggestions to me. They are most valuable for me, sir. Thank you.
That was an interesting paper. Lots of questions. I think we will be having lots of questions on this paper. In meanwhile, I would like to ask the next presenter, Dr. Bhushan, to have his presentation on, and after this, we'll have questions for the speakers who have already presented the papers. Can we have Dr. Bhushan's presentation? Meanwhile, while this presentation is getting on board, is Dr. Amaya around? I have a question for Dr. Amaya. Okay, Dr. Atif Naseem, is he there?
Yes. Good evening, sir.
Yes, Dr. Atif, did you find any difference in the image intensifier time, radiation time? And also, I had another question. Was this case study done on a particular group of grade lysis, like a low grade lysis or high grade lysis? Can you let us know?
We usually perform MIS relief on patient with grade 1 or grade 2 lysis, and yes, as usual, the MIS, any of the MIS procedures that we take will pose us to greater risk of radiation and to the patient and to us also. Hello, am I audible, sir? Hello. Am I audible? Hello. Am I audible? Hello. Sir, you are mute, sir. Sir, you have.
Yeah. Now you're audible, Atif.
Yes, sir. Hello.
Hello.
Yes, sir. Sir, am I audible? Hello.
There was some network issue.
Hello.
Hello.
Yes, sir. Yes, sir. Hello.
Yeah.
Atif, you have to unmute yourself to speak. Dr. Atif.
Yes, sir. I am.
Yeah, and you'll have to speak up because we can't hear you. Can you hear us?
We have performed all the surgeries, sir, with lysis grade 1 or grade 2 in our institute, sir. And in terms of radiation, sir, any MIS procedure which pose patients and doctors also to the greater risk of radiation. So.
Okay, and one more question I had was for bone graft. Did you use anything apart from autograft?
No, sir. Hello, sir. Your last words I could not able to hear.
For
sir.
bone graft, did you use any bone graft substitute?
No, sir. No, sir. We just used that facet with the facetectomy part, sir. That's what we have used, sir.
And fusion was assessed on X-rays or CTs, and how early was the CT done?
Sir, CT we are doing after 1 year only, sir. But yes, we could see early fusion on X-ray also sometimes We have the X-rays, we have the data, sir.
Okay. All right. I have a question for Dr. Anand Babu.
Nishant, I think just Dr. Bhushan is not there. So if Dr. Ghanshyam's presentation is ready, we can play it and then ask the three people the questions. And I would encourage other people who are present as faculty in the audience also, if they want, they can ask questions. And maybe Nishant, you can read out the questions if they are typed into the chat box. So it'll go faster that way.
Great. Okay, so I think in meanwhile, Dr. Bhushan, he's not available. So I think we can have the next presentation, Dr. Ghanshyam.
Hello everyone, I am Dr. Ghanshyam Kakadia and my presentation is on sublaminar Marcelin tape augmented pedicle screw fixation for osteoporotic vertebral compression fracture. Osteoporotic spine has a weak and rarefied trabecula in the cancellous bone. Pedicle screw are a greater risk of pull out due to poor hold at bone screw interface. A weak pedicle offer little resistance against screw pull out. Natural history with osteoporotic vertebral fracture is anterior column collapse that also leads to implant backout. Cement augmented pedicle screw has its own complication like cement leakage, embolism and etc. Other alternative and newer technique to augment pedicle screw in osteoporotic fracture has longer learning curve, involve additional cost to the patient and are not without any complication. In this study, we have described the safety and efficacy of low-cost Marcelin tape to augment pedicle screw as a modality of spinal instrumentation for treatment of osteoporotic fracture. It was a retrospective study. 24 osteoporotic vertebral fracture patients were operated from June 2016 to 18 after failed conservative treatment included in this study as per inclusion and exclusion criteria. Our study safety parameters were neurological deficient, implant failure, revision surgery and infection. Efficacy parameters were pain score, fracture union, local kyphosis correction. These are measured during each follow-up. Total 24 dorsolumbar osteoporotic vertebral compression fracture patients included. Mean age was 66.1 years. All patients were operated by single surgeon with open posterior surgery using pedicle screw fixation, decompression, fusion, and sublaminar Marcelin tape augmentation. Sublaminar Marcelin tape augmentation technique steps are: after exposing the sublaminar space, a double loop of 20 gauge cold curved stainless steel wire with ethibond suture were inserted around the laminae of the instrumented vertebrae by insertion, advancement, roll through and pull through technique. After that, 35 cm long two Marcelin tape pull back with the help of ethibond. Each side Marcelin tape are passed over the connecting rod between the two pedicle screws. Both ends of Marcelin tape were sequentially tightened to each other. Finally, good bone graft bed preparation is done for posterior fusion. This is one of our patients who was operated with sublaminar Marcelin tape augmented pedicle screw fixation shows excellent functional and radiological outcome. Our study result shows that neurological improvement was noted in all neurodeficient patients. Preoperative mean local kyphosis was 22.1 degree and that was corrected to 10.4 degree immediate post-op, and there was only 2.5 degree loss of local kyphosis correction at final follow-up. Post-op functional outcome was excellent. VAS and ODI improved significantly in final follow-up. There was no implant-related complication in our study as compared to other modality of osteoporotic vertebral compression fracture fixation. One case has a superficial infection and one case has a deep wound infection in our study. One patient had proximal junction failure at final follow-up. Marcelin tape augmented pedicle screw construct rely on laminae for its hold, which is the strongest part of the osteoporotic vertebrae. So it avoid long implant construct and also avoid cement-related complication. Posterior spinal approach is a more familiar and less morbid in elderly patients. It addresses the spinal cord compression globally by freeing the compression anteriorly as well posteriorly. Marcelin tape is a radiolucent material and does not affect postoperative MRI. There was few limitation of our study like small number of patients, shorter follow-up, no comparative group and no follow-up CT scan to check fusion status. Thank you.
So all the three
That is
speakers have to
interesting.
unmute themselves to speak. All the three presenters, the last three presenters, Dr. Atif, Dr. Bagul, and Dr. Ghansham, if they're asked a question, please unmute yourself and speak. And maybe I'll ask the first question to Dr. Atif. I mean, BMI is not a really good indicator of obesity. It depends on where the fat is. And would it make a difference if you relook these patients with the distance from the skin to the fascia or the distance of the skin to the bone in these patients? Because, we have found that, not all obese patients are the same. And if the fat is located mostly on the back, that makes the surgery difficult. Whereas, the distribution on the thighs or abdomen, things like that. So do you think that would make a difference? Dr. Atif?
Yes, sir. Hello.
I don't know if.
Hello. Am I audible, sir? Hello.
Yes, sir.
Yes, Atif, you are.
Sir, I agree with your comments, sir. I agree with your comments. Definitely, the distance from skin to the depth is could be a greater good variable for this purpose. But still, sir, in terms when we concluded the results, sir, we have given positive results in terms of perioperative variables and definitely functional outcomes, and again return to work and fusion, sir.
There is another question for Dr. Ghansham from Dr. Arvind. Can you reduce the number of levels of fixation with pedicle screws if you have used Marcelin tape?
Yes, we can reduce, but in this study, in all patients, we use we fix a patient to 2-level cranially and 2-level caudally. But yes, we can reduce 1 level.
So maybe I'll answer that one little differently. In all these patients who have been operated, there has been a corpectomy done. But I have seen some Japanese studies and actually Dr. Abumi's group do these surgeries where they have done 1 level up, 1 level down, augmented the front with vertebroplasty, and then augmented the screws with Marcelin tape. So they have done that, but we were a little uncomfortable doing that with a vertebrectomy or a corpectomy kind of a thing. So most of these cases in the series are not those vertebroplasty with posterior fixation kind of a thing, but are corpectomy patients. So any questions for Dr. Bagul?
Yeah, for Dr. Bagul, I have asked a question. Did you notice any difference in levels while for recovery for the patient?
Yeah, the deficit was from the T1, thoracic 1 to thoracic 3 level. So with a 1.5 inch gap, 1.5 inch back, almost around 4 centimeter gap. Now after the scaffold and this thing, we found that there is some amount of sensory improvement. So sensory improvement was first. That was only one thing which found notice. But unfortunately, how much the distal improvement came over, we couldn't get a record because patient was from the Yemen, and he was giving the email that with amount of he was the email, but we didn't go to any authentic information about the further improvement.
Also,
So-
so two short questions I have. What's the cost and how much is the duration of the surgery for this?
Cost was less than 1 lakh rupees, sir. Around 70,000 rupees, you can say.
And duration?
Duration of the stay was around 4 to 6 weeks we kept in the hospital.
But Dr. Nishant, before we ask cost and all these things, this is basically a research kind of a study. So this is not something that you can, tell. And I would say that something like this, translational research would happen after doing it on animals. So is there evidence about
Sir,
gaps being
yeah,
filled on
sir, we
animals?
do it. Let me explain me, sir. This is a pilot study case, and we got approach from the ethical committee with the permission to undertake this particular case. This is the only case which is very unusual. It is so this is a very unusual case. It's a pilot study. It is not an experimental. It is not.
I understand, but
This is a research case.
yeah.
Similar kind of cases has been performed in the rest of the world. I think I can recollect 2 or 3 instances where the spinal scaffold is being used, but not as a research purpose, not under the clinical trial. This only as a pilot study case, sir.
I mean, if this has to be propagated as treatment, first it has to be demonstrated in animals that a gap of a spinal cord can really regenerate by doing the method that you described.
Yeah, so
and then would be phase safety, and so something like this would go different phases of trial. Let's not discuss the trial things, but let's get back to the basic way stem cells work. The problem with stem cells is that nobody has been able to figure out a way of doing long distance regeneration of the neurons. The stem cells are for the myelination. So you are doing a long distance regeneration of the neuron, which is different from myelination.
Yes, I understand. I understand the question. In fact, there are 3 instances outside India. This particular surgery has been performed with a very encouraging result. The main factor is a platelet-rich plasma and neuronal growth factor, which play a very major role. This is a very
all right, Dr. Bagul.
I
Thank you
think
very much.
this is a topic which is still in research, and the human mankind and doctors are really onto it.
Please keep on doing the research. We'll be interested to see how things go ahead. We'll move on, Nishan.
Yeah, let's go on with the next speaker. Can I have Dr. Kaivan's presentation, please?
Greetings to one and all. My name is Dr. Kevin Randera. I shall be presenting you the incidence and analysis of abnormal MRI of the lumbar spine in asymptomatic patient, a prospective study. MRI scans are being widely used in detecting conditions causing low backache and radiation to the lower limb. They are said to be highly sensitive in the detection of partial or complete tear of amylase fibrosis that are undetectable with other non-invasive imaging modalities. In many spine centers, there is a trend of doing MRI screening of the whole spine. We decided to take this opportunity and calculate the prevalence of abnormal MRI findings in lumbar spine of patients who never had any history of low backache or radiculopathy. So the aim is to detect and calculate the incidence of abnormal MRI in lumbar spine in asymptomatic patients to create awareness of caution regarding the operative management solely on the basis of MRI reports without thorough prior clinical examination. So MRI was done on of the lumbar spine on patients that came to the MGM Orthopaedic OPD with no prior history of low backache or sciatic pain. They had come to our center with complaints of neck pain with no symptoms of low backache. They were given a standardized questionnaire and screen. Anyone having low backache, sciatica, claudication pain was excluded from the study. And the MRI was done for detecting the underlying cause of neck pain in these patients. And along with that, a whole spine screening with spatial cuts was taken for a lumbar spine to detect any abnormality in the lumbar spine. So the subjects who entered the study underwent a 1.5 Tesla MRI. Herniated nucleus pulposus was considered to be an extrusion of focal origin with disc material extending beyond the osseous confines of the vertebral body, resulting in displacement of epidural pad, nerve root, or thecal sac. A bulge was defined as a diffuse, usually non-focal protrusion of non-osseous material beyond the normal disc space. The basic criterion for lumbar canal stenosis was non-discontinuous loss of signal in the epidural pad with compression of neural tissues within the canal. Degeneration of the disc was considered to be present when there was loss of height of disc space and decreased signal on T2 weighted sequences. For each level of disc, the neuroradiologists give a score of the findings of the MRI scan quantitatively and objectively, and results were average. Only the findings which the interpreters had defined as definitely abnormal were considered as abnormal findings. So here's a diagram showing a herniated disc and a lumbar canal stenosis. Inclusion criteria was age between 18 to 60, no back pain, no sciatica, no neurological claudication. Exclusion was any low backache lasting for more than 24 hours, history of absentee of work for the same, any claudication pain, any trauma to spine, any congenital abnormalities. So out of a total 100 subjects examined, abnormal MRI was seen in 30 patients. From these 30, a herniated nucleus pulposus was seen in 24, that is 80% of the patients. Annular tear was seen in 19 patients. Lumbar canal stenosis was seen in 6 patients. Asymptomatic hemangiomas was seen in 11, that is 37% of the patients. Spondylolisthesis was seen in 5, 16.7% of the patients of mild variety. And the most common non-intervertebral disc finding was a small nodule seen in 19% of the subjects who were asymptomatic. And there were 27 patients having an abnormal facet joint. From the 30 patients, 3 patients had lumbarization of S1 and 5 patients had sacralization of the L5 vertebra. This is a graph showing abnormal MRI findings based on the age. So in the present study, about 30% of the asymptomatic had abnormal MRI finding, and considering the high rate of prevalence of backache, the point is that the clinical findings should be correlated with the MRI report. Any abnormality in the lumbar spine is meaningless if considered in isolation. So substantial percentages of the individuals who never had any low backache or sciatica but had abnormal MRI have been reported. About 30% of asymptomatic population had a major abnormality in our study. Hence, a step towards the operative procedure should not be taken purely on the basis of imaging studies without knowledge of the clinical symptoms of the patient. And that is the entire aim of our study. This is the references. Thank you very much.
So I have a question, Dr. Kaivan. Was all the reporting done, and is it a single center series and reported by a single radiologist, all the MRI reporting?
So the reporting was done by a different neuroradiologist who were on call on that particular day, sir, not by one particular radiologist.
So how do you maintain uniformity? As in, is there any intra and inter-observer bias, anything done?
Yes, sir. So generally, sir, the MRI is done by the radiologist on call on the same day. And later on, before uploading them, sir, on our system, there's a single person, the head of the department, who used to supervise these results and reports. And then they used to be forwarded to us, sir.
Okay, great. Is Dr. Bhushan around? Is Dr. Bhushan around? So I think let's move on to the next paper by Dr. Vivek. Can we have Dr. Vivek's presentation on, please?
Hello everyone, I'm Dr. Vivek Bade. I'm presenting e-scoliosis correction with OARM imaging system and still station navigation better than freehand technique, a comparative study. In surgical scoliosis correction, freehand pedicle screw insertion technique is challenging due to its 3D dimensional deformity. The OARM 3D imaging with navigation system is reported to be more accurate for screw placement and to reduce radiation exposure to the surgeon. Between December 2017 and July 2021, 14 patients underwent posterior spinal instrumentation for spinal deformity using OARM imaging system and still station navigation. An intraoperative CT scan of the sterile surgical fields were obtained before the instrumentation. Instrumentation was placed and post-instrumentation CT scans were obtained before the wound closure to assess the accuracy of instrumentation placement and potential need for revision. A comparison group of 15 patients who underwent scoliosis correction utilizing fluoroscopy and freehand technique during the same period was evaluated. Evaluated parameters were age, successful screw placement, effective dose radiation, and correction. This was the freehand technique that we utilized. A case using freehand technique, post-operative X-ray, clinical results. This is the warm technique that we utilized. Correct. Warm guided correction in a syndromic scoliosis, post-operative correction, clinical improvement. This is again a warm guided correction. Warm guided correction in a syndromic scoliosis. So we found that there was significantly less breach in pedicle wall in OAM group. There was statistically significant high radiation to the patient in OAM group as compared to freehand group, and less radiation exposure to the surgeon in OAM group as compared to freehand group. Our results were consistent with the other studies. In contrast to our study, Jink et al. Reported higher radiation dose in OAM group than in freehand group, though the statistical difference was not significant. Also, however, Jink et al. Reported significantly less radiation exposure to surgeon in OAM navigation group as compared to freehand group. This result was similar to our study. So we conclude that the use of OAM with navigation system increases the accuracy of pedicle screw placement in patients with scoliosis. Significantly decreases radiation exposure to the surgeon, but higher radiation exposure to patients as compared to freehand group. Thank you.
Okay, can we have Dr. Harshit Dave? Harshit, can we have both his presentations back to back so that we can have a question answer session at the end?
Good afternoon, everyone. In the next 4 minutes, I'll be talking about MISS technique for chance fracture in a high-risk case of ankylosing spondylitis, technical difficulties faced and its advantages. Flexion distraction injury of the spine in patients with ankylosing spondylitis is challenging because of the associated medical conditions and flexion deformity of the neck and the trunk. We present a case of missed T12L1 chance fracture in a known case of AS with multiple comorbidities who was managed with posterior instrumentation using the minimally invasive spine surgery technique. A 54 years old male patient with AS presented with back pain since 2 weeks after fall from stairs with no neurological deficit. The X-rays and CT scans were done that were suggestive of D12L1 chance fracture, which was initially missed at a primary center but referred to us because of chronic back pain. He was a known case of diabetes mellitus, chronic liver disease, and osteoporosis. The patient also had falciparum malaria infection with thrombocytopenia and developed pulmonary edema. He received enoxaparin for thromboprophylaxis. These are the preoperative radiological images, CT scan and MRI showing unstable 3-column fracture through D12L1 intervertebral body and retrosthesis of D12 over L1. After medical optimization, the patient was planned for posterior instrumentation using minimally invasive spine surgery technique. Posterior spinal fixation from D8 to L4 spanning 9 levels using percutaneous pedicle screw placement and subcutaneous tunneling of the rods through the tubes was done. Intraoperative difficulties and adjustments made. Positioning was difficult and the table was broken from the center to accommodate thoracic kyphosis, and Mayfield clamps were used to accommodate cervical kyphosis. Extreme care was taken to avoid iatrogenic fractures. Intraoperative neuromonitoring was used. Rod pre-contouring to span the long segment D8 to L4 using MISS was difficult to ascertain. Due to the under-contouring, there was partial pull-out of the proximal pedicular screws D8 during the rod placement, but the overall construct was stable. This is the clinical picture intraoperative showing how the thoracic kyphosis was adjusted over a broken table and cervical kyphosis was maintained over a Mayfield clamps. So these are the intraoperative CM images showing entry point just lateral to the lateral margin of the pedicle, guide wire placement and pedicular screw insertion using MIS technique. Intraoperative images showing instrumentation and surgical incision taken for MIS. Operating time was 5 hours and blood loss was 300 ml. Patient was mobilized from the first post-operative day with hyperextension brace. Teriparatide therapy was initiated for osteoporosis, and post-operatively the neurology was intact. So these are the post-operative X-ray radiographs, AP and lateral. You can appreciate the partial pull-out of the proximal DH screws. At 6 weeks follow-up, proximal screw backout was noted, although fracture reduction and stability was maintained. So these are the X-rays at 6 weeks. The fracture has started consolidating, and this is the clinical picture of the patient, pain-free and walking with minimal support. In conclusion, posterior instrumentation using MISs can be used to minimize approach-related surgical morbidity and maximize functional outcomes. Care must be taken to maintain the pre-existing kyphotic alignment during patient positioning and transfer to minimize iatrogenic fractures and neurological complications. Rod contouring to match the pre-injury kyphosis can be challenging in a long construct and may result in implant backout in osteoporotic bones. Medical treatment of osteoporosis should be carried out in conjunction. Thank you.
Can we have Harshit's next presentation as well?
Good afternoon, everyone. In the next 4 minutes, I'll be talking about minimally invasive posterior approach for lateral mass screw fixation in a case of bilateral facet subluxation of subaxial cervical spine. Traumatic cervical spine injuries with neurological deficits are complex injuries and present a challenge in treatment. Surgical intervention should be aimed to achieve adequate neural decompression and restoration of biomechanical stability of the cervical spine. Anterior exposure and fixation provides good neural decompression and anterior column reconstruction, but in patients with bilaterally dislocated or subluxated facet joints, restoration of posterior tension band is indicated. Lateral mass screw fixation helps in achieving it, but at the cost of approach-related morbidity. Open approach to lateral mass requires substantial periosteal muscle dissection, causing disruption of the posterior musculoligamentous dynamic tension band and can lead to substantial blood loss, muscular atrophy, and considerable postoperative disability. MIS approach to lateral mass minimizes the amount of tissue and muscle injury, thereby overcoming the problems of postoperative pain and muscle spasm. So presenting a case of 23 years old male who sustained traumatic spondylolisthesis C4-C5 with bilateral facet subluxation due to fall of a heavy object on head. Neurological examination revealed quadriparesis with bowel and bladder involvement, Asia grade B. X-ray showed enterolisthesis of C4 over C5. CT showed bilateral facetal subluxation, and MRI was suggestive of cord impingement due to prolapsed C4-C5 disc and cord edema, as you can see in the pictures. In the operative procedure, after a standard ACTF, patient was made prone to perform MIS lateral mass fixation of C4 and C5 levels. A guide pin was inserted through the skin under fluoroscopic control to contact the lateral masses. The skin entry was chosen in a method to make pin trajectory parallel to facet joint in the lateral fluoroscopic views. In the axial plane, the entry point was in the midline of the neck. The pin trajectory is thus directed in soprolateral direction to approximate the desired screw orientation. A 1.5 centimeter skin incision was then made at the pin entry point, and a serial tubular dilators were inserted to a final diameter of 18 mm. The surface of lateral mass was then exposed with monopolar cautery and pituitary rongeurs. A 2.4 mm diameter cancellous drill was used to create a 14 mm deep pilot hole with the starting point 1 mm medial to the midpoint of lateral mass. The trajectory was 20-degree lateral and parallel to the facet joint. The degree of the hole was measured. The appropriate 3.5 mm diameter polyaxial was then placed. A second screw was placed in the adjacent lateral mass, and a 3.2 mm diameter top loading connecting rod was attached. Set screws were then placed to affix the construct rigidly. An AP fluoroscopic image was used to confirm the proper screw placement. So this is the intra-op CM images showing the MET tube position in AP view and the making of entry point in lateral mass. And this is the insertion of the lateral mass screws and intraoperative CM image. This is the clinical picture showing the length of the incision and the tubular diameters intra-op. In the results, in immediate post-operative period, there was no worsening of neurology. The blood loss was 50 ml and patient improved from Asia grade B to Asia grade D at 8 weeks after surgery. Bowel bladder function improved. The patient was completely relieved of neck pain. So in conclusion, use of MIS technique of lateral mass screw fixation offers great advantage of protecting muscle and minimizing the blood loss with less surgical time. Proper identification of key bony landmarks under fluoroscopy is necessary, and then the screw can be inserted in a similar way as open procedure. There's less post-operative neck pain and scarring as compared to open procedure. Thank you.
Hello. Very good presentation. Harshit, I have two questions. First, regarding your first paper on MIS fixation on ankylosing spondylitis patients. Did you have any issues while positioning? Was the fracture opened up? And the second thing is, how much challenge did you have to contour the rod and get it into the tulips? Tip.
You have to unmute yourself to speak.
Hello. 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 Dr. Harshit, can you hear me? Hello.
I think we'll take other questions. I think he's disconnected.
Dr. Shithir, any questions you have on Dr. Vivek's paper?
Dr. Vivek is there online?
Yes, sir. I'm here.
Okay. So how did you equate the two groups in terms of difficulty of screw insertion? Like not all scoliosis are the same in terms of not only the degree, but also in terms of the etiology. When you are comparing two groups for pedicle screws, how did you kind of do that to make sure that you are comparing apples to apples?
So, sir, actually, we used most of the patients from idiopathic category.
Mm-hmm.
Yes.
So there were no patients in this who were congenital or some other etiology, because some of your pictures were not idiopathic. That's the reason
Yes,
I'm asking.
yes, sir. There were 2-3 patients with the syndromic etiology, but not all patients. Most of the patients were from the idiopathic scoliosis group.
Okay.
Shitish, can I ask question?
Yeah, please.
Yeah. So for the same speaker who presented on scoliosis, so there is a Watanabe classification for the types of the pedicles. Have you classified, or would you like to classify the pedicles as per the classification and check in future? Hello?
Yes, sir.
Would like to classify the pedicles as per the Watanabe classification? We'll try to reassess and reevaluate according to OAM and freehand pedicle technique.
So we are not classified, sir, as such.
Okay.
So do we have any more questions? Is Dr. Harshit there? So I think we'll move on to the next session. It was an interesting session with so many interesting abstracts. So right now, if we do not have any questions, let's move on to the interactive session.
So
I would like to call Dr. Manish.
So we'll move on to the ICLs. Nishant,
Yeah,
we'll move on to the ICLs. We had a 5-minute break, but I think we can either take a break or start if the speakers are here.
Dr. Priyank and Dr. Gautam Zaveri. Gautam sir, are you there? Priyank?
Dr.
Yes, I'm here.
Yes,
So we'll hand over the proceedings to Dr. Priyank. We have 5 minutes to start. You can wait for 5 minutes and start at 5:30. That's the main interactive course lectures on osteoporotic compression fractures. So over to you, Priyank.
Sure, I'll be starting the same in 5 minutes.
Okay.
Thank you.
Thank you.
So, Dr. Kshitij, I had, since Harshit is not there, so I would just like to put the question up. There must be a lot of challenges faced while putting contouring rod and putting it when you're doing an MIS in ankylosing spondylitis patients. Do you have any experience of that?
Yeah, so the problem in that case is that the fixation points were too far off. So once you get in MIS fixation, and if the longer your rod gets, the more challenging it is going to get, because the way fixation works in MIS is that the screw comes to the rod, whereas in open surgeries you can put the rod to the screw. So and the longer your endpoints of your fixation, the more harder it is going to get. So in this case, it would have been easier to put percutaneous screws as close to the fracture and not skip levels. So like say 2 levels up, 2 levels down, or 3 levels up, 3 levels down. But I noticed that there were many skipped levels, which made you to put rods subfascially all the way almost the entire length of the spine. That makes it really hard to get the exact contouring. And I also noticed that the surgery took 5 hours for a percutaneous screw insertion. And that's, I think most of the time must have gone in that, getting such a long rod across so many segments. So the trick to do that is to go closer to the fracture, especially like a fracture in Angstpond, maybe 2 up, 2 down, or 3 up, 3 down, and not skip things in between, so that you can get a better contour rod. And if you on your lateral fluoroscopy find that the rod is sitting off, don't force the rod onto the screw. Take out the rod, contour it again, and then put it in. Because if you're going to force the rod into the screw is going to back out.
That was my second question. We know that the bone quality is really not good, and when we do percutaneous screws in metastatic patients, we see often the screws backing out while we're contouring the rod, and that's the thing.
So
I
that's
think
the
we've noticed
disadvantage of doing it in MIS.
Yes, correct.
So MIS, be very careful while doing it for osteoporotic bones, because it's unforgiving. It's not like open. So I think we have run out of time exactly. And maybe Priyank can introduce everyone, and we can go ahead.
Yes. Thank you, Dr. Kshitij, for being on board, and thank you everybody else. Now I would hand over the next session to Dr. Priyank. The next session is going to be a very interesting session on osteoporotic compression fractures. It's always a puzzle which way to go about, whether to conserve, operate, which type of approach to take. So we'll be hearing all from the experts. So Dr. Priyank.
Thank you, Nishant. Thank you, Kshitij. Like you just said, it's a very exciting session, and if we have given an entire day, it's still going to be less to discuss all the different aspects of osteoporotic fracture, because that's a new pandemic that we have to deal with. So without wasting time, I'll directly get along with the case. and then we'll have all the experts sharing their sharing their opinion. So here we have this 75-year-old social worker who had an osteoporotic fracture after a trivial fall. Initial 2-3 weeks of conservative treatment was tried. This gentleman was able to manage his activities of daily living with the help of with just little help, and he was not totally disabled. At 3 weeks, when we got his X-rays done, we could see a little bit of instability at the D12 fracture and some early signs, some vacuum phenomenon which we were able to see. Now, at 6 weeks, the patient started becoming incapacitated in performing his ADL, and the X-rays show further collapse and further instability. An MRI revealed that the fracture was going into non-union. There was avascular necrosis seen and Kummel's lesion was forming. So just assessing the type of instability, this gentleman had a intravertebral instability. Clinically, he had no neurology. So it's something which is an ideal case for vertebroplasty. And that's what we ended up doing. We filled up the fracture gap with the help of cement, and the procedure went off uneventful. Patient was very happy. At 1 month post vertebroplasty, was back doing all of his activity. Things are very good. But then the problem started. When the patient came back at subsequent follow-up, he was not very happy. The patient started complaining of pain. And when we got an X-ray done, it started showing loosening around the cement. And that's where the frustration starts, and we start thinking, what did we do wrong? Did we not investigate this patient correctly, or did we not treat the osteoporosis? Was vertebroplasty the right choice? And again, all the confusion started because we had done all the X-rays, MRIs, CTs, bone density. We chose the right procedure. Alendronate was already started on the patient. So where did we really go wrong? And that's where I invite this esteemed panel of doctors to shed the light and their experience on how do we manage osteoporotic vertebral fracture. We have Dr. Raghu Prasad Verma, Subir Javeri, Dr. Gautam Zaveri, Bharat Dave, and Agnivesh Tiku, senior panelists from all around the country, here to tell us how to deal with this complex problem. So I would like to invite Dr. Raghu Verma to teach us and tell us how do we evaluate and start prepping a patient who we are going to take up for osteoporotic vertebral fracture surgery. If we can have Dr. Verma's talk online.
So hi everyone. What's the learning objectives of this topic? It's to recognize the possibility of spinal osteoporosis in evaluating a patient of vertebral fracture, order the appropriate tests and investigate and treat conditions causing the osteoporosis, and obviously clinico-radiologically evaluate to chalk out a plan which gives the optimum result not only for the present fracture, but its cause, which is osteoporosis in the future. Now, an interesting article came out in 2005, which said that only 27% of the patients who were admitted for musculoskeletal reasons were diagnosed of fresh vertebral fractures. Imagine the rest were diagnosed only at a later date in a radiology, and it was totally missed out at the first attempt. In 2013, the British outpatient practices were evaluated, only 12% were detected of the vertebral fractures. Closer to home, in 2017, Mazumdar presented that clinical diagnosis of a vertebral fracture happened only in 60% of the positive radiology reports. This underdiagnosis of vertebral fracture is a worldwide problem, almost amounting to 34%, as in articles in 2019. So the low identification rate is bad because it leads to a cascading effect of future vertebral and hip fractures. We know that a woman, 65-year-old, has a chance of developing 1 in 4 chance of developing another fracture in the next 5 years. And imagine if you were to treat it at the right time, it could be reduced to 1 in 8 or 1 in 10. So most of us miss these innocuous fractures. 25% of them is what literature reports, where a small upper end depressed plate fracture is missed. But when an MR is done, it clearly shows the edematous picture of an osteoporotic fracture, something similar to what you can see here. Also, when we concentrate on lower back, some of the X-rays confine themselves to the lower lumbar spine, But actually, when you do a screening, or if I might say an extended X-ray, just like we do a cervical spine or a whole spine screening for lumbar canal stenosis, we might actually catch up and identify some of the thoracolumbar fractures. What about contiguous multiple fractures? Now, if you look at a poorly done X-ray here, you know that this one looks like a normal bone. That one, without a doubt, is a fractured vertebrae. And what about this one? This looks like an innocuous one. So when you do the MR, which is obviously superior, you say that there is an edematous area even in the vertebrae below. So eventually, when you treat the fractures, both have to be taken into considerations. What's the role of dynamic X-rays? Now, if you look at dynamic X-rays, the importance lies in the positioning of the patient. So you do one which is lying down, which is least dependent, and the other one is either sitting or standing. When you look at the left-sided picture here, you will realize that how well the air-filled or the Kummel signs develop. And therefore, we know that in the left one, we can get away with a vertebroplasty or an augmentation of the cement as a procedure. Whereas in the other one, there is so much of auto-reconstruction that's happening in the sitting and lying down, the one on the right, that we may not get away with pure cement or vertebral augmentation. We might need something more to do. So it helps you chalk out a plan. Also, remember, the neurology might change when they are sitting and loading. They have a sustained SLR when they are lying down, but the moment they get up or sit or stand, they have proximal lower limb weaknesses, which is the dynamic neurology, as we call it. The worst among them is the osteoporotic fractures in degenerative scoliotic spine. So if you look at them in an innocuous looking X-ray here, when you study the MR in the same patient, you realize the fluid cleft, which is seen in the coronal plane, mind you, so they can be easily missed. MR obviously enhances our diagnostic capabilities and also helps us discover or kind of differentiate between metastatic, infective, and osteoporotic fracture by its classical convex posterior border, abnormal signal intensity, both in the pedicle and the posterior elements, epidural mass, encasing paraspinal masses, and other multiple areas. Whereas a distinct osteoporotic fracture is a low signal intensity band. It's a fluid-filled cleft, like you can see in the MR there, as a what we call as a Kummel sign, a retropulsion rather than a convex, bulging out of the posterior border, and there are no epidural masses. As technology advanced, we have now the dynamic contrast enhanced MRI perfusions, where you can see on the right, the OVF, the osteoporotic vertebral fracture, shows a very focal uptake, whereas a pathological fracture shows a diffuse uptake, and therefore improves our ability to diagnose. The CT helps in delineating the template on which your fracture reconstruction is going to happen. It also helps you look at volumetric imaging. For example, if you want an anterior reconstruction for a vertebral fracture, along with the posterior instrumentation, that's where the CT comes into play. Also, its role is in patients whom we already have metallic hardware, which is fit into it because of old surgeries, like a fusion surgery with an adjacent level vertebral fracture. QCT, which is quantitative computerized tomography, came out in a big way, but its clinical relevance is still doubtful. The PET scan still continues to be the gold standard to differentiate a malignant vertebral fracture with an osteoporotic vertebral fracture. Its sensitivity is about 85% and specificity about 71%, mind you. The low specificity is because it kind of cannot differentiate between the non-osteoporotic, which is either the traumatic or the post-infection fractures. But as you can see in the imaging there, it's very clearly seen that the high uptake here that you see in the thoracolumbar and the sacral areas classically define a metastatic fracture, whereas a normal low uptake sclerotic zone is a osteoporotic fracture. DEXA continues to be the gold standard for identifying the extent of bone mass loss or osteoporosis. It's not affected, the femoral ones of it is not affected by arthrosis, osteoarthritis, or bone calcification. And therefore, they stand out more as compared to the vertebral level DEXA. A T-score and Z-score gives us an insight, as we all know. So though two-dimensional in nature, DEXA is best in terms of defining the extent of osteoporosis, predicting fracture risk, and can monitor response to therapeutic interventions. So remember, in radiology, there is a threefold plan. The diagnosis of a fracture, to diagnose whether it's an old or recent, or whether it's osteoporotic. CT and MRI investigates the etiology, differentiates acute and chronic, and assesses the compromise of spinal canal with a follow-up after specific treatments better defined in the two CT and MR. BMD gives you the extent of bone mass loss and to monitor therapy. any good result of surgery actually is optimization of medical conditions because it maximizes outcome, reduces the risk of adverse events, and improves efficiency. Herein comes a 2011 survey of spine surgeons where 60% of them only evaluated bone mineral density after fragility factor. Only 40% of them actually did it before a spine fusion, and only 18% assessed it for metabolic abnormalities. Mind you, the same group surveyed the same group of surgeons in 2019, and actually the the evaluation of bone health assessment had improved, but in no way changed the plan prior to surgical intervention. This is where we have to learn that well-done procedures can fail because the fractured bone is a manifestation of the generalized disease. Hence, an algorithm has to be in place. What about lab investigations? The one on the left is actually the standard investigations, and one on the right looks at the secondary osteoporosis causes, which also will help us enhance the diagnosis. In 2008, FRAX came out as an algorithm which encompasses anthropometric features, clinical risk factors, and BMD. And the 10-year probability of a risk of femoral fracture showed significant correlation, with corticosteroid-induced osteoporosis being the standout. What's the future? In vitro high-resolution techniques like histology, bone markers, microcomputer tomographies, or micromagnetic resonance could be the future. And on a community basis, a comprehensive program which looks at improving BMD, correcting modifiable factors, and stimulating osteoblastic activity as a part of the bone health optimization program will be the future. Therefore, remember, all surgeons should have a high degree of clinical radiological suspicion, look for subtlety in instability signs, look for comorbidities which are associated with osteoporosis, comprehensive analysis of available imaging, and calculate the FRAX score before you dwell on surgical interventions. Please remember, like tuberculosis, osteoporosis is a systemic disease, and the fracture is just a manifestation. Pre-op evaluation should not be oriented at defining the technicalities of surgical intervention alone, but also set a roadmap to treat the cause, which not only will prevent a failure of your intervention, but also prevent further breakdown of skeletal integrity in the future. Thank you.
Thank you so much, Dr. Verma. It was a very comprehensive presentation on all the different aspects of evaluation. I had a couple of questions for you. One is that, see, not a lot of people have all the investigations at their disposal. So if you have to have the bare minimum investigations which you would want before, taking up any case of osteoporotic fractures, which one would they be? And the second questions were, what would be the red flagged osteoporotic cases where you would want to, try and investigate further to find out if there is any other secondary causes of osteoporosis?
So a radiology well, can you hear me?
Yes.
Yeah, so a radiology well done is the key. I think especially in an old nil neurology patients, I would look at doing some dynamic x-rays, even if it's sitting or standing, because it gives us a picture of the anatomy, not only of the fracture per se, but of the alignment, the biomechanics around it. If the patient have a subtle neurology, even if it's subtle, I would still dwell to do an MRI, and I would have a bone, rather a DEXA scan, a bone densitometry done, because it kind of defines what my plan of action for the future also. So if I can minimize it into three things, these will be the three things I would do. What are the red flags to look for? I think for me, the most important is long-term use of steroids for interstitial lung diseases or rheumatoid arthritis or whatever the cause could be, because for me, that is a red herring for sure. I mean, it could lead to failure because it could lead to collapse later for other reasons. If the MR gives me any doubt of either infection or metastasis as the probable other diagnosis, differentials, then I'll keep probably my fingers crossed and not jump into it, because I might even dwell in probably doing a CT-guided biopsy if I have the access or not. Without a doubt, I'll send a biopsy, even if it's a vertebroplasty. However, we may throw it out. The FNAC, take a small fluid, what comes out during a vertebroplasty, send it, because I have had a couple of cases I can remember, and I always say this, that it ended up actually being COX. When we send the sample, vertebroplasty worked very well because it did focal construction, but at the end of the day, the patient needed AKT treatment, and they got better anyway. So I think this would be my approach in those symptoms.
Thank you so much. There's one more question for you. Is there a cutoff for the SUV uptake on PET that is recommended to differentiate METs from osteoporosis, especially in those with MRI that is unequivocal?
Yeah, so I'm not too sure if there is a cutoff for your intervention point of view, which means ultimately what you need to do in terms of whether you want to do a vertebroplasty or a fix or whatever, that doesn't change. I don't know about how it matters in oncology purview, because say for example, say I have a metastatic spine from a basic CA lung, a diagnosed patient. I wouldn't possibly change my diagnosis if I have to give him pain-free with a plasty anyway. I don't know whether it will change my surgical approach. It might eventually change my approach to adjuvant management thereafter.
So I think the question was a bit more technical regarding the uptake of the dye that is seen in a PET scan, because even an acute osteoporotic fracture could show a higher uptake. So is there some is there something mentioned?
I'm not too sure. I'm not too sure. I consider there could be. I'm not too sure. I like the other faculties to tell us if they have a.
Anybody can shed light on it.
So I had a situation where I had a patient whom the MRI was not very clear whether it is metastatic or osteoporotic, and the patient had a history of colon cancer 10 years ago. And the oncologist was saying it's too far off. It doesn't look like, but the MRI was kind of neither here nor there. It was a little suspicious. So we got a PET scan done. And then there is a paper on this cutoff, which uses the cutoff as 4.5 or 4.25 as a SUV uptake. And this patient had a little higher SUV uptake, like 5 or 6 or something, and we thought that okay, it's metastasis. We got biopsy done and all, it all came clean. So I'm not sure with this one case I was like not very sure whether that PET really helps, because it's a range of values. How low is low and how high is anybody's guess.
Yeah.
So maybe I will not do a PET next time for such kind of situations.
Correct.
It's expensive to do it.
Yeah, it is.
Yes, Dr. Dave.
Currently, we are in the situation of early investigation. The routine saga of classic pictures, classic diagnostic criteria are going to go down. We get the patient just in few days of the pain, and that's where we are likely to miss the classic picture, classic imaging as well. And we are so many, and there are so many investigation tools, and everybody gets Tom, Dick, and Harry, everything is done. So we are likely to miss Kshitij and Raghu, and I'm sure, you would have seen this in the clinical practice, and that is becoming more and more challenging. And that's going to be the real scenario in the future as well.
Correct. So if there are no more questions, we'll just move ahead with our case. Now, coming back to our case, this gentleman who had an osteoporotic fracture at D12, this guy was disabled, but he wasn't disabled enough for a major surgery. So at this stage, you start thinking, is there some minimally invasive options that are available which can give him a good result? And that's where I would like to invite Dr. Subir Javeri to tell us about the different minimally invasive options that we have to treat these osteoporotic vertebral fractures.
Good afternoon, friends. I have been entrusted the task of discussing the MIS options in osteoporotic fractures. We are all aware that percutaneous vertebroplasty was developed to stabilize the fractured osteoporotic vertebrae and can be performed under local anesthesia with negligible blood loss. It provides immediate vertebral stability and weight bearing and can be performed very well as a day-care surgery and is quite cost effective. However, the downsides of PVP are that there is a significant amount of recurrence or persistence of pain, and there is also a bone loss around the cement in the long term. The liquid monomer tends to cause sudden hypotension in many patients, whereas the liquid cement does have a tendency to extravasate into the vein, the lungs, and more so recently from within the heart as well. Any posterior migration of cement, as shown here, can lead to a disaster and requires an immediate open surgery for the treatment. The kyphoplasty was developed to increase the safety of the procedure of the cement injection. It requires insertion of a balloon to create a cavity within the vertebrae, and the thick paste like the cement is then inserted in a controlled manner. There is minimal extravasation of the cement with reduced embolism and cement-related complications. However, the disadvantages of percutaneous kyphoplasty are that it leads to an increased stiffness of the vertebrae, higher chances of adjacent segment fractures, as well as greater chances of a recompression fracture, and it is not cost effective. This article published in 2018 where the authors reviewed 281 patients of compression fractures showed that a third of their patients developed recompression fractures. What they showed was that the greater contact of the PMMA with the central end plate reduced the chances of recompression. Subsequently, patients with neurological deficit were treated with hybrid constructs, where the vertebroplasty and the kyphoplasty was done in conjunction with fixation. And the favorable results in these patients allowed the extrapolation of this concept to vertebral compression fractures. These are the images of a 68-year-old male who presented to me with persistent back pain following a fall. And if you notice, he has a pincer variety of a fracture with superior and inferior end plate fractures. I decided to go ahead with a hybrid fixation, and over 4 years he has stood the test of time, although there was some degree of collapse which was visible. Cemented augmented screws, also called fenestrated, was subsequently developed because they demonstrated increased pull-out strength as compared to the regular pedicle screws. The fenestrations were located in the anterior third of the screw. It allowed filling of the anterior and middle third of the vertebrae without risk of cement extravasation. And less than 2 ml of cement per injection was recommended, and less so even for the upper thoracic spine. So subsequent cases were done with fenestrated screws, as is shown here. Although this was an open case, we decided to do a percutaneous prophylactic vertebroplasty above the fixation. The same concept was then extrapolated again as an MIS fashion. In this individual who was quite elderly and having an ankylosed spine with a compression fracture at D10, which was going in for a non-union. No amount of general anesthesia was absolutely impossible because of medical comorbidities, and we decided to do everything percutaneous under local anesthesia, and this was the result that we were able to get. Certain novel implantation techniques have been developed for the same concept, and what was known as vertebral body stenting was developed, and vertebral stents were then inserted, expanded, and filled with cement. However, the RCT that was done along with kyphoplasty showed that there were greater implant-related complications, and so currently they are being used only in neoplastic patients only. The Kiva implant was developed in 2010, which is basically a coiled peak implant deployed over a guide wire, and the cement insertion allows integration of the implant to the vertebral bone. It was noted that it was quite effective and provided a better correction of the wedge deformity with the Kiva implant. The spine jack implant was also developed subsequently, which allows correction in chronic cases, and in an RCT it showed that there was better correction being maintained with the spine jack. However, another article noted that there was a higher incidence of adjacent segment fractures, and a prophylactic vertebroplasty above the spine jack was recommended. An osteofixed cementless system was shown to be inserted percutaneously without cement, where expandable titanium mesh cages were inserted. And because cement was not used, there were no cement-related problems, no leaks, no adjacent fractures, and there was a reduced radiation exposure to the surgeon and staff. So if we take home, if we take home the message that despite novel innovations, cement augmentation of OVCFS stood the test of time. Despite the allegations of being a sham procedure, VP and KP are here to stay. Hybrid procedures tend to provide better relief as compared to isolated VP or KP in select situations, and we need to better define the indications of using these implants in conjunction with VP or KP. MI's options exist, but they need to be more cost effective, and teriparatide has proven to be a game changer. Thank you.
Thank you so much, sir. It was an excellent presentation. A couple of questions. One is, do you have any criteria where you would recommend vertebroplasty versus kyphoplasty versus MIS augmentation?
Right. So I actually have done some uh, uh, what do you call a background search on my previous patients, and what we have come up with is that if these patients they have a greater than 50% loss of vertebral height, or if there is more than almost 20 angulation between their sitting versus supine spines. It seems to be a lot of noise coming from someone's.
Avni, can you mute all others? Pharma tech team.
Yeah, that's fine.
Sorry.
No, that's okay. So, so basically, more than 50% of collapse, as you saw in those cases, where we had almost like about to become like a thin wafer vertebrae kind of a scenario. And those who were, there was more than 20 degrees of angulation between their sitting and supine X-rays. Those are the ones where I start considering doing additional fixation, because we have been doing vertebroplasties. Kyphoplasties I started doing since 2003, right? So I have seen like 7, 8 years, 10 years down the line, they just keep coming back, cribbing back pain, back pain, back pain. Even at like after the first 2, 3 months, that's the honeymoon period. Then they just start cribbing, and no amount of teriparatide helps. So what I have seen is that after 12 months of teriparatide, there is a proximal fusion that occurs of that vertebrae with the vertebrae above.
Yes.
And that is when they actually stabilize and settle down, and they stop calling us. Okay, now the pain is little bit less, you know. So vertebroplasty by itself is not 100% answer, but those where we have done hybrid cases, they seem to have done much better in the long run. But I have always, wherever I have added teriparatide to this regimen, I have been successful. That is why I put the last line that teriparatide has been a game changer.
Thank you. Thank you so much for the insight. Yes, yes, Dr. Dave, you had.
Yeah, I think I have two things to really give the input about. One thing is if you get, when you inject the cement, then if you get the honeycomb appearance of the cement, consider that it is pathological. It is not Camel's, it is not something which is an osteoporotic fracture. So investigate thoroughly those who have honeycomb appearance of the cement injection. That is one. Second thing, nowadays, I'm not sure, we used to inject when we started doing the vertebroplasty, we used to inject the dye in order to see the spillage into the disc and posterior. Posterior wasn't a major problem because we would not do if there is any doubt. But dye going into the disc has been a challenge as well. So still, is that the scenario which is still going on? Because practically we do not do nowadays vertebroplasty.
Yeah, I tend to agree with you. We screen the CT and see if the patients have any end plate erosion, and in those cases we just don't do vertebroplasty. We just follow what Dr. Zaveri said, augment it with MIS stabilization. So if there are no other comments, yes, Dr. Zaveri.
One thing what we must understand is that vertebroplasties and kyphoplasties, when they were designed, they were to be used after 4 to 6 weeks of conservative care. People have extrapolated and started doing them in acute situations. So that is when you start getting those small cracks going either into the disc or into the posterior cortex. So if you attempt anything after 4 to 6 weeks, most of these times the smaller ones have healed, Yeah, if their anterior cortices are there, they will leak. If there's a leak, a bigger one, then yes, that's going to happen. But the posterior ones, fortunately, seal off by then. So disasters are unlikely to happen if you give sufficient time before embarking upon a vertebroplasty early on.
Thank you. Thank you so much, sir.
Dr. Priyank.
Yes.
One question. Dr.
Yes.
Srivastava here. Dr. Bharat Dave just now commented that he is not doing, vertebroplasty anymore. Any very specific reason for that?
Sir, we get the patients who are early and we start teriparatide early. And that is what I'm going to cover in my medical management talk. So practically we used to do 5 to 10 in a month earlier. But since last 5 years, we probably do only 1 in 6 months, which are real non-unions.
Okay. Good. Thank you.
Interesting perspective. So, sir, we'll move ahead with the session. And back to our patient, we followed the principles and did vertebroplasty. However, the vertebroplasty started failing, and eventually at 8 weeks post vertebroplasty, the patient started developing neurology. Now, the patient here started having instability and neurology both. So what now? What was the reason? Was it the patient selection? What's bad? Was it the timing? Is there some infection that we missed, or did we choose the wrong option? How do we proceed next? Now that's the big question, and there's where I would invite Dr. Gautam Zaveri to, tell us how to decide and plan the different options in managing OVF.
Surgery for osteoporotic vertebral fractures is a highly debated topic in literature. When is surgery required? What is the best surgical approach? And how should we go about performing the surgery? Are all burning questions that have yet to get good answers. Over the next few minutes, I, Dr. Gautam Zaveri from the Jaslow Hospital and Research Center in Bombay, I'm going to share my experiences and my approach to dealing with surgery in osteoporotic vertebral fractures. The first question is, when should you operate? And here I'd like to emphasize that more than 80% of patients with osteoporotic vertebral fractures will obtain significant pain relief within the first 4 to 6 weeks after injury, and hence surgery is generally not required for patients with osteoporotic vertebral fractures. In that case, when is it required? It is required in an acute situation when fracture is an unstable fracture, if there is an accompanying neurologic deficit, and later when there is a persistently painful osteoporotic fracture or painful vertebral pseudoarthrosis. The German Trauma Society has given us a definition, a classification in order to determine which fractures are unstable, unlikely to do well with non-operative treatment, and therefore require surgery. According to this classification, OF1 is a injury with bone marrow edema where the X-rays and CT scans do not see any deformation of the vertebra. These are stable injuries, can be treated non-operatively. Similarly, OF2 can also be treated non-operatively because there is very little deformation of a single end plate and little involvement of the posterior vertebral wall. OF3, on the other hand, involves a more significant end plate fracture, a more significant involvement of the vertebral wall, and the danger here is that this fracture may collapse over time, resulting not only in pain and deformity, but a delayed neurologic deficit. There is still controversial whether this fracture should be treated non-operatively or surgically. On the other hand, OF4, where there is a significant failure of the vertebral frame, there is a complete burst fracture, a significant vertebral collapse, or a split cleavage type of fracture, these are unstable and require surgical stabilization. The final OF5 is a vertebral fracture with accompanying posterior ligamentous injury, and this is unstable, requiring surgical stabilization. Surgery in these elderly, frail, and patients with multiple comorbidities may often be fraught with complications either intraoperatively or postoperatively. The surgical challenges themselves include a challenge in obtaining good implant purchase in the osteoporotic bone, a challenge in obtaining adequate reconstruction of the anterior column so that load bearing may be adequately permitted, and in the long term, preventing junctional fractures and failures and achieving a solid fusion. The first challenge is obtaining adequate implant purchase. In recent times, cement augmented pedicle screws and expandable tipped pedicle screws have become popular in obtaining good hold in osteoporotic bone. However, in my practice, I have found little use for cement augmented pedicle screws, and in a majority of the patients, I am able to get away using other tricks to obtain good implant purchase. These include either under tapping or avoiding tapping of the screw, using longer screws with bicortical purchase or screws with a larger diameter. We often use screws with dual threads, a cortical thread in the pedicle and a cancellous thread within the vertebral body to get better purchase. Instead of using a typical pedicle screw trajectory, which is medially oriented, we sometimes use a cortical screw trajectory, which is outwards and upwards, getting purchase within the pedicle and the end plate, and therefore having a better hold. In some cases where the pedicle screw does not seem to have adequate purchase, I tend to supplement it with sublaminar wires. And as a rule, in osteoporotic bone, I use longer implant constructs, typically 3 above and 3 below the fracture site. One of the biggest challenges in the osteoporotic bone is adequate anterior column reconstruction. If your anterior column is not reconstructed, it cannot transmit loads adequately, and therefore there is a flexion loading or a kyphotic bending force which is applied on the posterior implant. This results in pull out of the implant or failure at the junction. And how does one reconstruct the anterior column? If the patient's primary problem is instability and neurologic deficit, and there is very little deformity in spite of the vertebral collapse, I tend to do an in situ stabilization with decompression of the neural elements. If the preoperative X-rays, supine and standing film show a significant difference in vertebral height, these patients are treated with cement augmentation of the fractured vertebra along with posterior stabilization. However, if the vertebra is completely collapsed and there is a split cleavage fracture, I tend to do a vertebrectomy and reconstruct with cage as long as the bone is of a relatively decent quality. If the bone is extremely weak, then I tend to do a vertebral shortening where I shorten the posterior vertebral column so that the end plates come closer to each other and the amount of flexion loads on the posterior implant are reduced. In the long term, the problem is with junctional fractures and failures. And the best way to avoid junctional fractures and failures is to avoid ending your fixation at a previously fractured level or at junctional levels. Teriparatide is the single most important thing that has been shown to reduce the risk of junctional fractures and failure. Other tips and tricks include cement augmentation of the junctional vertebrae, use of Mercilin tapes through the spinous process in order to prevent junctional failure, and use of transverse process hooks. The final challenge is to achieve a good spinal fusion. In all patients where I'm doing a posterior or posterolateral fusion in osteoporotic bone, I tend to supplement my autograft with an equal amount of allograft so that I got a good scaffold in order to promote the fusion. I have rarely found the need for using bone morphogenic protein. However, I routinely use teriparatide in the perioperative and postoperative period in order to promote the spinal fusion of this bone. To conclude, surgery, although rarely required in osteoporotic vertebral fractures, is indicated for patients with neurologic deficit, ligament instability, or in patients where cement augmentation is indicated. You must remember that anterior surgery alone is doomed to failure in the osteoporotic bone. And therefore, majority of the times, the surgery involves a posterior stabilization, decompression if necessary, and anterior column reconstruction if necessary. Posterior surgery in osteoporotic bone can be challenging because of the challenges of implant purchase, challenge of anterior column reconstruction, in the long term preventing junctional failure and pseudoarthrosis. Thank you.
Thank you so much, sir. Very well explained. Just one question: is there any cutoff on the bone density that or a DEXA scan that you use to decide on the number of levels, or if you want to augment it with cement, or is it a clinical judgment on table?
So it is a clinical judgment. There is no. I never do a DEXA scan. I think it's a waste of the patient's money. Okay, so I don't do a DEXA scan in my patients preoperatively, or otherwise. I just check the high risk factors that the patients have, the X-rays, the age of the patient, and the fact that they've developed an osteoporotic vertebral fracture is enough to tell me that this patient has osteoporosis or not. For all practical purposes, when I go in with the mind that I do not want to use a cement augmented screw. So I plan to do my fixation with that goal in mind. So I take steps at every stage of the procedure to make sure that I get an implant purchase. I think the single most important thing is an adequate anterior column stability. Anterior column stability is emphasized in the thoracolumbar fractures in young patients. It is even more important in the osteoporotic bone, which does not have the capability of load bearing. So you need to make that posterior implant that you are putting in load sharing. One of the things which I have found very useful is to use a hard shell rectangle and sublaminar wires, because this allows a little bit of collapse in these patients. And I, for one, have loved using it in the selected patients with osteoporotic fractures, especially when the lesion is in the lower dorsal spine, where I can escape up by fixation up to the upper lumbar spine and don't lose lumbar motion. If I feel that it is in the thoracolumbar junction or upper lumbar spine, then I tend to use pedicle screws more often. But I think if you go in a stepwise manner, and another important thing is that if it's osteoporosis, try and do the entire fixation under Siam control. So you have only one chance to put the screw in the correct direction. Trying to change the direction, trying to change the trajectory, you make multiple different channels, which then weakens the bone. So I tend to use Siam much more in an osteoporotic bone at every stage of the surgery. But generally, I can remember probably 2 or 3 instances over the last 20 years when I've had to use cement to augment my screw fixation. Generally, just following all these tricks, and of course, for the longest period of time, I have used sublaminar wires to augment my pedicle screws if I am worried. And they have given me great results. I can say that I have not had really a problem, except possibly one patient with HIV and tuberculosis where the implant pulled out. Because other than that, over the years, I have not had a problem at all with this kind of a fixation.
Correct. Good point, sir. Thank you. In the interest of time, we'll just move ahead and take any further questions at the end. So just with our patient, we ended up going long. We did the whole hog. We did 3 above, 3 below fixation. Things were good in the beginning. The patient had good early neurological recovery, but then at 2 months, the implant started walking away. And this is a picture that you don't want to see in your follow-up X-rays. The implant started walking away, and eventually it collapsed, and patient started having severe radiculopathy. So what next? Again, we went back to the drawing board to see what we were missing. And suddenly it hit us that did we really treat the osteoporosis? Wherein I would like to invite Dr. Bharat Dave to tell us what is the correct treatment for medical management of osteoporosis.
Greetings from Bharat Dave. I am Dawad. will be talking on the treatment of osteoporosis and concentrating on the sequential therapy. Thanks to organizers for giving me this opportunity to share my experience and the literature. What is sequential therapy? As we know, diabetes, blood pressure, same way osteoporosis is an aging too. And would like to start with the quote, love me or hate me, but think about me and remember me. And this should also be included into the sarco-osteoporosis, meaning sarcopenia and osteoporosis. They are the brother and they are the duets walk together. Once diagnosed, it's a lifetime treatment required and drugs have the different actions. And the sequential therapy is one of the most important aspects one should consider in the treatment and management. Following studies have been included starting from the Expose, FACT, Vero, Horizon, EVA studies, and recent studies related to the COVID as well has been included in the talk, in the lecture. Clinical practice, what I have discussed, what is available here in our country, considering the moderate to severe osteoporosis, clinical risk factor should be considered whenever we plan the treatment. And I have included our clinical scenario, our patient preference, and our clinician's limitation as well. So coming to the clinical risk factor, one must remember and one must follow in the day-to-day practice. And would like to highlight the secondary osteoporosis, which is caused by the drugs like anti-epileptic drugs, like anticoagulant drugs, and even recently the rifampicin has been added to cause the osteoporosis as well. So we should plan the treatment as per the secondary causes of osteoporosis must be ruled out. What we do in our setup, I think it is something which we do is the BMD DEXA scan. We evaluate this DEXA scan in detail in the form of BMC and BMD both, and we have the spine and hip evaluated, and we consider the lowest of either of them and diagnose them as osteoporotic. We have the blood basic profile, and we also monitor the overall outcome with the BMD and on occasions the bone turnover marker as well. Coming to the basic treatment plan, teriparatide is something which is available as an anabolic drug. That's the only drug which is available which causes the osteoblastic stimulation, and that is something which is used by practically all of us. What are the positive sides? Well, it's the only drug that improves the bone architecture, trabecular and cortical. And I will call this as a miracle molecule because our osteoporosis management has completely changed. Our vertebroplasty, which we were doing 5 to 10 in a month few years ago, now that has come down to maybe once in 6 months. But what are the negative sides? It's costly, percutaneous, has to be injected every day. Compliance has been a problem, and we are challenged by the biosimilars, and the effect of these biosimilars is not the same as one would expect with the primary molecule. One has to evaluate serum calcium level and serum PTH level before prescribing teriparatide. Friends, remember this, because hypercalcemia, hyperparathyroidism secondary to osteoporosis is a well-known entity, and one must rule out the malignancy as well, because this is the hormone therapy and it can aggravate malignancy as well. So our observation has been poor adherence due to subcutaneous infiltration and the cost of the therapy. Bisphosphonate is another molecule which can increase the matrix mineralization. It doesn't restore the lost structure, but it substantially improves the microarchitecture and it by closing the resorption pits. And it does not stimulate osteoblastic activity directly. Our observation has been good adherence to the treatment by the bisphosphonate. Positive aspects, cost effective, both available oral and IV, maybe once a year as well can be used. And most important, the effect remains for 2 years after withdrawal. One must consider the drug holiday, and creatinine clearance should be observed as well before prescribing the medication. Negative effect, it is patient compliance, gastric upset. So occasionally we start the H2 antagonist and the PPI a day before the drug ingestion. So suppose patient is taking it on Sunday morning, we say that Saturday evening you can take this medicine. So you do not have the side effect of it. Denosumab is available in our country. And what are the positive aspects? It is available once in 6 months. We have 10-year data available about its safety. There are no major lab reports required. It can be given to anybody, and it can be given to those patients who have malignancy as well. And it is 6 months if you have to repeat it. If you do not repeat it, then the BMD drop and the fracture risk increases significantly. So this is something which is very, very important. And if you find that denosumab is patient is not going to adherent to, then probably we can start bisphosphonate afterwards. It is an injectable molecule, and patient compliance and adherence, our observation has been good with this molecule. Coming to the overall, how do we start the medication? Teriparatide 18 to 24 months. It is given once in lifetime, but I'm sure many of us have given it to the patients second time as well, but which is not indicated in the pharmacotherapy. Contraindicated in malignancy. Serum calcium and PTH level has to be monitored and has to be checked pre-operative, pre-starting the treatment, which is very important. I repeat, it has to be done. It's red label, which people will come and ask, but most of the time, one can very well communicate and explain them. Cold chain has to be maintained. Bisphosphonate, as we know, jaw necrosis and atypical fracture should be considered. Denosumab, it is safe in malignancy. Combined therapy, adding 1 plus 1, does it give you 2 effect? No, it does not give you 2 effect. So one may not start both together, but if patient is going to be defaulter, one may consider as well. So teriparatide to denosumab or teriparatide to bisphosphonate after the bone induction has occurred, but denosumab to teriparatide is not recommended in the literature, and in the overall treatment outcome is poor. Decadurabolin, it is an anabolic, it is injectable only. Weight gain has been an issue. Prostate cancer should be ruled out. We have done a study recently with the 2-year follow-up, and our experience has been decadurabolin combined with anti-resorptive has found superior effect than only anti-resorptive medication. When do we stop all the medication? Perhaps never. Vitamin D and calcium has to be continued, and we should check the BMD yearly, and we should keep monitoring osteoporosis. This is a very important slide because whenever there is osteoporosis, we usually should be giving teriparatide, then followed by bisphosphonate or denosumab. And once patient becomes normal, we can just continue with the oral calcium and vitamin D, and one must monitor the glomerular filtration rate. Issues unresolved with osteoporosis, patient education, awareness, I think it is much more at the moment. Adherence to the therapy has to be considered, and we should be talking about the sequential therapy as well. We have found in cases where there is resistant osteoporosis, we should be looking at the atypical fracture. If patient complains of pain in the thigh, please evaluate, and patient usually ends up with the fracture. Even if there is a small little crack seen, immobilize them, educate them. We should be considering the Indian data, which is lacking at the moment. To some extent, we are using the Singapore data for the FRAX, Indian population of Singapore patients. COVID-19 challenges has been found because the minute the lockdown was announced, we telephoned practically all our patients and advised them to continue medication which they are on. If not available, communicate with us. So that was something which everybody should have done, and maybe some of us may have done as well. And treatment must continue with osteoporosis. So message is clinical risk factor present, low BMD. BMD could be deceptive as well. So make sure that we read the BMD properly, rule out the secondary causes, and one should start teriparatide, osteoblastic, followed by the other 2 molecules, either bisphosphonate or denosumab. When there is low BMD or clinical risk factor present, then one can start only the osteoclastic suppression in the form of anti-resorptive, depending upon the patient compliance. So this is very important slide, 18 to 24 months of teriparatide. Combined therapy doesn't give as good effect as one would expect. I would put a disclaimer here. This is the treatment plan which we follow at our center. This is something which should be sort of, used it on personal basis. Identify it in the early stage, educate the society and the patient, concentrate on the full course and the regular follow-up. Sequential therapy is must. Identify the defaulters. Newer molecules like denosumab has less defaulters, and let us fight this monster of osteoporosis. Telemedicine should be used aggressively in order to educate this patient. Compliance is very, very important, and sequential therapy should be followed. Oral calcium, vitamin D has to be given, but make sure that vitamin D is not overdosed because it is a fat-soluble molecule, and side effects are observed in the form of headache and generalized body pain as well. So make sure that it is not hypervitaminosis D. Teriparatide, maximum 2 years, discontinue therapy, and once it is discontinued, the effect will wear out in 2 years, sorry, 2 months. So you must continue, or we must follow with osteoclastic suppression after stopping the teriparatide. Denosumab 10 years, if second dose is not taken, BMD will drop. So make sure that it is all written in the notes in the prescription, 10 years of therapy. At least patient is going away with the prescription. Bisphosphonate drug holiday should be considered. Combination therapy, not very, very positive evidence. Thank you for your patience hearing. Thank you.
Thank you. Thank you so much, sir. We'll quickly move to the last talk of today before we take questions because we are running slightly late. So you very well pointed out my blunder where we had not really treated osteoporosis very well, and that's one of the reasons why we are suffering. So here the thing was that we had to eventually go back in and do revise this patient, and there's where implantology comes into. How do we salvage this? What are the different implants that we can use? And to enlighten us about that, I invite Dr. Agnivesh Tiku to share his talk.
Thank you, Priyank. Thank you, BSS. Is my screen visible?
Yes, it is.
Okay. So how do we decide the implant strategy in osteoporotic spine? So as compared to a normal surgery, we tend to do certain variations in screws. We tend to put more screws. We tend to medialize them more to get a better purchase and a better pull-out strength. There are certain screws available with hydroxyapatite coating. There are cement augmentation of normal screws. There are fenestrated or cannulated screws available. We tend to aim for bicortical purchase with normal screws, and there are hooks, wires, and cables which are available. Now, there are certain screw designs which we need to keep in mind. Is the contact of screws with the bone is more important. So now if you try to increase the pitch depth, which means that your core diameter of the screw is less, but your thread is quite more, which is how a normal cancellous screw looks like, your pull-out strength will become better, but that in turn decreases the screw strength. So that is why you need to sort of keep a balance in between where you have to do. And because it's not only the pull-out strength, it's about the weight that the screws have to bear in cyclic loading. The largest diameter screws you can put are the safest. Again, we usually do not go more than 80% of the diameter of pedicle because putting a screw more than that can cause a stress fracture of the pedicle. Then there are conical screws which are available. They are like self-tapping screws which are tapered ahead and then sort of becoming broad towards the rear end or the tulip end of the screw. When you put these screws, you get a very good feeling that, oh, the screw is very tight. It's like good hold. But that is insertional torque. It's not pull-out strength. If you have a conical screw, it toggles, it pulls out. It is weakest in pull-out. So we have to differentiate between what we feel when we are putting in the screw versus a pull-out strength. So conical screws, we should avoid putting in osteoporotic spine. The second is, how do we plan and put the screws? Let's see that normally most of the screws are at 80% of the depth of the from the facet to the anterior vertebral body. Now, if we consider this as 100%, if you put a shorter screw because the screw is touching end plate or it's not, you're not able to negotiate it, the strength reduces by 25%. Whereas if you're putting to the anterior cortex, you are getting 50% more pull-out strength as compared to a normal screw. This is in the lumbar spine. In thoracic spine, you get 75% purchase as you cross the neurocentric joint or the pedicle body junction, to be more practical. Now, if you put an anatomical screw, which is along the pedicle, versus a surgical straightforward screw in thoracic spine, that gives you an additional pull-out strength of 27%. So a straight surgical or a straightforward screw is preferred in osteoporotic spine. Ideally, do not tap them, but do not tap more than 1 mm. Never ever try to tap the same mm in these screws. And in these spines, cement injection increases the initial pull-out and fixation strength. But once it becomes loose, it is as good as a screw, as a normal screw. Now, if you medialize the screw more, you get a better purchase by around 28%, because you tend to lock in a wider portion, and it's a triangular portion which will be more resistant to pull out. Now, if you burst a screw, or if your screw is loose when you put in, there are certain options which you can do. Consider using a larger diameter screw if the pedicle walls are intact and they can accommodate a larger screw. If you are not able to do that and you have a same size screw, you sort of try to change the trajectory so that you have two different planes in which you are trying to go, the initial pilot hole and the second one. Consider cement augmentation if you are familiar with the technique, or skip that pedicle, use a wire or hook at that level and sort of go into the next level. Now, if you put in a screw and you take it out and put it back again, you lose the strength by 34%. The largest diameter screw is the best. And if you're looking at salvage, say a revision of 6 mm screw, if you put a 7 mm screw, you sort of get a 73% purchase. But if you cement augment the 7 mm screw, you get a significant sort of increase in the pull-out strength. And if your pedicle can accommodate a 8 mm screw, which will not be a very sort of common scenario where you will be able to put that big size, but if you do, it is better than augmenting the same size screw. Now, we usually tend to cement augment whenever there are severe osteoporotic spine. So this is a patient with 2-level osteoporotic fractures with multiple sort of severe osteoporosis and deficit. So in this case, we used cement augmented screws and they stayed back and the patient went on to heal very well. Again, intra-body cage reconstruction is something which we can do instead of cement. I find it more forgiving. So this is another female with a central body collapse with a neurological deficit. And in this case, we did a central body cage augmentation with normal screws. She had a small old fracture. So we put a short segment screw here. And at 1 year, she went to heal very well without any problems. Dual thread screws have a differential pitch between the cortical and the cancellous bone. And we have been very happy with the use of these screws, especially if you want to cement augment them. You sort of tend to put in the Jamshidi needle, do the cementing, and then tap it and put in the screw. If the porotic fracture is involving the disc space along with the end plate, then you need to do a fixation, either shortening of the column or anterior augmentation. Alone, a screw fixation will not be able to take the load for a longer time. Now, with the failing screws, or if the spine is very osteoporotic, what do we do? Now, screws have a definite advantage because they offer a 3-column fixation. The pull-out strength of a screw in thoracic spine has been much better than a pull-out strength of a claw or a transverse process pedicle hook. But this is in a normal spine. When you choose an osteoporotic spine, this thing significantly drops and this rises. So that is why hooks and claws, they tend to be more forgiving than a screw in a very sort of a osteoporotic spine. And this has been a study where the BMD, if the hydroxyapatite content is less than 100 milligram per ml, then you sort of, they do not have any advantage. The screws do not have any advantage above the fixation. Now, this was a very old study where just by radiographic analysis, if you had grade 3 or this type of looking vertebra with an acute fracture and all, then whatever you do, you get poor fixation. But again, now we have moved on and we have many more techniques to counter this thing. So this was actually a contraindication in the 80s and 90s to sort of fix this. And when you look at the absolute values of bone mineral density, a bone mineral density of less than 300 milligram per centimeter square on DEXA it's not recommended to do a pedicle screw fixation. And if you do a pedicle screw fixation and it fails, then the thing which comes to the ultimate rescue is the heart shield. And this will sort of go along with you, and it's more forgiving, and it's an age-old, tried, tested method. And this is the thing which you should rely on. Now, there was a study which was done on 3 different type of sublaminar wires versus tapes and hooks. And the 2 things were studied: the laminar cutout strength and the stiffness of the construct. The thing was that the tape was as good as a braided cable and was better than wires in pull-out strength. However, there was no difference in the stiffness of the construct. To conclude, I would like to say that to understand the stability pattern and plan the treatment accordingly, do not miss anterior reconstruction if it is needed. Keep multiple options available. You don't know what you may want to sort of use during the surgery. Have a customized approach towards each fracture. Don't shy away from sublaminar wiring. Old is gold, and especially in the very sort of old ladies with severe osteoporosis and very poor skin cover, it is got the least profile than compared to a pedicle screws. And do not miss on treating osteoporosis. Thank you very much.
Thank you, Agnivesh. Your talk was a real eye-opener. Since we are running against time, any of our panelists, faculty, they have any final comments for the delegates before we move on to the next session?
Yeah, I think I would like to say, Priyank, that osteoporosis vertebral fractures are a challenge, but not as much as a challenge as it is being made out to be. The principle is to keep it as simple as possible rather than complicating things. Remember what Bharat said, that medical therapy is the primary treatment for osteoporotic vertebral fractures. I disagree with Subir and Bharat both. My patients with vertebroplasty have done phenomenally well, and they have not come back cribbing to me. Maybe they have come cribbing to you, but they have not come cribbing to me. They've been happy with the results of the surgery. I think the key is to choose the patients well. As far as surgery is concerned, yes, one would like to avoid surgery in these patients as much as possible. But if and when surgery is required, if it's a pathology which is involving the dorsal spine, like tuberculosis, and then there is an osteoporotic spine, one must consider using sublaminar wires if it's a highly osteoporotic spine. On the other hand, if it is in the dorsolumbar spine, there are a number of tricks and that you can use, as highlighted by Agnivesh in his talk and by me in my talk. And these are simple things. There is nothing much. You use basic biomechanical principles. Make sure that the anterior column is adequately reconstructed in whichever way you want. Do not try to be too bold and correct deformities. I have a huge criticism for percutaneous screws in the osteoporotic bone. When you put percutaneous screws in the osteoporotic bone and then you try to slide the rod in, the rod is often not well contoured. And then you try to push the rod onto the screw. And that tends to get the screw to pull out. I have seen many such cases come to me secondarily after being operated by other people. For percutaneous screws with, trying to get the bone to the rod is a bad thing to do. It tends to open up anteriorly and causes instability. And otherwise, as I said earlier, that in 20 years of treating osteoporosis, the vertebral fractures, touch wood, I haven't had more than 1 or 2 patients who have had a significant failure. So just stick to simple things rather than complicating things. When you start using cement augmented screws, etc., you are exposing the patient to the risk of cement embolism. If there is an infection, then removal of that screw becomes a nightmare. So there are all these further issues. So Just trying to do something at that point is not good enough. You have to think about the future also. So with these words, I think I'd like to end this session. Thank you very much, Priya.
Thank you, sir. Very well put. I think we have had a very good take home here. Without delaying further, I would like to hand over the proceedings to Doctors Dheeraj and Harshad for the next ICL on transforaminal interbody fusion techniques. Thank you, everyone. Thank you for the day.
Yeah, thank you, Priyank. I will. Dr. Harshad Ardekar is with me. Dr. Harshad. Okay, so we will move with the next talk. We have Dr. Mihir Bapat, and I think Dr. Mihir Bapat was not well, hence his talk was taken over by Amandeep. We have Dr. Arvind Kulkarni, Dr. Guru Raj, and Dr. Kan Singh in this session. And this is a very interesting session, which we, for a common procedure, which we all do is transforaminal interbody fusions. I will like to invite Dr. Amandeep for the next talk.
Yeah, so can you play my talk, please? This is the wrong talk. Should I take over?
Yes, sure, Amandeep, please.
I hope you can see my screen.
Yes, can.
So, good evening all, and thank you to the organizing committee for giving me this opportunity to share my talks. My talk basically would be on analysis or recent literature review on MIS versus open, and sort of an introduction to the consequently following talks. So MIS versus open, the raging debate goes on. What exactly do you mean by MIS surgery? So any surgical procedure where you're using normal anatomical planes or limiting the surgical corridors with the use of latest technological advances in illumination, magnification, and instrumentation to leave the smallest surgical footprint possible. If you'll go through the chronology of various surgical techniques developed over time, you can see Magrill performed his first percutaneous pedicle screw fixation at the same time when Harms came up with his T-lift technique. It took almost 20 years for technology to catch up with imagination of a spine surgeon, where a safe, minimally invasive lumbar fusion surgery can be done, which was achieved in the early part of 2000. Now, while preparing for this talk, I did an exhaustive search in the English literature for any recent articles on open TLIF. Mind you, I couldn't find a single article only on open TLIF since post 2010. All available articles were either comparisons with newer techniques or meta-analysis. So what deduction can we make by this is, I think open TLIF has cemented itself as a gold standard for lumbar fusion surgeries. But at the same time, we can appreciate a shift in surgeons' mindset towards establishing newer techniques. Now, apart from the obvious aesthetically pleasing scar, the MIS technique does give us additional benefits as well. These are reduced blood loss, decreased post-operative infection, decreased length of stay of the patient, better short-term outcomes, but at the same time, the long-term outcomes are similar to those of open TLIF. As the experience of a surgeon increases, the duration of a MIS TLIF or other MIS procedure also reduces. The complication rates of minimal invasive are as similar to those as open TLIF. This is all at the expenditure of increased in radiation exposure, but with recent technologies like navigation and robotics, this can be minimized to a certain extent. Now, take this example of multi-level disease. Does this cause any changes in the outcome of a patient if we do it through a minimal invasion? or of this patient where he is morbidly obese with a high BMI, where the distance between the skin incision and the lamina is approximately 10 centimeters. So the articles usually say that in morbidly obese patients, the operative time does increase, but as compared to open and MIS TLIF, it is substantially less as compared to minimal invasive surgeries. As the incision size is less, the decreased blood loss is there, thus in turn converting into less requirement for transfusion post surgeries. There is no significant increase in complication rates either in open or MIS TLIF for both these cases. Perioperative outcomes are considerably better in such patients if operated through MIS TLIF. Now, the other option or scenario is that of adjacent segment disease. You can see over here that the patient has developed a proximal junction stenosis at a proximal level to a previously fused segment. If we want to do it through an open case, we have to revise the previously inserted implants. We have to redo the previous surgery, extend the laminectomy window proximally. Now with OLIFs, we can do it through a virgin area where all these complications related with the revision surgery can be negated. In cases such as deformities or degenerative scoliosis, the workhouse for so many years have been open TLIF or open fusion surgeries, as you can see over here. It does create a good amount of fusion, but at the same time, there is suboptimal sagittal correction as well. Now, in such cases, OLIF technique has proven quite worthy in correcting the sagittal balance and restoring the lumbar lordosis. But can all these cases be done through anterior or oblique approaches? Let's take this for an example where the patient is severely osteoporotic. He has multiple levels of severe stenosis also present with spondylolisthesis. In these cases, trying to do any minimal invasive surgery has its own set of complications. All different type of minimal access surgeries cannot be used as a thumb rule in each and every case. You have to select which according to the anatomical level as well. Only PLIF and TLIF can be done safely in all these levels. In ALIF, as you can see, it cannot be done at L2, L3, T12, L1, 2 levels, and OLIFs cannot be done at alpha S1 levels because those retractors are not available in India or in our setup. Sagittal corrections are best corrected through ALIF, XLIF, or OLIF techniques, but at the same time, the incidence of cage subsidence is also high in such cases. Usually, these surgeries are staged while they might require an anterior plus augmentation with posterior percutaneous stabilizations. Osteoporosis is a relative contraindications for doing such kind of minimal invasive work. So the workhorse or that the age-old open TLIF still holds true in today's scenario. To sum it up, open TLIF is a versatile procedure. It can be easily reproduced. It can be easily reproduced by anyone, even in a basic setup. It is quite cost effective. MIS has its own benefits, such as daycare is short stay, superior outcome results are there, but not all cases can be done through MIS techniques. It cannot be done in severe central stenosis. It cannot be done for high-grade listhesis. People are doing it, but they're in literature, it's only case reports which are over there, not proper case series for any one of these. The learning curve is high, but once you are above the learning curve, then you can try with these complex cases as well. It is quite infrastructure dependent. You have to have specialized retractors, illumination, and magnifications for doing this. And that comparatively increases the cost of doing these surgeries at each level. But it is compensated to a certain extent by the short hospital stay as well. Now, I would like to end by saying there are two kinds of procedures, good to know and essential to know. Open TLIF is one of those procedure which is essential to know by each spine surgeon. Whether the same holds true in the future for MIS, it is for time to tell us. We have various senior lecturer speakers will be following. Hopefully, they'll share some light on this topic as well. Thank you.
Yeah, thank you, Amandeep, for this wonderful talk. Any questions from the panelists or the delegates? Okay. So, Arvind sir, you have any questions for him?
No, it was a wonderful talk.
Yeah.
Yeah.
So let's move to the next session by Dr. Arvind Kulkarni. Dr. Arvind Kulkarni is a spine surgeon and a master in MIS techniques. And over to Arvind sir.
This is not my talk. This is no. This is my video, which was supposed to be shown last week. So got mixed up.
It's MIS TLIF in challenging situation.
Yeah. So this is my week. This was supposed to be shown last week. This is a video. This will run for 20 minutes.
Tech team,
can you change that?
Hello, yes, sir.
So by the time you will ask some questions to Amandeep. Amandeep, can you tell some case scenario where you feel still MIS has a play and you prefer MIS MIS over open?
No, 90% of the cases are plain slip disc with either unilateral or bilateral. Can you hear me?
Yeah.
Unilateral or bilateral symptoms. So in unilateral cases, it is quite easy to do them with one-sided approach by using a tube. So in such cases, definitely MIS does hold true. If you ask me the difference between an MIS TLIF and an open TLIF, it is just the approach to the lamina or the facet. So instead of using central retractors, you are using an expandable retractor. Inside the basic crux of the surgery, that is facet excision and decompression and interbody fusion, it's same in both these techniques. So what all the basic cases you can do easily with open, I would suggest that we start with those in MIS techniques. Once you learn the knack of looking at tangentially and not vertically as in open, you get a hang of it, then slowly and steadily you can start doing the complex cases as well.
Okay. Yeah. Thank you, Amandeep.
If you don't get the video, I can share a screen and play it.
Tech team, you can allow Dr. Arvind Kulkarni to share his screen.
Yes, sir. Yes, sir.
Vama has something against Dr. Arvind. This is the second time it's happening to you.
Minimally invasive TLIF is a highly demanding surgery, especially in special situations such as these.
With
the patient populations that suffers from the indication for a missed TLIF and the
one beyond
that suffers from osteoporosis is the same. So hence these patients need to be evaluated thoroughly pre-operatively with bone mineral density. If immediate surgery is not indicated, it's a good idea and it gives an opportunity to initiate anti-osteoporotic treatment along with the primary conservative treatment for the condition. In case, even if immediate surgery is indicated, there is good evidence now that if you initiate anti-osteoporotic treatment perioperatively, especially with teriparatide, these patients have a high fusion rate and have reduced pedicle.
Hello, Dr. Arvind, what happened?
I think the video stopped playing. They were playing the video. No?
Is Dr. Arvind there?
Penetrated or dual diameter screws. Coming to rod insertion and cage placement,
avoids a reduction mechanism or a pivot mechanism.
Arvind sir, one request. Arvind sir, can you present a few minutes before?
Yeah, that's what I can start sharing from here.
Yeah.
Vama, please stop sharing the screen.
The same recording.
So switch off your video, sir, and let the
Can you see my screen?
Yes, sir, can.
Minimally invasive TLIF is a highly demanding surgery, especially in special situations such as these. The patient populations that suffers from the indication for a missed TLIF and the patient population that suffers from osteoporosis is the same. So hence these patients need to be evaluated thoroughly preoperatively with bone mineral density. If immediate surgery is not indicated, it's a good idea and it gives an opportunity to initiate anti-osteoporotic treatment along with the primary conservative treatment for the condition. In case, even if immediate surgery is indicated, there is good evidence now that if you initiate anti-osteoporotic treatment perioperatively, especially with teriparatide, these patients have a high fusion rate and have reduced pedicle screw loosening. Coming to specifics of pedicle screw fixation, be gentle at each and every step. There should be precise railroading. Use a blunt tipped guide wire and don't advance beyond the mid body in the lateral image to prevent it from getting into the abdomen. Tap the initial few turns only, and you don't use rescue techniques initially. These have to be kept as reserved techniques, and it is always a good idea to use special screws such as fenestrated or dual diameter screws. Now coming to rod insertion and cage placement, avoids a reduction mechanism or a pivot mechanism because that can loosen the screw and pull it out. So if still use, insert and tighten the inner screws only after the adequately contoured rod is fully seated in the tulips. And I would prefer a sextant mechanism for the same. And the cage that we use should be as long as possible in AP dimensions because we want to support the cortical rim. Now, CM guided disc space preparation is very important, especially in a highly inclined situation such as high-grade listhesis, because these patients have osteoporosis and your instruments, the shavers, curettes, etc., can get into the body if you're not in the right trajectory, as shown here. And again, avoid putting a very large size cage in terms of height by distracting the disc space with using the pedicle screw rod mechanism, because this will lead to cage subsidence as well as blowing of the screws. Now, invariably, most of our patients are obese. It's very important to advise to lose weight prior to surgery. Most of the times, it is not practical. And when these patients come up for surgery, adequate counseling is very, very important because these patients can have surgical as well as medical complications. It is a good idea to use navigation as well as a high-end C-arm with excellent penetration because the regular C-arms cannot penetrate these patient bodies. I would simulate a Jackson frame positioning with horizontal bolsters to keep the abdomen free, and that will reduce the posterior obesity. Again, these patients come in terms of having frontal obesity alone or posterior obesity alone or combination. When it is just frontal obesity, it is not a challenging situation because it's as good as operating on a regular patient with low BMI. And it is important that the entry point, to understand that the entry point laterally direct is directly proportional to the posterior obesity. If you are too medial, you can get into the canal. And my personal opinion is, these are the best patients to operate because your tube is held very well solidly by the surrounding soft tissues and you get a sense of accomplishment. And on the other hand, it's actually difficult to do missed relief in a thin patient because the tube keeps pulling out again and again. Now coming to high-grade listhesis, there are enough challenges here: reduction, fusion, as well as getting a good balance. So there are two types. One is the translatory type, and second is the angulatory type. In translatory type, I would use this particular method. I would put screws on the opposite side of the symptoms, put the tube on the side of the symptoms, loosen the disc space, get its height, and achieve reduction from the side where we have put the pedicle screws ahead of time, and then come back to the side of symptoms, cage, insert the cage. So these techniques, use of reduction plus putting a large cage, will help in effecting a good amount of reduction, such as seen in this particular. Ambulatory, it could be easy, as soon as you position the patient, you will get your reduction, or it could be difficult, such as this. This is a case of spondyloptosis. Now, in such a situation, all strategies are very important, including positioning, dome osteotomy, pedicle screw fixation. So, positioning and dome osteotomy are common to both an open and MIS techniques, but the real triumph with MIS is when you go the longest, widest screw in the best trajectory. Now, see, this is a summary of steps as to how this patient was treated. Positioning, dome osteotomy through the tube, insertion of cage, pedicle screws in the most strategic positioning, so that they have a firm hold, and then effect a reduction. So this is a follow-up after 6 months, which was published in 2 articles. When it comes to revision surgery, this is a perfectly made surgery, perfect recipe for a revision surgery, because you are avoiding the midline scar tissue. So you're going from the side to the
Sir, carry on, sir, please. Arvind, sir?
The tech team, you have muted the speaker. Vama tech team, you have muted the speaker.
The benefits of the patient are, it accompanies minimal trauma, it has better cosmesis, the recovery is faster, the pain medication requirements are less, and again, it adds elegance to the surgery. Of course, we have a learning curve. There are baby steps, and then we become a master. Thank you.
Thank you, Arvind, sir. Do you have any questions for him? Kshitish? Ayush, you have any questions for Arvind Kulkarni, sir?
Yeah, so no, it is. I also find that it is much easy to do a MIS in these cases than do open. Especially you have a high BMI, and even with listhesis, I don't think that is a big issue. Maybe, but case selection is important. Only few things like I always try to get a tricortical purchase with even the MIS cases in S1 with especially in high grade listhesis, and sometimes the trajectory is very challenging. Do you use navigation for that, or the CM is good enough? Dr.
CM is good enough. Yeah, so right from day one, I've been using a tricortical purchase. So that comes with practice. When you're using the navigation, because you can put as wide a screw as possible, and you can be pinpointing, putting it tricortical quite, medially, safely medially, and get a bite into the tricortical area. I find it more navigation more helpful in the other levels like L5, L4, where you want a very good purchase. You want to be safe and you want it to look dangerous. So you want to be bicortical, but not beyond the cortex. That is where navigation helps.
Yeah. Professor Khan, are you here, sir?
I am here.
Yes, sir. So you want to add something to this?
I mean, I don't think MIS TLIF is a one fit kind of solution for everything and everybody. I think in the United States, that we've seen an evolution of it. I think an MIS TLIF done correctly is a technically demanding procedure. I always tell them, and I tell my patients that, that good open surgery beats bad MIS surgery every day of the week. And I think, unfortunately, I see a lot of bad MIS surgery. MIS TLIF, we published our series. I think I'm 2,000 or 3,000 patients of MIS TLIFs into my career at this point. What I take for granted as maybe routine is not necessarily applicable to the population. I see a challenging learning curve. And so in the United States, I think for the most part, MIS TLIF is kind of maxed out or plateaued. I think people have gone to alternative strategies that are more reproducible, whether that be lateral, direct lateral, OLIF, anterior OLIF kind of combinations. So, I just always caution people on the advocacy of MIS TLIF for everybody. I see that there's a steep learning curve and some people overcome it and some people don't. I also think it's very humbling to obtain a CT scan, and we collect CT scans on all of our patients for academic purposes and publication. It's very humbling to think what you deem to be successful and then get a CT scan at 1 year, et cetera, and kind of track these patients long term. So I think we're still in our infancy of learning what is applicable to most people and not, but I do commend all the faculty members for their experience and sharing their kind of learning curves with the group.
Thank you, Dr. Professor Khan. Yeah, so we'll move on to our next talk. Dr. Gururaj, he's a spine surgeon in Indian Spine Injury Center, and he will be talking on tips and tricks to avoid complications in MIS TLIF. Yeah, over to go, Dr. Guru.
Thank you, Dheeraj and Bombay Spine Society for giving me this opportunity. Actually, I just got to know that somehow they have misplaced my recorded talk, so I'm going to do it live. Can you see my screen?
Yes, Guru, we can.
Yeah, okay. Thank you once again. We all know that the TLIF is one of the most common procedures which is done as a spine surgery procedure. And as the TLIF has advanced, it has become more and more minimally invasive. So for any surgery or a procedure to be successful, there are successful tips and tricks or successful steps to be followed. So a road to successful MIS TLIF involves many steps, beginning from the training because it has got a steep learning curve. And then for any procedure to be successful, you have to have a proper patient selection. Otherwise, you will go wrong, how much ever technically correct you are. And then preoperative planning is very, very important before you venture into any operation theater. And then gadgets are very, very important, especially when it comes to MIS TLIF, because you need particular set of instruments and equipments to perform a successful MIS TLIF. And then positioning is important. And then approach and exposure. Complications related to it can happen, and complications related to docking of the tube can happen, and complications related to decompression can happen, and end plate preparation complications can happen, and cage related complications can happen. So since the beginning in 1982, when the first TLIF was reported, and then in 2003, Foley's reported the first MIS TLIF to reduce the intraoperative paraspinal muscle injury. From there onwards, it has evolved, and that is why it has basically a training aspect to it. So you have to have a proper training to do any procedure properly. So undergo a proper training, you need to have a trained under a proper mentor. So if you are trained under proper mentor, most of the complications you can avoid in these common procedures. And the next thing is the most important factor in any procedure is patient selection. And then you need to properly plan them, especially MIS TLIF, because it's mainly image guided procedure. So you need to study your radiographs and imaging properly, like CT and MRI, because you are going to do these surgeries through a small window. So then you need to study your imaging properly before you plan surgery on these patients. And then you can study the CT or radiographs properly so that you don't put a bigger size screw in diameter and in length. And then you have to have a proper set of gadgets, basically at least basic sets like maybe all the instrumentation set, long-handed bayoneted sets, and then you have to have a tube, and then you have to have at least a loop with a good light source. Then you have to have a proper image intensifier. After that, if you are luxurious enough, you can have microscope, you can have O-arm, you can have a robotic arm, and you can have a high-speed burn. And then because the procedure is mainly image intensifier guided, so the visualization under CM becomes of paramount of importance. So in obese patients and in severely deformed spines, it becomes really difficult to visualize proper anatomy in a C-arm. And you have to always make sure that there is a end plate symmetry exists, but especially in wedge compressions, especially in old patients where you have some amount of asymmetric collapse of vertebral bodies. And especially again in junctional regions like maybe lumbosacral junction and in cervicothoracic junction, you have to be very careful. So when it comes to MIS TLIF, the pedicle screw insertion is one of the most important part of it. So to do that properly, you have to have a proper positioning of the patient where you see a true AP image and a true lateral image where your end plates are parallel and pedicles are really superimposed. And then the most common cause for failed back surgery in any spine surgery is a long level surgery. So to avoid that, you need to identify your levels of surgery properly. So those can be done according to your training. Maybe you can count it from downwards from the sacrum, or you can count it from above from C2 when you have a whole spine screening MRI or whole spine images. And then if at all, if you don't have them, you can count it from the lower down, or you can have a pre-operative image with the maybe needle inserted into the vertebral body. And then positioning becomes really important when it comes to MIS TLIF, because if you position in such a way, you will end up fixing the spine in kyphotic position, especially in lumbar spine. So you need to position in the proper way, because especially your positioning is going to give you correct amount of lordosis, what you want to achieve, because you are going to do it from only one side, you don't remove the other side facets. So implants have very limited role in achieving the lordosis when it comes to MIS TLIF. Then again, incisions, the plan is usually based on the AP fluoroscopy, especially for pedicle screws. Your usual incision is 5 millimeters lateral to the lateral border of the pedicle. You have to be very careful when it comes to obese patients, because you'll have to maybe take an incision more lateral as compared to normal patients. Otherwise, you will not be able to medialize your pedicle screws properly. The other incision, which is very important, is a deep fascia incision. If you don't take a generous deep fascial incision, and then when you drive your pedicle screw, if you drive the deep fascia along with your gadgets, so it will cause a severe pain in the post-operative period. Sometimes it can end up having compartment syndrome in these facial planes. So you have to have a proper facial incision to basically minimize the post-operative pain. The next is pedicle screw cannulation. The most dreaded complication which can happen is a medial violation or an inferior pedicle violation causing neurological deficits. So you have to be very sure, and you have to see, basically we have to see this axial image to put a proper pedicle screw, but we are limited by AP lateral views. So you have to have a clear three-dimensional visualization in your head before you start doing these procedures. So you have to be very careful, and you have to, one thing which is, you have to be sure that when you are at the medial border of the pedicle, you have to be already crossing the posterior wall of your vertebral body. Otherwise, if you are already crossing the medial border and if you are somewhere within the pedicle, that means that you are already violated the medial wall of the pedicle. So be careful in this step. And the next thing is guide pin related complications. Even though it looks very basically minor complications, they can lead on to major complications. Guide pin may perforate anteriorly and cause basically injury to the major vessels. So it can happen mainly in osteoporotic bones. If you have a clotted blood around the guide wires, when you tap along the guide wire can actually draw along the tap and perforate the anterior vertebral body. Or if you have a bent or a damaged guide wire, again you can drive the guide wire along with your tap. And you have to be again very careful. These guide wires can break if you don't put your pedicle screw or tap along the direction where you have put your guide wire. So, and the other complication which can happen and which prolongs your surgery time is guide wire back out along with your tap. So to prevent that, you always have to have a clamp, hold it when you drive it in or when you are taking it out, so that guide wire doesn't migrate anteriorly or it backs out. And if at all, if you don't drive your screws along the guide wire properly, they can break or they can bend, and it becomes really difficult to take out this guide wire. So if at all that happens, you might want to take the screw back. Along with that, the guide wire sometimes comes out. If at all it's broken, if you're not able to take it out, you can just leave it there. And the next thing is, if you don't measure your lengths properly, you can have very major anterior wall perforations with the pedicle screws. These can sometimes cause neurological deficits or severe post-operative radiculopathies. So you have to be very, very careful in measuring the length of these screws. When it comes to docking of the tube, it all depends where you dock, depends on what you want to do. Whether you want to just do decompression or whether you want to do a T-lift with decompression, or you are just aiming to achieve a fusion. If you're planning to just do a decompression, you will have to dock it more medially at the basically lamino-pars junction. And then if you're planning to do just a T-lift fusion procedure, you will dock it more laterally. And one thing you have to be careful is that you are muscly trying to push your tube laterally. The skin and in the deep fascia, little medial, which you really intend to do it, so that your tube doesn't get pushed backwards. And the other thing is top loading of the tube, because people who have done this procedure, they know that muscle creeping is a really irritating factor in this procedure. So if you don't top load it with your flexible arm on the tube, it tries to come back out, and then muscles creep in, and then your visualization becomes difficult. And then you can have rod related complications especially when you try to thread the rod in multiple screws. You can miss out one screw in between or one screw at the end. And before tightening and breaking of your extenders, if you don't make sure that you have already threaded into all the screws, then your fixation gets compromised. And then when you realize it at the end, then it becomes really, really messy to take out this rod and then put it back properly. So make sure in the image guidance or there are instruments with which you can make sure that the rod is really, really into the two lips of the screw. So in conclusion, the MIS T-lift needs meticulous pre-op planning, and adequate radiological visualization is must. And don't hesitate to open if you are in doubt. If your anatomical landmarks and if your visualization are not correlating, don't hesitate to open it. Anticipate complications always and be ready for salvage strategies. And especially beginners who are interested in doing these procedures, attend as many as possible cadaveric workshops, operate with experienced surgeons, talk to your mentors, and carefully select your patients for a successful T-lift. Thank you.
Thank you, Guru, for the great conclusion and the superb talk on this challenges in MIS T-lift and its mistakes. Professor Khan, I want to ask you, you just mentioned about the fading off of MIS T-lift in US and more of anterior surgeries are coming in. So can you tell me what's the common reason or the mistake is done? What's the common reason why it's fading off?
I don't think it's just unique to the United States. I think India will see it as well. I mean, I don't think that the United States is unique. I just think that we're a couple of years ahead in exposure to MIS procedures. But I give a whole lecture on the failures of MIS T-lift, and the most common failures are not the inability to complete the procedure. The most common failures are the failure in visualization, the inadequate annulotomy, the inadequate facet resection, which leads to a poor preparation of the end plates, which leads to undersized cage. And then, just the overall concept of an MIS T-lift in general. I mean, the way I do an MIS T-lift now is different than when I did an MIS T-lift 14 years ago. And I do a bilateral complete facetectomy, essentially a Smith-Peterson osteotomy. I do bilateral cages. I do compression across the graft to maximize lordosis. Otherwise, a T-lift by definition is a kyphosing event. So sagittal decompensation, inadequate end plate preparation, poor visualization, all those things are kind of coming to the forefront as we become more and more kind of critical. I mean, unfortunately or fortunately, in the United States, payers look at failure rates and they look at quality metrics and scores. And so all of these things are kind of challenging to reproduce sagittal alignment, to ensure a solid fusion, all these things. If you can't do it as a surgeon, you're getting docked by the payers. So I think that's why the shift is occurring. And then I think it'll occur across the world. I don't think it's just unique to the United States. I just think that the exposure has been here a little bit earlier.
Sir, thank you, sir. Sir, you mentioned about the facetectomy you do on the other side too. So you use the paramedian incision, a single incision on both the sides, or two incision on one side and single incision on the other side?
Yes, I do a bilateral complete vasectomy through an 18 millimeter non-expandable tube bilaterally. So bilateral paramedian incisions.
Okay, thank you, sir. So we'd like to invite our next speaker, Professor Karan. So it's an honor to have you, sir. Sir is a co-director in Minimally Invasive Spine Institute and a professor in Department of Orthopaedics. Sir is a founder and president in Minimally Invasive Spine Study Group and a professor in Midwest Orthopaedic Rush University, Chicago. Thank you, sir, for taking out time to come and talk here. Thank you very much. Over to Dr. Karan Singh.
Absolutely. It's always my pleasure to help participate, and there are many common friends that I have on the panel and people that I've met over the years. It's always a privilege to speak with such renowned surgeons and to give our perspective, at least my perspective and partial perspective from the United States. With that being said, I'm going to hopefully share my screen. And can everybody see my screen at this point?
No, sir. Tech team, we have a recorded talk of Professor Khan.
No, sir. Actually, sir will be doing it live.
Okay. So allow him to share. Sir, we can see the screen now.
You can see it?
Yes, sir.
Okay, so thank you. So I think I was asked to give a talk about transitioning to what we call outpatient spine surgery, or I believe in India it's called daycare surgery. The principles of the talk will remain the same. Essentially, I do always like to give a background about myself to give perspective on the transition to getting here. At this point, I think for those who know me, I'm about 16 years into my clinical practice. I transitioned to outpatient spinal surgery approximately 13 years ago, transitioned to minimally invasive surgery about 14 years ago. I'm about 6,000 minimally invasive surgeries into my career, and about 2,000 outpatient spinal surgeries done in my career at this point. I always encourage everyone to put up their financial disclosures. I have no disclosures as it relates to these talks, but I am a designer for a minimally invasive pedicle screw system for Zimmer Biomet and for a minimally invasive tubular system for Stryker K2M. None of those will maybe be mentioned in this talk, but I think it's always important to give that perspective. So as I mentioned, I transitioned to outpatient spine surgery approximately 13 years ago. Over 1,100 outpatient surgeries at this point in my career. I mentioned cervical, even though this is not cervically related, because the concepts of transitioning to an outpatient arena are still the same. Cervically, you can see we perform, at least I perform at this point, 3-level arthroplasty as an outpatient, as well as posterior cervical laminoplasty. And by outpatient in my state, in Illinois and Chicago, that is defined as the patient is discharged home the same day, not 23 hours later, but actually within 6 hours of the surgical procedure. As far as lumbar cases, we started with simple microscopic discectomies with and without tubular retractors. Then became multi-level laminectomies and largely based upon tubular retractors, percutaneous pedicle screw fixations. Now I do degenerative scoliosis cases in the ASC. The picture on the right is the first kind of the first case that we did in a lateral environment. So that was the first XLIF that we did. That was about 8 or 9 years ago. That was the team. And now we do 3-level lumbar front back scoliosis. I do MIS TLIF, as I mentioned before. Almost all my MIS TLIFs are bilateral complete facetectomies. I take iliac crest bone graft, and we do it for 2-level fusions as well as an outpatient. And now we're doing ALIFs, anterior fusions, L5S1, and we'll be transitioning to L45 and L5S1 shortly as an outpatient. So, looking at outpatient spine surgery, I think that you can break it down into 3 categories. It's all about risk stratification, and that is based upon patients. And what we've really learned is anesthesia standardization. I know there's a large talk and buzz about awake spinal surgery. If you look at the literature of it, it's very poor still. and it doesn't relate to 100% outpatient rates. So we've developed a multimodal analgesia program, which I'll talk about. As I mentioned previously, all of our cases, 100% are required to be discharged the same day within 6 hours after surgery. I think it's also essential in outpatient surgery to figure out preoperative and comorbidity screening. And one of the most important things that's probably often overlooked and underemphasized is patient education preoperatively. I think from a surgical standpoint, some of the most challenging things to do as a spine surgeon is to be introspective. Not everybody is capable or willing to do outpatient surgery and to alter their surgical technique. I have surgical partners, spine surgical partners, who are world famous and who don't perform any outpatient spine surgeries. That's no knock on their technique, but it does require an evolution. And I think that an important factor in transitioning to outpatient spinal surgery is defining the environment and the intraoperative control. And I'll talk about all three of these categories here. So patients and pre-surgical evaluation, we do a complete standardization of the anesthesiologist. So that's a paradigm shift. I use the same anesthesiologist for every single case of mine. At this point, 90% of my practice is what I do is an outpatient for the cases I mentioned previously. We have a single anesthesia medical director that standardizes the protocol, which I'll go over shortly. And that means that every single case that we do, it is the same anesthesiologist and the same delivery of medications preoperatively and postoperatively, as well as intraoperatively. And we use a defined multimodal analgesia program for each and every single patient. And the only thing that we vary the multimodal analgesia program, or the MMA protocol, as we call it, is based upon age as well as weight. So we do a very thorough preoperative screening. We make sure that these patients have only ASA 1 or 2 medical risk factors. Now we do only under 75. Before we started off, it was under 60 years of age, I should say. We do BMI up to 40. Before it was up to 30, but now we're very aggressive, and 40 is not a challenge at this point for our anesthesia team and the surgical staff. The only thing that is a big concern for us is sleep apnea, particularly in surgical cases involving the cervical spine. As you guys can understand, doing a multi-level cervical arthroplasty or laminoplasty on someone with sleep apnea may lead to a significant challenge. So we do preclude anyone with sleep apnea from the surgery center. And then we make sure that these patients have an appropriate family level of care and level of understanding so that they're educated about what to do the same day and the next day. In my state, in my city, I can't have admissions to the hospital. I can't have readmissions for pain control. I can't have readmissions for complications. Otherwise, we lose our license. So in all the cervical surgeries we've done, we've only had one hematoma that we caught in the recovery room that we addressed the same day. Otherwise, over the 1,100 cases, we have not had any readmissions for pain control. Otherwise, we get cited by the state or any complications from readmission as well. So this is the multimodal analgesia program that we developed in 2016. I developed in part with my anesthesia colleague, Dr. Kumar Bhuvanendran, who is a world-renowned pain specialist, as well as he's the chairman of anesthesia at Rush. This is one of the first to implement a defined pathway. It was based upon my partners who were pioneers in outpatient hip and knee replacements, and we kind of piggybacked off of their cycle and their protocols. Essentially, if you look at the protocol, I'm happy to distribute the protocol to anyone who actually wants it. It's published in Spine. We published several iterations of this over the last 5 years, I think over 40 or 50 papers on it. But you can see we actually give medications prior to the patient even hitting the recovery room. As soon as they check in, they're given a low-dose pregabalin, a muscle relaxant, as well as a narcotic beforehand. All of this leads to a complete reduction of narcotics intraoperatively. We use almost no, very, very low dose narcotic, maybe a little bit of fentanyl. We use intraoperative IV Tylenol, and we use a propofol induction. And I do a significant local blockade with bupivacaine and epinephrine. And then the day of surgery, patients are given either oxycodone, depending upon their tolerance, or hydrocodone. And I would say that we just published a paper, 90 or 88% of patients are off of narcotics within 2 weeks. 100% of patients are off of narcotics within 6 weeks. And around 60% of patients are off of all pain medications within the first 72 hours after surgery.
And I tell you, nothing makes a patient happier and more vested in their spine surgeon when they wake up from spine surgery and they don't have pain. They ultimately think that the surgery was an amazing success. And I think anesthesia has a phenomenal impact on the patient's perception of how good and the quality of the surgeon you may actually be. So some of the surgical issues, I go back to surgical awareness and introspection. You know, we don't use navigation in our surgery centers. It's too expensive. We don't use robots in our surgery centers. It's too expensive. We use standard fluoroscopy. That's we make sure that we do a pre-incision local anesthetic block and do anesthetic block at closure. I don't use expandable tubular retractors. I think they cause a lot of pain and discomfort. So we use 16 and 18 millimeter tubes for all our lumbar fusions. And I think we have complete hemostasis. We run all the patients normal or hypertensive intraoperatively to control for any bleeding. So we have no bleeding in the PACU. And it has to be surgical predictability. You have to be able to look at yourself and make sure that you can do a surgical procedure in a defined amount of time. The most surgeries that we've ever done, or at least I've ever done in a surgery center in one day, our record was 26. That included lumbar laminectomies, decompressions, cervical discectomies, and arthroplasty, and lumbar fusions. Typically in one day, we do 8 to 10 surgeries. This week, my anesthesia team was phenomenal. I did 4 cervical disc replacements and a revision MIS TLIF. We made incision at 7:45 a.m. and then we were done at noon. So within 4 hours, we'd completed all those procedures. But that's a true testament to the predictability as well as the anesthesia staff. The intubation, extubation is immediate upon completion of the closure, and the patients are stabilized in recovery. Intraoperatively, we make sure that we're balanced for duotomies and vascular injuries. We have all the vascular staff, equipment available in case of a vascular injury. We have not had any. We're approximately 200 lateral cases in. I told you, as I mentioned before, we do multi-level, at least I do multi-level degenerative scoliosis patients now in the surgery center. In the recovery room, we have a standard observation for cervical arthroplasty and fusions. We do 6-hour postoperative observation. That was based upon the cervical spine research study, which showed that almost all hematomas in the postoperative arena occur within the first 6 hours. We used to have the same protocol for the lumbar fusions, but we realized that that does not need to occur anymore. So we discharge our lumbar fusions approximately 2 to 4 hours after surgery. Every patient that is discharged has to be ambulating at least 100 feet by themselves. They have to urinate with a post-void residual less than 100 cc's, and they have to have a pain score less than 3 based upon oral narcotics with no sedation. We do a full neurological examination. I see the patients pre and post-operatively. They're given a full instruction sheet, and we have an effective staff transfer policy in case there are any issues. Every single patient gets a phone call early in the morning, the next morning, by my staff. We offer those patients to be seen in the office if they're having any difficulty. And I give every one of my patients my own personal cell phone number and email address in case they have any issues. It's surprising to me, it's amazing to my partners that I give this information out. And I have to tell you, over the 1,300 or so outpatient surgeries I've done, no one has ever abused my cell phone or my email. And in fact, they have pinged me only when there's a concern and anxiety, and I've addressed it very quickly, and helps prevent unnecessary workups in the emergency room or in the hospital. So it's been a godsend for my practice and my patients. In general, they're very respectful of that privacy. So, in the United States, the future of spinal healthcare is outpatient spinal surgery. Interestingly enough, the United States, the government just passed that if you perform a TLIF or a disc replacement or a lumbar laminectomy in the hospital, you are paid 15% less than if you perform it in an outpatient arena. So the government is pushing for outpatient surgery. It understands the costs are approximately half that of the hospital, that 90% of these patients that are being done in the hospital don't need to be. And so it's a heavy focus based upon just a cost containment model in the United States. And I really do believe at the end of the year, if you have to have a personal strategy in place for tomorrow, for the next 5 years, and from 10 years from now. And if you keep doing what you're doing today, then I don't believe you'll succeed in your medical practice. I think that an evolution is occurring, and I think these patients do phenomenally well if chosen correctly. And if you're self-critical about your own practice and ability to translate into an outpatient arena. At the end of the day, spine surgeons are now at the bottom of the food chain in the United States. We've learned that the control of the healthcare system is through the delivery of the healthcare. That is the surgical center and the outpatient arena. That is where surgeons can re-enable and gain control and access and battle large hospital and healthcare systems. And I think that in the United States, when we started 13 years ago, less than 1% of spine surgeries were done in the outpatient arena. And now currently in the United States, it's approximately 30%. So it's rapidly changing. My prediction is in the next 5 years, I think you'll see approximately 50 to 60% of spine surgeries done in the outpatient arena in the United States. The rapid shift is occurring just due to economic pressures and social pressures around us. At the end of the day, I want to thank you. It's always a privilege and an honor to give this lecture based upon our own personal experience. I always learn something from all the presenters that I've heard this morning, and I'm happy to answer any questions that the audience may have.
Thank you, Professor Karan, for this wonderful talk. This is a perfection that you can, or any spine surgeon can achieve by discharging the 90% of work on the same day after 6 hours. Any questions from the faculties? Dr. Arvind Kulkarni, Dr. Mihir Bappa, Kshitij, Ayush.
I have one question.
Yeah.
Thank you, Dr. Singh. It was a wonderful talk. So the medicines that you mentioned in your talk, the oxycodone, the hydrocodone, they are not really available in India. What we have is tramadol, we have morphine, we have fentanyl patch, we have buprenorphine patch as narcotics. But the Dilaudid and the oxycodone are not available in India. So is this protocol possible on tramadol or fentanyl or morphine? Because they have a lot of side effects.
Yeah, so, that is a challenge. I guess I'll just clarify one comment before I address this comment. We have 100% discharge rate in the outpatient arena, but I was saying that 90% of my practice is now outpatient. But going to your point, Dr. Chowdhury, it's an important point that you mentioned. Some people don't understand what multimodal means. Multimodal means that pain is not singular in its etiology, and it may be peripheral, it may be central, it may be local. And so understanding the reduction of pain from a cognitive standpoint, from a behavioral standpoint, from a physical standpoint involves a multi-faceted approach to it. So I always tell people it's not as simple as trading one medication out for another, because the way that hydrocodone works versus the way that tramadol works, the way that it changes the overall synergistic pathway. So while tramadol is a narcotic-based agonist, its receptor is slightly different than hydrocodone or oxycodone. And so, in India, there are challenges. At the end of the day, the substitution of one medication for another leads to a bunch and series of downstream effects. Like, we don't use morphine anymore. Morphine causes extreme amounts of urinary retention, causes sedation, causes first pass effects with nausea and vomiting. We don't use Dilaudid, we use fentanyl because of its short-acting nature. So to answer your question in a long way, the hydrocodone and oxycodone, when used properly, are phenomenal medications because of their slow-acting release and their narcotic agonist receptor activations. So their substitutions can lead to a downstream effect that's negative. Unfortunately, I don't think it's as simple as replacing them with some other medication. And the balance of this MMA protocol is based upon those medications. I would hope with the literature, which is very clear now, that I don't know, the Indian payers or whatever the policies are, would allow those medications, because the benefits for this are tremendous and the cost savings are extreme. I think it would be beneficial to society and to the surgeons alike. I think it would transform your surgical protocols dramatically.
And I have another question about NSAIDs and ketorolac. Are you using that?
So, I go back and forth on that. So I don't believe that the use of an anti-inflammatory in the perioperative period results in a non-union. So my concern with Toradol, ketorolac has been there's an increased rate of bleeding and bleeding in a contained space may lead to some postoperative hematoma and pain concerns. For that reason, we have not utilized Toradol in fusion cases. We do use selective Toradol in those patients who may be narcotic sensitive in decompressions and selectively in arthroplasty cases. But for the most part, we haven't. We used IV Tylenol. IV Tylenol is actually expensive. Now we use actually just oral Tylenol beforehand. And we take that medication before surgery. So the modification of the technique has occurred a little bit. But we try to use cost-effective medications. I'm not against the use of Toradol. We just haven't demonstrated its efficacy in our populations.
Yeah, can I ask you, Karan? I just wanted to know, see, for these long fusions, T2 to pelvis, usually what is the protocol in the US? How many days do you keep these patients?
So it's really surgeon dependent. It depends upon the intraoperative factors and variables, how much fluid was given, how much fluid was lost. I think you said T10 to pelvis. I have a partner who does T10 to pelvis, and typically those patients go home the next day or 48 hours after surgery. So, the longest day we typically have for a T10 to pelvis now, because the hospital monitors it, is around 3 to 4 days, with the most still going home the next day or the day after. I mean, there's some people who kind of keep them longer, but the push has been, where there's certain things that you can control that make a big difference. If you don't over-narcotize these patients, you don't get urinary retention. So you can mobilize them the next day. We have physical therapy that sees the patient at 7 a.m. They see them again at 1 p.m. the next day. So early mobilization. All those things lead to an earlier discharge. So even our inpatient populations have been accelerated as far as discharging them home to sooner.
One of the limiting factors in my practice with regards to these MIS cases, whether it is decompression, discectomy, or 1 or 2 level misclips, is about 20 to 30% of these they are retained because of urinary retention. They don't go home because of urinary retention, and there is no stepped on support to manage this. So what do you do? I mean, probably it is a universal thing, it is a universal phenomenon. What do you do?
So we actually looked at, I published this paper in Spine Journal in 2019. We called it POUR syndrome, postoperative urinary retention syndrome. And we looked at all the MIS cases. And we found that there's a couple things that the anesthesiologists were doing unintentionally so, and you may find this true in your practice. Anesthesiologists were using phenylephrine to maintain blood pressure. Phenylephrine causes sphincter constriction of the bladder. So they would get, when they were using phenylephrine, they would cause unintentional bladder constriction, and then patients couldn't void. So we removed phenylephrine from that. A secondary thing was that they were using a reversal agent for your muscle relaxant. So they would muscle relax all the patients, they use a long-acting muscle relaxant, and then they would reverse them. The reversal agent results in bladder atony. So they would get a atonic bladder that would not contract. So for our cases, my MIS TLIF cases and everything else, we give a short-acting muscle relaxant. We use succinylcholine. It lasts about 10 to 15 minutes. And I let all the twitches come back. So naturally, you don't really need muscle relaxation in MIS TLIF because you're using a tubular retractor. So there's no muscle fighting you. So we actually use no muscle relaxation, and we eliminated those two. I would challenge you to look back and ask your anesthesiologist if they're using reversal agents and if they're using an alpha agonist for blood pressure control. Those two things are significantly predictive of postoperative urinary retention. The third thing is the amount of intraoperative narcotic they're using. We use fentanyl, which is short acting, and we use less than 100 micrograms of fentanyl. And the reason we use low dose is because we give them an intermediate acting oral narcotic beforehand, the hydrocodone or the oxycodone. And so our intraoperative medication requirements are very low. So if you can eliminate and control those three things, you don't need awake spinal surgery. You don't need anything. Like I said, you get 100% discharge rate, which is what our discharge rate is the same day for outpatient cases. And those urinary retention, out of all the things that we had to manage over the last 10 years, was the hardest hurdle to overcome. And that is anesthesia dependent. And if you can eliminate those three factors, you will dramatically increase your rate of discharge.
Yeah. Can I ask a question, please? Guru Raj here.
Yes, Guru, please. Last question.
Dr. Khan, the rate of discharge really depends mainly on the anesthetic techniques and the pain management, or is it something different in the surgical techniques also?
Well, I think part of it is I said part of the talk was introspection as a surgeon. So I do think you have to evolve as a surgeon. So, I think I'm a big believer, and I give some lectures on the standardization of MIS spine techniques. So I do believe reproducibility as a surgeon and predictability as a surgeon is an essential role. And so once you can become predictable and reliable as a surgeon, then the implementation of standardized anesthetic techniques can make outpatient surgery much more realistic and feasible for you. Like I said before, in our state and in our city, I'm not allowed to have a patient stay longer than 6 hours. I'm not allowed to have a patient go to a hospital after their spine surgery. Otherwise, it counts against the center. So yeah, certain surgeons don't do many of the cases. Some do a little bit. So it does involve introspection as a spine surgeon. But if you can become standardized, then as I mentioned before, routinely doing 3-level cervical disc replacements, doing 3-level X-lift, 2-level MIS T-lift can be on the horizon as an outpatient, and patients do very well and are pain controlled that way.
Yeah. Thank you, Professor Kern, for this wonderful, enlightening talk. I thank all the faculties for this session, and we'll move on to our next session. I also request Professor Kern, if he has time, may I request him to stay back? We have a very good session on worst complications in spine surgery.
Absolutely, I'm still here.
Thank you, sir.
Good evening, all. As we move to the last session of this day, we have an exciting session on my worst complications. We all as surgeons want to learn from others' complications as well, and this is where we are here. We have the first speaker, Dr. Hitesh Modi. He is a chief consultant spine surgeon at Zydus Hospitals and is a PhD in spine surgery. May I invite him to start his presentation? Dr. Hitesh. Do we have Dr. Siddharth, who is next in line?
Yep, I'm around.
Yes, so we can start with your presentation.
Okay, I'll share my screen then.
Yes.
Well, thank you, friends. It's always good to be back with your friends and colleagues, senior colleagues. As you all know, I'm very much a Mumbai boy, now in Pennsylvania. So I'm going to talk about a case that I did about 2.5 years ago. And it was a cervical spine surgery, and was a challenging thing. Complications can really shake you up. They can change the way you practice. They can make you change a lot of things about what you do, what you don't do, and what you plan to do. So this was a case, a 60 years old lady who had persistent neck pain with radiculopathy. She also had early signs of myelopathy, and she was actually an ICU nurse and used to work in my hospital. She used to take care of a lot of my patients who, for some reason, used to go into the ICU for kind of long surgery. So she used to see some of my most challenging patients, and she had tried all the standard non-operative treatment, which seemed to be not helping her, and finally wanted to proceed with the surgery. So this is the MRI picture. As you can see, the first and most striking thing is not just the cervical stenosis, but the size of the neck fold. So if you go back, this patient was BMI 42. She had bad sleep apnea. She had a history of steroid use. So a lot of challenges in addition to the cervical stenosis, multi-level, most prominent at 5, 6, and 6, 7. There also seems to be a disc that seems to be going behind the C6 vertebral body. So a challenging presentation with cervical myeloradicalopathy. This is the T1 weighted image, the axial picture. You can see the disc behind the C6 body. So the C6-7 disc had migrated proximally and was sitting behind the C6 body. And this is the CAT scan picture. Doesn't look to be anything in terms of a major calcification, but the striking thing was that her vertebral bodies were pretty small. She was about 14 or less than 14 millimeter in length for the vertebral body. So she was someone who did not have a favorable anatomy, either in terms of her body habitus, her BMI, or even her bone anatomy. So in view of the various factors, the huge posterior neck folds, the deep neck, after a lot of discussion, it was decided to proceed with an anterior approach and then perhaps do a staged posterior surgery, depending on how things worked out. So the plan was to do a 4-5-5-6-6-7 discectomy, C6 corpectomy with percutaneous iliac crest bone graft, and then anterior cervical plating. And depending on what kind of construct I could achieve, how the stability was, I was hoping to decide about the posterior surgery. So role of posterior augmentation, you always have to think about whether it is a good strategy to do a single stage front and back and deal with the issues, especially the respiratory problems due to the airway edema, or try and do a staged procedure. And in view of her medical comorbidities like sleep apnea, the BMI, I just decided to kind of go a little slow and decided to stage the surgery. And the patient was very much insistent. She, as far as possible, was actually wanting to avoid a posterior surgery. And if it was needed, she wanted to wait it out a little bit before she could even look at that. So intraoperatively, it was a very challenging anatomy as well as visibility. I mean, you can see, you just can't visualize the cervical spine. She had big, broad shoulders, and even after taping and traction, it was not a very favorable anatomy. I could achieve a decent fixation and a construct. Of course, the screw hold was not the most ideal that we get. The exposure was difficult, the visibility was poor, the bone was osteopenic. I could just get 14 millimeter screws, which I was a little unhappy about. And because of the retrovertebral compression behind the C6 body, I had to do a complete C6 corpectomy. And then I was a little concerned about the length of the screws and the fixation because of the osteopenic bone. So this was the ultimate picture that I could achieve. Pretty satisfactory picture from what I can see. I had put in a peak corpectomy cage from C5 to C7, and patient actually did well after the surgery. She was discharged on day 2. She had some compliance with the use of the collar because of her neck anatomy. I think the collar used to just make her feel a little choked and used to feel tight, and it was very difficult to get a collar that could actually fit her or make her happy. So these were the post-operative x-rays. Seems to be a decent lateral picture, but on the AP view, the plate was a little tilted, and I was just not sure why this would happen. I mean, I have seen this happen, especially if your neck has been tilted during the surgery, and perhaps your intraoperative picture showed a straight plate, but later on you had a slight oblique tilt. But the plate was a little tilted, made me a little concerned, but we decided to keep her and kind of under close observation and let her go home. Again, the tilted plate for a follow-up visit. You can see the swimmer's view where things look to be okay. And I again discussed about the role of early posterior stabilization. The patient continued to be reluctant. Brace compliance was a problem. I explained her why we needed to go in from the posterior aspect because of the corpectomy, the long construct. her bones being osteopenic, and then the kind of fixation that I could achieve. And she was just not very sure whether she wanted to have the second surgery, and that too so soon. Unfortunately, when she came in for a 2-week visit, the plate appeared to be failing at the distal end. And you can see on the CAT scan that the C7 vertebral body has fractured, and the plate along with the cage and part of the C7 body has subluxed anteriorly. Thankfully, the patient was neurologically stable. She did have some increasing radiculopathy, but neurologically she was doing okay. These were the actual images, and you can see on the far right that the plate has pulled out, the distal plate has pulled out the anterior aspect of the C7 vertebral body, and the cage is completely kind of subluxed and into the anterior prevertebral space. So this was not a happy situation. These challenging situations always have to rise on a Friday afternoon. So I had to get this patient admitted. I put her in traction. I was just trying to formulate the strategy as to what was the best way out of this situation. And my options were to look at a early anterior surgery, maybe a single stage posterior surgery along with that, or maybe a early front kind of a anterior followed by a posterior surgery. Again, the medical comorbidities, the recent surgery was not a great issue to have when planning a front and back surgery. So I decided to kind of do a staged procedure again. The first stage was to do the revision surgery from the front, and then maybe in a day or two, depending on how things go, how her extubation or how her respiratory status was, to go and do the posterior fixation. I had to anticipate things like a scar tissue because she was almost 2.5 weeks out. Again, the kind of reconstruction, the kind of cage that I would need, this was going to be a long construct because I would have to do an additional level corpectomy. And then with her osteopenic bone, again, the fixation was going to be a challenge. I also thought about the use of halo, at least to kind of buy some time. But again, that was just something that I was considering. So I went ahead and did a staged anterior and posterior surgery. These are the pictures after the front and back surgery. I do not have the intraoperative pictures, but I had to do anterior C7 corpectomy in addition to the prior C6 corpectomy, put in a large expandable cage there with variable angle end plates. And then to augment the fusion, because this was an expandable cage, I actually had to create a nest of DBM allograft putty, kind of push it into the cage and create kind of a nest around it so that the voids around the cage were filled in, and I had a continuous kind of piece of bone going from the C5 to the to the T1 body. I also used some iliac crest bone graft to add to it so that that augmented the fusion. Again, the screws had to be 14 millimeters. It was not possible to put in larger screws, and the anterior approach was difficult because of the scar tissue. So I actually had to bring in an access surgeon to just be sure that I could separate the esophagus from the new scar tissue. Thankfully, it was not too bad, but something that I had to anticipate. And then in about 2 days, I did a posterior fusion. It was a long C3 to T2 construct. Posterior exposure was quite challenging because of the neck folds, and again, the visibility was not, radiographic visibility was an issue. I decorticated the facet joints, put in small pieces of infuse on the posterior aspect on the facet joints to augment the healing. Again, this is not a approved use of BMP because it is not, it is an off-label use in the posterior cervical spine, and then put in the allograft. So it was a major anterior posterior surgery over a 3-day period. The patient did well after the surgery. Her recovery was uneventful. She was more compliant with the brace, and she actually could go home a week after the readmission. This is the CAT scan picture. Looks pretty pretty decent, nice alignment. The expandable cage is spanning the entire defect, and the cervical alignment is also kind of neutralized, or in fact, I would say a little improved. And these are the X-ray pictures at 2 weeks when she came in for the staple removal. Again, everything is holding up in place. The cage is behaving. The posterior construct is behaving. These are the X-rays when she came in at 3 months. Again, holding up pretty good. I believe by this time she would have started healing, and she was completely symptom-free. The patient was quite happy at that stage and actually wanted to go back to work. I put her in a spinal bone stimulator so as to augment the healing. And at her last follow-up, she was holding quite steady with a pretty decent outcome and with no residual complaints. So I think that's about the case. I have some literature that I can review, but I was just hoping to open the case for discussion if we are agreeable to it.
Yeah. So with this, I'd like to invite all the esteemed panelists, Dr. Mihir Bapat sir, Dr. Arvind Kulkarni sir, Dr. Gururaj Sangarimat sir, Ayush and Saket. Let us brainstorm. So we have the first question from Dr. Dheeraj Sonawane. In retrospect, what has changed? Like, what would you have been doing to avoid this in the first place if you have a similar situation in future? Dr. Siddharth.
I think one of the option was to go from the posterior aspect, but again, her neck folds and having the risk of an infection is always challenging. I mean, when everything goes well, you are always kind of happy that perhaps, but posterior surgery again is a more kind of demanding surgery, especially when they have a very obese thing. Positioning can be challenging. But perhaps if it was to, I had to go from the front, I would have done an early posterior fixation, maybe the next day or the day after. That would have been the best solution after what I could experience.
Yes, Gautam sir. Yeah.
Yeah, Siddharth, very nice case. But if this is your worst case, then I congratulate you, because we've seen so much worse cases in our lifetimes that this to us would be something very ordinary. Anyway, so let us start with the first thing. Why did you do C4-5? There was absolutely no indication to do 4-5 over here. So let me ask you why you did C4-5 in the first instance. Then if there was a C6-7 disc which had partially migrated behind the vertebral body, all you needed to do was take a little bit of the vertebral body and go there. There was no need for a corpectomy. You made a big deal about 14 millimeter screws. Whether you put 14 or 16 millimeter screws, do you think it makes a huge difference to the fixation? So I find a lot of fallacies in your entire approach over here and what you have described over here. If when you went in back, the other thing is you talked about this obese patient. If there is an obese patient, what is the need to do minimally invasive surgery? Do a nice open first class exposure. Make sure you do a very good job out of the surgery. There is no reason. The anterior tilt of the plate which you described, that is routine. I rarely ever see cases where there is no anterior tilt of the plate. So I don't know what exactly were you giving us a message about. When you revise the patient, it makes no sense to go in again anteriorly first. You should have gone in posteriorly, stabilized the whole area if you wanted to, and then gone in anteriorly, because if you went in anteriorly, you fixed, already there was a failure there. If you did not get a good hold of your implant again, then you would have been in problems intraoperatively. Even if you are saying that she was so osteoporotic because of steroids, then even when turning the patient prone, the plate could have come off. So there are a lot of fallacies to this whole thing that you have presented. I'm not sure about this way. I think my approach to this would have been that I would have done a simple C6-7 discectomy with a little bit of partial sort of lower half corpectomy and a fusion with a nice bone graft and plate over there. Number two would be that I would have used a nice transverse incision, raise the platysma up and down long enough so that I get a nice exposure of the anterior cervical plate.
even if it is an obese patient, I don't see that as being a problem in an anterior cervical approach. You are very right when you talk about posterior cervical positioning exposure, but not with anterior cervical approach. And then having done that, if you were still, you should have been able to make out whether you will get a good fixation intraoperatively. If you are not satisfied with your anterior implant fixation, so anterior implants pulling out because she has not used a cervical collar makes no sense to me. We don't use cervical collars in anterior cervical spine surgery. So a lot of things don't match up in what you are saying. I appreciate you have done a fantastic case. It's a lovely presentation. But I think you were already expecting problems, because who otherwise does X-ray 1 week after surgery and then again 2 weeks after surgery when the patient has very little complaints. So a lot of critique to what you have done, but certainly appreciate the good result at the end. Thank you.
Thank you,
So
Dr.
can I chime in? This is Kern Singh from the US. So can I chime into the comments, and then I don't mean to cut anybody off, but Sid, could you go to the original X-ray? And first of all, you know what? It's always easy for everyone to play armchair quarterback and to criticize. So I applaud you for putting up the case. And it's always very challenging and humbling to put up your own complication. In the United States, we say everyone's blank stinks. So, you know, it's everyone has issues and cases. Would you mind putting up the original X-ray? And I do agree with Dr. Zaveri on a couple of points. Number one, I don't believe bracing has any effect on biomechanical outcomes, and bracing has kind of gone by the wayside. So I don't think that that's the case. Number two, short segment screw fixation, 14 millimeter screws. You know, there's ways around it. You can actually shorten the plate and angle the screws towards and make it like a diagonal screw. That would increase screw purchase and length. But I don't think that actually was the issue in this case. I also agree with Dr. Zaveri that even a C6-7 ACDF or a hemicorpectomy to get to the disc would have been kind of a more, I guess, a less morbid procedure. The reason I ask you to put up the X-rays, which unfortunately we don't have the X-rays, if you look at your X-ray films and even the postoperative films, the patient has a C2 positive tilt. They're positively balanced. If you look at it, it's a very flat cervical spine. And if you look at if you probably got a full length scoliosis film, you would look at this patient and see that they were actually positively tilted. And if you look at your construct, at the end of the day, it was already doomed for failure. It's not a construct of because osteoporosis and obesity. It's actually sagittal imbalance, and then placing a corpectomy by its definition is a non-lordosing event. It's a neutralizing event. You can't get lordosis out of it. So now what you've taken is a situation of positive sagittal imbalance. You put a long construct there, and then you've extended her in a neutral event. And if you look at your final postoperative X-rays, the C2 to T2, or C3 to T2, look at C2. It's 20 or 30 degrees positively tilted. She is going to tip over, because if you look at her neck from C2 to T2 or C3 to T2, she's almost zero. There's no lordosis. So she's going to sagittally decompensate. Going back at this, I think in these individuals, and this is kind of my closing point to what Dr. Zaveri was saying, and maybe I would say in a little bit different kind of manner, which is in patients that have more comorbidities and more challenges, I look for what is the smallest amount of surgery to rectify the problem. And in this individual, this person is not really suffering from what I believe is C4-5 mild stenosis. I actually think it's the retrovertebral disc herniation. And then you try what I would go is like the same thing, the ACDF at C6-7, and then start taking off the least amount of bone of C6 and working up to get to that disc herniation. You can usually fish it out. And if you end up with a hemicorpectomy, that's still just a glorified ACDF with the large cage. And you don't change your sagittal decompensation that way.
So good point.
My by the way, I went to Penn State. I love Penn State. I played tennis at Penn State. I see you're in State College, so
yeah.
I see that you're there. So we have common ties.
Go Lions!
Yes.
Any more comments from Dr. Kulkarni, Dr. Bapat sir? Or we move to the next case on MIS.
We have to allow him to respond. Now, he gets a chance to respond, I would think. You know, he got bashed for 10 minutes. He should respond.
So a couple of things. I think I actually planned a partial C6 corpectomy, and I was on the fence about the C4-5 discectomy. But somehow I made a decision to do a C4-5. My plan was to do like 5-6-6-7 and a partial C6 corpectomy. But as I did my partial C6 distal corpectomy, the disc that was sitting behind was just not amenable to be pulled out. It was fibrotic, it was adherent, and I had to kind of take out more and more bone. And at the end of it, I was left behind with a sliver of bone, which would not have been a good surface for a cage to sit. So I think a lot of things had to be done in a particular way, because intraoperatively it just led to a situation where I had to do things in a certain way. And then I can very well understand that I could have put in longer screws, but because of the inadequate visibility or poor visibility, it was just challenging to get your screws in a particular angle. So I had to go by what was most obviously evident. So yeah, I mean, there could have been a few things that could have been done. Again, to answer Dr. Zaveri's comment, it was not a less invasive approach. So I don't know where he picked up that this was a less invasive approach. And I think, I mean, a lot of these things had to be responded based on what were the intraoperative findings, and not just what someone would have done just looking at the X-rays and the images. I think the C4-5 not doing that, I think that was something maybe I should have maybe avoided, looking at the other comorbidities.
No, I think those are reasonable. I think that my point was, I don't think anyone here can criticize your intraoperative decision making. I would just challenge you to go back and look at the sagittal bounds on this patient. If you look at that C2 tilt on the last X-ray, she's neutral, she's positive on that. So I would just say that it was a recipe for for failure, I think, if you look at the original films.
I think I agree. Retrospectively looking at it, the sagittal alignment was.
Siddharth.
Yes.
Just one comment. As a surgeon, when you are faced with a circumstance like this, you take decisions, whatever you feel correct on table. I think that is what you've done. But the single most comment about an anterior fixation is that it is the quality of the bone. Whether you do 1-level corpectomy, 2-level corpectomies, everything will hold if the bone is solid. Because these are cancellous screws. They are not cortical screws. So they are just holding on to cancellous bone.
Yeah,
they can either migrate in the bone or the bone will fracture. So if you knew that this bone is osteoporotic and your hold is inadequate, a mandatory posterior surgery immediately was warranted, because otherwise this was the most likely outcome. This was almost like predictable, because probably you knew on table that the screws are not holding, and that is how you presented it. Because you kept on saying that she is obese, she is taking steroids. So if you knew that the screws are not good, whether it is short construct or long construct, you have to support it. And that is what you ended up doing finally.
Thank you, Mihir, for those comments. It was a very difficult case. I mean, I have a little bit disagreement with the difficulty level. I think everybody who has a complication, for them that's a worse complication, because that patient has put their trust in you. So no complication is small or worse. I think when we meant show your worst complication doesn't mean that you have to pick and choose. But there was a great learning from this case, and we must applaud Siddharth for showing a very good case. And it's very important point that we all overlook. Dr. Kern Singh brought about was about the sagittal balance, but we are really short of time. So let's go on with the next case.
Kshitij, just a small question. I mean, so this is nothing to do with the case. See, these guys with big necks, when you position them, they have this horizontal furrow which goes 1 inch down, and it gives me a heart attack. We had a similar patient this week where I was going to do posterior. It was OPLL, and his anterior neck was as bad. So, but between the two, the anterior was better. So I turned him around. The furrow was 1 inch down. It had filled with warts. And is there any practical solution? We used traction. We did everything that everyone does. Any practical, US, they have fat guys. What do you do?
Yeah, so we have BMIs I just did a BMI of 55 in a cervical spine. So I mean, that's a massive neck. You couldn't even see C2-3. You know, there's actually in the United States, you can get, and actually I'm sure you can get in India, but it's a simple carbon fiber attachment that we use. It goes over the head plate and it depresses the shoulder. And so you lock the patient in the patient, and then you can essentially, it's downward pressure on the shoulder, and it's much more effective than taping. And we put it on for our fluoro shot, and we put it on for patients when we place our instrumentation if you're using a lateral fluoro. And it's amazing, even on a BMI of 50, how much traction you can get with it. I'm happy to send people the link for the device.
Yeah,
It literally is only, I think, $1,000. You know, it's not expensive, and it is dramatic for the difference you can see in visualization. The reason I use it is because we do, you know, patients BMI 40, 50, 55, and I do arthroplasty, and seeing like C6, 7 or going down distal, it's a pain in the butt. So this device makes it very easy to do and to see down there.
Interesting.
So
we
we'll
now
move on
have,
to the next,
we have an interesting case of
we have
MIS.
3 more cases to go. I think we'll exhaust all the time.
So may I invite Dr. Hitesh Modi to share his screen and begin the talk?
Am I audible now?
Yes, sir.
Okay. Thank you very much to give me an opportunity. So this is basically a very simple case, but like I am sharing my feelings with this case in MIS. So no disclosures. This is my own case. As we know that if person is having a simple disc, MED or tubular retractor gives an excellent result. So I will just share one slide for the case and one video. This is a 43-year-old lady, came with left-sided L34 disc. With I decided to go ahead with MED, and during the surgery, like you can see this video, and then I will directly go to the panel. So this was actually happened, and this is the case. So this was like nightmare for me, and this has happened. As we all know that this is definitely a dural injury at L3 and L4. So severe dural injury with post-operative cauda equina syndrome. So directly I would like to go to the panel. There are basically 3 types of management: how to manage intraoperatively, second is how to avoid, and third, how to deal with these patients. So I would like to invite panel, Dr. Kulkarni, Dr. Zaveri, Dr. Bapat, all are expert in tubular retractor. So I think this is a good learning point, and what I have learned, I will share it later on. So I would like to invite first of all respected panel, sir.
Yeah, Hitesh, which burr do you use? Which one was this?
This was a cutting burr.
No, which company?
Medtronic.
No, yeah, what was the shape of the burr? Was it like the Rosenberg or the matchstick burr, or what kind of burr was it?
It was, I think, the 5 mm cutting burr, which is basically used for the bone cutting.
Was it the round one?
It was round. It was round one. Yeah.
Round one.
Yeah.
So I think the round one is very aggressive. Round one cuts in the front as well.
Agreed.
So I think those matchstick burrs are more. I don't know if they are more safer, but maybe depends on your practice and your learning over the time. But I find the round ones really aggressive.
And,
I recently got into the similar problem, although not in a tube case, but in a scoliosis case with a round burr.
Okay.
And I used to always use a matchstick head burr for working around the dural sac. But somehow, I recently changed the hospital and they didn't have it. And that was a tough problem with the burr.
Yeah, so I just add, I think that this was I would just add that this is a round burr phenomenon. I've never seen it, first of all, the video, I've never seen that before, but, fortunately we've never had the cauda equina syndrome from that, because we use a matchstick burr on purpose because it's a side cutting burr. I mean, the area of concern is the ventral tip of the burr that you can't see. And a round tip burr, 5 is a large burr, first of all, and then a round tip on top of it is a very aggressive cutting. So you may be cutting the side lateral recess, but you are thinning the dura. And so that's why we always try to go to a side cutting burr for that particular reason, so you can't push into it. I think that would be the most safest and straightforward solution to this problem.
Yeah, completely agree, sir. Dr. Zaveri, I think you would like to put some comment.
Can I say
but
something?
I have, but I think Mir wants to say something.
Please, sir.
No, I think see, let us be very frank. All of us have had our neural tears, and all of us have had neurodeficits. Maybe not Coda equina syndrome, but it's a type of a neurodeficit. Now, the problem here is that it's the way I think, Hitesh, we handle the burr, whether it is a matchstick burr or a rounded tip burr. We should know which is the cutting edge, and you have to protect the dura. That's how you manage it. Really, it just happens and it comes with time. You learn through your complications. So there's nothing how to manage. Like Kern said, you can use a side cutting burr, but the aim is to know where the tip of the burr is. Yeah. That is the foremost and the most important thing. And the second is, in this particular case, I think you have to just detach the burr, open the patient up fully, and just do a wide laminectomy, and then separate out that burr tip as gently as possible, reposit the dura, put a DuraGem foam for the rest.
Right.
So I'm sure you have done all that, but Coda equina syndrome now has to be managed. You just have to observe it and see how it recovers.
Yeah.
Can I make a point? One thing very critical to this kind of surgeries is, do we have the habit of giving the video, this one to the thumb pen drive to the patients, or the CD to the patients? If you have a habit of doing that, this patient, if the patient knows that someone else was operated and given a CD, they'll ask for this CD or pen drive. And medico-legally, I'm not sure whether there is onus on you that you have to give it to the patient. Medico-legally, you have to submit it to the patient. I don't know. That is very, very important, because when you do MIS, you always record it.
Yeah.
This doesn't fortunately happen with open cases.
Yeah. So I have given CD to the patient, and I have convinced it. I have managed it all for next 6 to 8 months. So let me share some of the points.
And second is, if you would have done it at alpha S1, the patient would have at least not got a foot drop.
Yeah, agree. So what actually happened in this case, the canal was slightly tight. So initially we used to thin out the lamina, and then we insert our caries and ronger. So in this particular case, the opening was very narrow, and that's why if you see the video, the lamina was already, the fenestration was done, and I thought slightly lateral part of the facet joint I should burr it out, and I was so confident, and then that mistake or complication happened. So I would like to share like your paper only, and you have mentioned all these things about dural tear in your case presentation. I have experiences of like 400 or more MISs along with decompression and fixation, and having had 9 dural tears, and I opened 2 cases and 1 case which I showed here. So basically, I want to highlight what are the commonest reasons for dural tear during MIS surgery. So first and foremost, I would like to share that overconfidence of a surgeon is the first cause. Then the instrumentation, skin entry, maybe wire, Carison burr or hook. Then the technique like medial to lateral, as we are discussing right now, or the use of the burr or handling of the burr. How do you cut the ligamentum flavum? If there is no attention given to the dentate ligament, that can also cause this kind of burr. And the important is case selection, too tight canal or revision cases. Then light magnification microscope if you are using with loop or maybe endoscopic vision, and the selection level like upper lumbar level. So if I discuss that the first complication like overconfidence is the main. So as a surgeon, when you have like 2 MEDs pending, one MIS TLIF is pending, and then you are making in hurry, and you want to go ahead with cases one by one, then these complications are very common. So like I would like to, after this case, I have learned that any case of MIS or any tubular retractor, I will treat all cases as my first case. I will not make any hurry. I will take the approach very patiently and go ahead. Then, so this is my first lesson, that treat every case as a first case, and principles of the any kind of surgical procedure should be followed. There is no ifs and buts. Second is, like rightly we have discussed about the cutting burr. It should not be used at any moment, any time. So from that onward, I am always using a diamond burr, whether it is taking long time or short time, I always use diamond burr. And whenever the canal is open, I am seeing the ligamentum flavum, no matter whatever happens, I will not use any kind of burr. And vision during the burr is very, very critical. If your finger or hand is coming inside the burr or inside the vision, then don't use burr, just use caries and ronger. So the second is like use of hook. Like whenever we do ligamentum flavum removal, I always use this kind of rounded shaped, rounded ball tip hook, and try to elevate the ligamentum flavum, and then gently use my caries and ronger and try to see whether I am actually pulling the dura or actually cutting the ligamentum flavum. So vision should always be there whenever we are taking bite. It should be from medial to lateral, not lateral to medial. And always cut ligamentum flavum. Do not pull it. If you see any dural movement, there may be attachment of dentate ligament or any other attachment, then leave it, isolate it first, and then go ahead. The second one, if I see some attachment or excessive dural movement while taking bite, then I always use the patty here. Like I can see, I have inserted patty and protected my dura, and then try to take cut. And I always go and take cut from medial to lateral side, even in TLIF case or even in discectomy case. So this is how, if dural tear is happened, then gel foam, Surgicel, fibrin glue, tissue patch, all the things should be available. If you are not able to manage it, then conversion to open is the best choice. These kind of micro instruments are also very, very helpful. And this is the video of the same patient that I opened up. Ultimately, I repaired the dura, I did all those things, and finally I did discectomy and completed the case. After that, this is intraoperative management. And after that, how to deal with the patient. I genuinely and frankly confessed to the patient that this has happened. I explained his relatives, patients, everything about bowel bladder injury complications. And I have seen patients frequently, like every week, every fortnightly, and I followed up her for at least 6 months. And by the end of 6 months, by grace of the God, I think she recovered 80 to 90% with some sensations around the perianal region. Otherwise, she could regain bladder and bowel functions. So this was the feeling of this case, and these are the literature which I would like to share. Thank you. Thanks a lot. And I would like to have opinion or any advices from the panel as well.
A very well presented case and very well managed. So any other thoughts or comments here before we move to the next case quickly?
Siddharth, did you use any Duracell? This is Siddharth. Did you use any Duracell or any sealant after the surgery?
After surgery, I have just used Surgicel. After the repair, I have used Surgicel and gel foam. That's it. I have not used, because the Valsalva maneuver was quite okay, and it did not show any dural leak.
Yeah, because sometimes the Duracell or some of the dural sealants can expand, and that can itself cause cardiac one, I like picture. So something to look into, but very nice, nicely done case.
Can we have the next video on? So we have Dr. Tushar Rathod, who is an associate professor of orthopedics and spine surgery at the GS Medical College and KM Hospital. He'll be sharing his case on lumbar fixation in a young male of tuberculosis. Host, please share the video.
Yes, I have pre-recorded talk. Please play the talk. I'm going to discuss a case of a tuberculosis of a spine in this my worst complication series. 19-year-old male patient presented to us with a significant deformity involving a lower lumbar spine. There were two discharging sinuses which were discharging a copious amount of pus. Patient was in a significant pain and was not even able to stand. Patient also complained of left pleural numbness. He was a diagnosed case of tuberculous pleural effusion and was taking AKT for last 6 months. On examination, there was hyposthesia involving L3, L4, and L5 dermatome, but rest of the neurology was normal. There was a bilateral hip flexion deformity due to a massive iliopsoas abscess, which we'll see on a subsequent MRI images. The pigtailing for the abscess was done, and the sample was sent for both culture and histopathology. Patient was given traction, which showed improvement in the flexion deformity over a period of 3 to 4 weeks. The sample turned out to be a drug-sensitive tuberculous organism, and the same AKT was started for the patient. After 1 month of AKT, the discharge reduced significantly. However, the sinuses were persistent. We gave a good preoperative optimization with the nutrition, traction, and medical management, which helped in improvement in the symptoms. This was his X-ray 2 months before the presentation at our institute, which showed a L2 and L3 spondylodiscitis. And at the time of presentation, he had a complete collapse of L2 vertebra and near total destruction of L3 vertebra, with a resultant kyphosis at that level. There was also increase in the destruction in the L4 and L5 and adjacent vertebral body, which was noted on a fresh X-ray. This is a standing image of the patient, which showed a significant kyphosis because of lumbar spinal deformity and a positive sagittal balance with a vertical sacrum. This is a CT scan, which showed a significant destruction of L2 vertebral body, that is near total destruction, and a partial destruction of L3, L4, and adjacent body. The L3 pedicles were intact, so we decided to cannulate them for a surgery. The L4 pedicle was partially destroyed, so was the left-sided L5 pedicle with adjacent body next to the pedicle. The MRI showed again a significant amount of L2, L3 spondylodiscitis with disc space destruction and epidural abscess component, which was probably leading to his paresthesia in the lower limb. The subsequent MRI showed again a similar L2, L3 spondylodiscitis, which had increased with a destruction to the adjacent vertebral body involving the L4 and L5. This is the left-sided prevertebral abscess, which you can appreciate in a sagittal reconstruction. And there were massive iliopsoas abscess, which were still persistent, which were almost occupying the girth of the abdomen. So the plan, as we decided, was because he was a young patient, we wanted to save the motion segment. We had only two options, either to fuse long and span across the lumbosacral junction, or end up at the L1 and end up fusing both from D12 to L5 vertebral body, or fuse short and correct the deformity and try fusing up to the L4 level and try to preserve L4, L5, and L5S1 motion segment. And we decided to do with a second plan and did a wishful thinking. This is the clinical image when we gave a position to the patient. There was a persistent deformity and discharging sinus. However, the discharge was significantly reduced. We opened up from the back. We did all the posterior release. We corrected the deformity, debrided and drained the abscess. And we did an instrumentation from the back involving both D12 and L1 vertebra proximal to deformity. L2 vertebra was reduced and we could get a good reasonably alignment between the L2 and L3 vertebra. We cannulated both sided L3 pedicles. However, we could cannulate only the right side L4 pedicle, and left side L4 pedicle was completely destroyed. We did not have hole. Even the post-op X-ray showed a partial destruction of the L4 pedicle on the right side as well. The patient, the post-operative course was uneventful. The pain reduced significantly. Patient was upright, had an upright posture again. We gave a blessing and AKT was continued and patient was discharged uneventfully. At the end of 3 weeks after discharge, the patient came back with again implant prominence involving the back, and to our expectation, the whole foundation had been pulled out from the downside. This is his standard view, and again the patient had a positive cerebral balance because of the kyphosis. So in retrospect, the mistakes that we did and that we reviewed was over-reliance on a pedicle screw in already compromised pedicles due to the disease process. We expected that there would be a concentric collapse which would be inherently stable, but in contrast, thoracic spine, where there is additional rigidity which is provided by a thoracic cage, it is not so the case in a lumbar spine, which is highly mobile and is put to a lot of stresses. And brace obviously cannot compensate for a poor fixation, and compliance of patient in such cases is always questionable when they get a significant pain relief and improvement in the surgical posture. So now the plan, because the patient had both pulled out his L3 and L4 pedicle screw, we wanted to span across. But as we discussed, even the left side L5 pedicle was also destroyed. So we decided to settle across the L5 S1 junction and fuse longer. And you take a help of both S2 LR iliac screw, which will provide a strong pelvic foundation. And same plan was executed. We decided to go one level above as well to D11 vertebral body, and we did a both-sided S2 LR iliac screw as well as S1 pedicle screw. We did not do any pedicle fixation or compromise L4 pedicle. We could get a reasonably well alignment. This is a standing photograph at the end of suture removal, where you can see the sagittal balance has been restored. This is a post-operative 3D CT reconstruction, which shows a significant destruction of the lumbar spine. And 6 months following the surgery, the patient had followed up. We showed a good consolidation between the L2 and L3 body. A patient had no complaint and had gained the weight. And the recent follow-up, which is 11 months, showed a considerable gain in the weight by the patient. There are no fresh complaints, no pain, and patient is employed. He could not come, and so I have no X-rays to show, but there are no fresh complaints for the patient. Both scar and sinuses have healed nicely. So in conclusion, though one may try to save the motion segments in the spine, it should not outweigh the need for the adequacy of the fixation. And in a spinal TB, often the pedicles are involved, so the purchase of the screw is inadequate. And when in doubt, it is always wiser to extend to the adjacent level and not to worry about the motion segment. Thank you for your patience.
A nice case. So do we have Dr. Guru here to comment?
So definitely these multiple bony involvements with partial destruction in tuberculosis are really complicated. Whatever you do, you end up having failures. So what we typically do these days is like, until unless there is a neurology, it's always better to just drain a pus and give anti-tubercular treatment and wait till the bone consolidates a bit. Even though if the deformity increases a bit, it doesn't matter. Until unless there is no neurology, it's better to wait. Otherwise, you will have to do these multiple surgeries, because definitely we know that as the tuberculosis heals, there is some bony collapses which is going to happen. And if you don't have a good pedicle screw, and at least if you have a good 2 pedicle screws above, 2 pedicle screws below, which are in a normal bone, then you are bound to have failures in fixation. And the other thing which I think I had put up a case in ASSI Connect at a cervicothoracic junction, where we just waited. We didn't do anything anteriorly or nothing, just went ahead and fixed it in whatever position it was, just not to allow the kyphotic deformity to progress. And then once the tuberculosis treatment starts acting and the bone consolidates, you can come back and try to correct the deformity so that your pedicle screws can hold and actually basically prevent the failure. So that's what
I agree with Guru. He has exactly pointed out the important thing. And even in these cases, we waited for like around 1.5 months before going instrumenting. But again, in a Cox, you get a lot of pedicles which are destroyed, as he rightly pointed out. And going 2 or 3 levels beyond, we thought we could save the motion segment, which was kind of a wishful thinking, which backfired. But yes, if you have a doubt in a purchase, which I thought I had a good purchase on a table, but it was a significant longer lever arm. So probably that's the reason that the screw pulled out. And there was also, as important, 2-level fixation is always required, and one should not play with that.
Dr. Mihir, do you have any comments about this case?
I think I think everything has been really covered, because if you see the first case and this case, it's almost on the same principles. That means that if you want to fix, you have to have a solid bone. If you want to fix short, you have to have an extremely strong bone. If you don't have it, then it is better to err on a longer fixation. That's the principle of an osteoporotic bone. That means you always fix long, you don't fix short. And the second thing is, if you really want to reconstruct, think of an anterior stability of some sort. That means that you can't leave an anteriorly destroyed body on a posterior construct. So that also amounts to a lot of strain on the implants and resulting in implant failures, even in longer constructs. So anterior stability has to be looked at. So, well, if you ask me, this patient would have ended up with a slightly longer construct to do with.
Yeah, even the drug resistance matters. Sometimes, these patients are frail and they are not really in very good health. It's probably maybe a judgment error on your part to do that in the beginning, hoping that you would get away with a smaller surgery considering the patient's health, but you compromise on those things, and patient eventually ended up having what should have been the first one, kind of a thing.
Yes, Gautam.
Tushar, you had a golden opportunity when you had bilateral psoas abscesses. You had a golden opportunity to go anteriorly. So my approach here would have been a posterior stabilization with going anteriorly, draining that abscess, going into the diseased area and putting a nice strut graft. Then your posterior fixation might have worked, because then you would have provided stability on table. Here the problem was your implant was doing too much. But having said that, I think a fantastic reconstruction subsequently. Did you find that there was because in the last X-ray that you had shown, the pelvis appeared retroverted, the sacral slope was very low. Did you think that there was still a little bit of flat back and a flat pelvis, retroverted pelvis?
Yeah, there is the sacral slope we could not restore to like almost 40 degree. I agree with your finding, but it is still kind of on a lesser side, and we have some retropelvic. But again, since there was a lot of destruction, I could not play much with the instrumentation in that part, and I wanted to create a strong foundation this time. So I had used the S2 LR relax screw as well.
I think you didn't have any option. That was the thing to do.
Yeah.
So we'll move on to the last case for the day.
Dr. Ajot Raut, who will be presenting his case on a similar cervical spine TB and multiple failures. Can I Dr. Sai to share his screen?
Hello, good evening, everyone. I would quickly show you the case because of the time constraint. So going to the history part, a patient, a 24-year-old male, had come to us with neck pain since 1 month. He had bilateral lower limb radicular pain. He had weakness bilateral upper limb, and he had no myelopathy signs. His gait was normal. On examination, neurology was shoulder flexion, abduction, extension, and elbow flexion was 1/5. So we went ahead and did an MRI. The MRI was done, and it showed a epidural abscess, which was mostly foraminal, and there was no bony collapse. So when we saw this patient, there was no upper motor neuron signs involved. These were the sagittal images of the patient, and these were the axial cuts of the patients, where we saw mostly there is the cord was not compromised, but the foramens were involved. So how to go about this case? I will quickly ask everyone that how would we do a biopsy? Do we go aggressively? Dr. Ankit sir.
I mean, you try as much as possible to get a biopsy if it is feasible. So, what did the radiologist say? Can you digital images?
Yeah. So this one.
Yeah. Sometimes it's hard to do a biopsy there,
Correct, sir.
It depends on the radiologist, if somebody is confident, then maybe you can.
So the same way we went ahead and we asked the radiologist to do a CT guided biopsy for the patient. But CT guided biopsy turned out negative for all these tests: culture sensitivity, BMJT, gene expert, LP, and histopathology. So we started patient on empirical AKT, and patient was followed up. Now, 1 month post AKT, we again did a MRI of the patient. As patient pain was getting better, the abscess started resolving, but we saw bony involvement now. We saw the mechanical failure. C3 body was fractured. So we decided to give him a traction and brace for the patient. So this was the MRI picture 1 month post AKT. And these were the axial images. Again, 3 months down the line, when the AKT was started, we again saw that the abscess was resolving, but again we saw that the C3 was collapsing. And at this stage of point of time, the patient came to us with complaints of neck pain, bilateral radiculopathy again. So how do we go about this case, sir? Here, after 3 months of post AKT, where we see abscess healing, but the collapse is increasing.
Did he have any UMN signs or gait imbalance apart from the radicular?
Now, after 3 months, he had hyperreflexia. Other than that, no gait imbalance or anything.
Me, sir. What will you be doing at this juncture?
Sorry. When you see what happens in tuberculosis is that finally there's going to be an autofusion between C2, C3, and C4. So the question is whether you really want to correct that C2 to C4 kyphosis and give it an better radiological picture, because you want to correct that Schwann neck deformity that is developing in the upper cervical spine. Really believing that it is going to end up with any kind of terrible paralysis or terrible radicular pain is not possible now, because the disease is responding, the spine is stable, the posterior elements are stable. So naturally, if it heals, it's going to heal with kyphosis. If you want to correct, you correct it anteriorly and posteriorly. You stabilize it posteriorly because the strength of the C4 body is circumspect.
Okay. So if we go surgically, so we do anterior posterior both.
Yeah, of course.
So we decided to operate upon this patient, and when we did a C3 corpectomy with the anterior mesh cage and a plate, and posteriorly we went and did a lateral mass in C2, C4, and C5 levels, and biopsy was done. Open biopsy was done at this stage, and we gave a patient post-operatively a cervical extension brace. So this is what everybody would have done. Or
what was the biopsy report? Biopsy report.
First time, sir, CT guided biopsy report was negative. Second time, intraoperatively open biopsy was done. That was also negative for all the tests.
So it was a responding tuberculosis. So we are confirmed on that.
Histopathology also was
not showing anything.
Histopathology was what?
Nothing suggestive of nothing, no COX, anything. And but
so it was not malignancy or something like that.
No.
It should have said something chronic inflammatory disease or fibrotic tissue, something.
Yeah, it showed inflammatory, chronic inflammatory changes.
Which means it is working. Then that's what you can say about it.
Yes, but sir, because when we did posterior.
See, I think, like I said, the strength of your C4 body is circumspect, and you can already see the spikes of your cages sinking into the end plate. So it is always good that you have stabilized this. Otherwise, pure anterior would mean an implant failure. And let's hope that this sort of stays and helps the patient.
Correct. Posterior laminectomy was also done. And we followed up on this patient again post-operatively 2 months when the surgery was done. And this was the X-ray picture of the patient. As you said, we did posteriorly, but unfortunately, the implant started failing anteriorly.
Wait. The error here is doing a posterior laminectomy. There is no need to do a posterior laminectomy because the good fusion is over the lamina in this case. Now, if you go back to your MRIs, your lateral masses are destroyed. If you go back to your MRIs, your lateral masses are destroyed. You can almost see the abscess coming around the spinal cord. Your lateral masses are destroyed. So your posterior connection with a significant anterior destruction should not be removed. So I think the only way this implant can fail is if you do a laminectomy.
Correct.
because this surgery was to restore the anatomy of the spine. It was not for decompression.
Correct, sir. So when
I agree. Yeah.
So now, sir, what would we do with such cases? How do we go about it now? Should we leave the implant? Should we wait and watch, or should we just try to give a traction or brace for the patient?
I think you
need
should get
CT
a
scan right now.
Get a CT scan, see what it is. I mean, I would be hesitant to go back in the
to analyze every what is happening.
Yeah. I mean, if you
So this
can
was-
salvage this all from the back, it would be better.
So this was the MRI done, sir, post-operative 3 months later. When the implant started failing, we did an MRI, and this is the MRI picture of the patient. Again, we saw that the abscess and everything is resolving, but the collapse is still happening.
No, but now new vertebral bodies are showing marrow changes.
Yes,
They're
C5.
not- So that is that infection that is spreading, or I mean, that was not there before.
Correct. And the second biopsy has also shown all the reports negative. So we also thought of changing the medical management. Do we revise this patient or just put on traction and brace? So these were the options available in front of us. This was the intraoperative picture after positioning and traction, which was done second time when we took him for OT. This was the intraop picture after positioning and traction. So what we did was we again went back and we changed the C4. We extended posteriorly construct till C6 till C7, and we revised the C4 screws. Anteriorly, C5 corpectomy was done and a mesh cage was applied. The screws were passed through the mesh cage, and we also started patient on the second line AKT drug. So, I mean, comments on the.
No, I don't know why you have done this. Because
I also don't agree with your execution.
Because why you have done this? Because you have put the second mesh cage on a fractured body.
Correct.
And really there's no hole to the distal end of that cage also. That flimsy implant, I don't know whether it can really prevent the cage from going out. See, I think between a plate and a cage, a backed out mesh cage can really tear your visceral structures anteriorly. So you have to be very, very careful that your cage is very, very solid.
Correct.
Yeah, and also the reason why the top end is not failing is because that's a C2 pedicle screw, and your
Yes.
lower end is all lateral mass screws. You need
Correct.
a pedicle screw somewhere, because you know that the lateral mass don't have much of a hold.
What
To
else
hold
could
the-
have we done, sir? With after this X-ray, what else could have we done if we would have decided to operate him?
No, but then Saijot, before that, actually, as I asked you, CT, once the implants are failing, we need to see whether C2 pedicles are also holding, or is there any kind of loosening there. You go ahead and do this and then come back again when the upper construct fails.
They must have done a CT for sure. I mean, why?
No, I think putting a pedicle screw with a disease that is extending into the disease into the distal bodies is a little dangerous, because there is a disease process which is still eating up the bodies distally, and we are still not sure what's happening to the medical part of the management.
Correct.
Okay, so I think what should have been really done is, if you want to reconstruct this, your primary aim is again to get a tissue diagnosis. Have you tried that?
So third time also we tried. We got a biopsy sample, sir. Third time also the sample was sent to Hinduja. Again, everything turned out to be negative.
So if it's a disappearing bone disease, please don't operate. There's nothing you can do. The bones will disappear.
Do is put in enough implant to overwhelm it until that disease heals. Means by doing that levels more, I mean, you'll have to really get very good pedicle purchase down. And if that C2 is loosening, then you'll have to go to the occiput. Maybe not fuse it, but hold on to it temporarily. You can do an implant exit later. But if things are collapsing like that, and you don't have as Dr. Bapat said, that if you don't have a medical control of this disease.
Any roll-off, sir? Second line drug treatment, AKT?
See, you can ask that to the infectious disease, but really
We have discussed.
everything is empirical. That means that this is a clinically resistant COX, but without a diagnosis.
Correct.
That means,
And your last screw is in C7, right?
Just a minute, Sajo. Did you send bacterial cultures?
Yes, sir. Culture sensitivity, bacterial, aerobic, anaerobic, fungal, all three were sent.
Okay.
Is your last
So,
screw is
sir,
in C7?
yes, sir.
So then why not pedicle there? Why lateral mass again?
Correct. So, sir, this is the post-operative for second after surgery, second month also patient had followed up to us, which was 2 days back now, and this is the X-ray which was 2 days back. He's still there with us following up, and we really don't know what to do now. And we have been started him on traction bracing and medical second line TB drugs. We have discussed with the infectious people. Everything is done, but we still don't have answers to this.
That cage is really dangerous.
no, I think the first is to put him in a halo and protect his viscera, because the C2, if I can see, the C2 end plates are also going off. That cage, I don't know what is happening to the C2 above that, because that cage above, it's still holding on to the C2, but I don't know how long. The second implant is looking extremely dangerous, where you have
extremely dangerous.
No, but Mihir, it's not very easy to remove these implants now.
Yeah.
So
It's not going to be.
No, see, Kshitij, easy or not, if it is going to endanger the esophagus and the trachea, you still have to have an ENT surgeon or whatever surgeon you have with you. Let him expose the whole implant for you. You have to have help on this, because you have to keep a close watch.
Means get rid of the implant, put a fibula there, and put the patient in a halo.
No, get rid of the implant, put the patient in a halo, and watch him. See, you cannot keep this implant.
And put a fibula there, no, from C2 down to.
No, the thing is that there is no end plate below, so you have to go down to the normal end plate.
You have to go down, yeah.
So go down to the, but again, an unsupported fibula.
Yeah,
is
but
not a very strong construct.
Patient in halo after that.
Yeah, so put the patient in halo.
3 months.
Finally, you require a diagnosis.
Without that, everything is in a problem.
Whatever you hear closely, even the posterior elements like the lateral mass also are disappearing. So, what is happening here really? Without a tissue diagnosis, how would a fibula with a good plate and a good halo will hold? And for how long?
At least you should show us the CT scan. You have not shown a CT scan so far.
It's not a malignancy, right? It's not a lymphoma or a tumor like that, right?
No, sir.
Now you should get a CT scan for sure.
Sure.
Because if you see, there's no lateral mass on the right side or left side, rather whatever side that is.
No, there's no bone there behind the cage, above the cage, behind the area.
No, your lateral mass screws are floating in the middle. Where's the bone around the lateral mass in what, C4, C5? There's no bone. Your lateral mass screws are all floating. Your fixation is in C2 and C7. In between, there's nothing.
It's a tough call. I think the diagnosis is a little in doubt in this. What this is.
Yes, sir. We are still following up with the patient.
CT back again.
Have you worked up this patient from the endocrine and all these points of view?
Not yet, sir. Only infectious people we have spoken to.
No, is it something
the patient
else? Are we missing the boat completely?
Correct, sir.
It's not tuberculosis. Is what sir is saying. It's something else only going on.
Because now you have given primary AKT for so many months, and the bone is rapidly disappearing.
Saijut, can I see the last MRI again?
It looks more like disappearing bone disease or some of those variants where something much more aggressive.
Yes, it's something else.
Look at that MRI. It is going way down. It is going behind C7 now. Your C7 is going to pull off. You put him in a halo.
Correct, sir.
You see that epidural cuff is extending to C7. Everything is going to disappear there in no time.
Okay, sir. Thank you so much, sir, for feedback.
Thank
And
you. Do let us know what happens later.
sure, sir, sure.
Yeah, tough case.
Tough problem, Bapre.
Thank you so much.
Thank you very much, and thank you, Ankit, for moderating this session. It was a very difficult session, actually. A lot of heated discussion, but it takes a lot of brave efforts to show your complication, which makes all of us wiser, actually. And it doesn't matter whether you are a young surgeon or an old surgeon. I have learned a lot from my juniors as well. So, I mean, Siddharth is no junior, he's my colleague, but we all have these complications which kind of are very depressing, but we bounce back and learn and hope that we can do the best for our patients the next time. So thank you all the speakers for preparing these cases, especially Dr. Siddharth for staying back. I know it's a early Saturday morning for you there in the United States. So with that, we'll end this. And unfortunately, the next session was a very interesting interview with Olympic medalist Mirabai Chanu, but because of scheduling conflicts with her, we were not able to have this live interview with her. So if we have some time, she has sent a message to all the Bombay Spine Society members. As you all know, she recently won an Olympic silver medal, and if the tech team can play her message for us.
Yeah, Kshitij, we don't have just one. We actually have three messages from
Yes,
three different. So we will be starting with Mr. Viren Raskina, who sent us a message. He's our gold medal winner in Olympics. He's the former Indian hockey captain, and we'll start with his message first. So can you play his message, please?
Hi everybody, my name is Viren Raskina. I'm the former India hockey captain, Olympian and Arjuna awardee, and currently CEO of not-for-profit organization Olympic Gold Quest. OGQ was started by two of our sports legends, Geet Sethi and Prakash Padukone, with a very sharp mission to help Indian athletes win Olympic gold medals. I'm very happy and proud to say that at the last three Olympics at London 2012, Rio 2016 and Tokyo 2020, India has won a total of 15 Olympic medals. And the training of 9 out of those 15 Olympic medal winners was supported by OGQ. And at the recent Paralympics in Tokyo 2020, India won a total of 19 medals, and the training of 10 of those 19 medal winners was supported by OGQ. I'm so happy to say that our doctors, especially our orthopedic and spine surgeons like you, come forward selflessly in support of athletes anytime they are called upon to do so. Orthopedic spine surgeons have been an integral part of the OGQ story, and I'm sure this partnership will help us get many, many more medals for India at the Olympics. Thank you once again, and my best wishes to each and every one of you, and for the Bombay Spine Society Conference 2021.
Hi everyone, नमस्ते। मुंबई की स्पाइन सर्जन के साथ बातचीत करके मुझे बहुत खुशी हो रही है। टोक्यो 2020 ओलंपिक में मेरा मेडल के लिए आप सभी की शुभकामनाओं के लिए बहुत धन्यवाद। लेकिन ये ऐसा अचीव जो मैंने सोचा था कि कभी भी संभव नहीं होगा जब 2018 में मेरा लंबर डिस्क इंजरी हो गया था। दिल से सबको थैंक यू। आप सबको मेरी शुभकामनाएं फॉर आवर सक्सेस मुंबई स्पाइन।
It's a pleasure to be with you on the occasion of annual conference of the Mumbai Spine Society. I would like to congratulate you and the entire medical community for being so helpful and taking such keen interest in athlete rehabilitation and sports injuries. Many years ago, we could have never dreamed that Indian athlete will sign out across the world. Least of all for the Lady India to be a 6-time world boxing champion. This would clearly not have been possible without the enormous support we get from the medical community. Thank you and best wishes for an excellent conference.
Great. So in order to save time, we have run all three messages together. The first one, as we discussed, was from our former Indian gold medal winning captain. The next message was from Mirabai Chanu, who's our Olympic weightlifting silver medalist. And the last message was from Mary Com, who is a five-time world boxing champion and Olympic bronze medalist. Uh, now, Kshitij, are you there? We cannot leave you behind. You've been there all throughout this whole day. You need to be here. I also want to request. Yeah, you want to say something?
No, go ahead.
I want to request all our members here, Dr. Harshad, Dheeraj, Siddharth, Guru, Hitesh, everyone to Bhavin, Ranjit, Agnivesh, all of you to switch on your cameras as and Amir, don't run away. As we have our a great stand-up comic who will be coming on, and I don't want to be the only one to be made fun of here. So I want to invite Siddharth Dudeja to come over and have a show with us. Thank you for coming over. It was on a little short notice that he agreed from his tight schedule. In fact, he has just come back half an hour back from a show and he just ran straight into his bedroom to have this show with us. And I'm very happy to see that you have combed your hair and shaved and everything for this meeting. So over to you, Siddharth. You have the names of all our doctors here.
Yes.
And Harshad, Mihir, please don't run away. Be here for this.
All right.
I'm going to mute myself.
Yes,
and,
yes.
and
You
you
can
take
mute
over.
yourself. All right. Thank you. Thank you, Satyan, for that introduction. So वही आप सब अपना camera on रखिए तो मेरे लिए better होगा because I need some reaction. I want to see you guys. Otherwise, it just be like I'm performing into the void. So like some of them like Dheeraj said, Ankit, Dr. Satyan, everyone's a doctor here. सबके लिए doctor word ये नहीं use करने वाला हूँ. So सब हाँ कैमरा ऑन रखिए, थैंक यू. और बाकी जो कैमरा ऑन नहीं रख सकते हैं और ऑडियो ऑन नहीं रख सकते तो रिएक्शन दे दो, तेज से ताली वाला जैसे मैंने दिया नीचे, या थम्स अप. बेसिकली यू कांट क्रिटिसाइज मी एट ऑल. I'm the Indian government right now. Can't criticize me. Only good things you can say about me. But wow, thank you for calling me for this. The minute I was invited to perform for Bombay Spine Society, who was that? When I was invited to perform for Bombay Spine Society, I was like, मैं पक्का आ रहा हूँ क्योंकि मैंने जितना स्लिप डिस्क पे पैसा खर्च किया है मुझे सारा रिकवर करना था. ठीक है, I have spent a lot of money and आप लोगों का presentation और heated arguments देख के I don't know. I thought I was a strong person till the time I saw this presentation where you guys are doing surgeries and stuff, and I don't think I can do it. And आप लोग का सेशन देख के मतलब मेरे को स्कूल का थोड़ा PTSD हो गया because I thought like Mr. Mihir was my teacher suddenly. It just felt like okay, this is very this thing, but it's great to be here. Once a Greek philosopher once said like change is the only constant, but if he was born today he'd say back pain is the only constant. यार मेरा बैक पेन खत्म ही नहीं होता है यार पूरा टाइम. लाइक आई नो लिटरली ऑल द बैक वर्ड्स, scapula, trapezius, rhomboid. I've had all these injuries, serratus, sare. Like I have had so many back injuries, and just generally I'm not ever going to buy Club Mahindra lifetime voucher. I've asked Dr. Satyan to give me his loyalty program क्योंकि मुझे काफी लगेगी जरूरत. Wow, you guys feel really sad right now. like वापस चलाओ बैक का जो इंजरी का वीडियो सब लगाओ वापस. But okay, then I'll just get into my material. like I said, it's a tough time to be a comedian in India. I literally have to remove my spine at this point. I can't grow one because क्या है comedian को जेल वेल में डाल रहे हैं आजकल, आप लोग को पता है कि नहीं? आर्यन को भी जेल में डाल दिया, तो मैंने क्या किया, घर पे मैंने जेल जाने का प्रैक्टिस चालू कर दिया है, जैसे मेरी मॉम ने आज मेरे को दाल दिया, मैंने उसके अंदर और पानी डाला, बोला पतले दाल का आदत लगाना पड़ेगा, मैं मॉम इज लाइक बेटा हॉल में आके खाना खा, मैं बोला यार मैं सुब्रतो रॉय नहीं हूँ, ठीक है, मेरे को जेल में 1 BHK नहीं मिलेगा, चुपचाप दरवाजा खोलो और मेरे मुंह पे थाली मारो, क्योंकि आजकल थोड़ा डर लग रहा है, क्या है ना, इंडिया में ना कॉमेडियन जाते हैं जेल और स्कैमर जाते हैं लंदन, और हमारे पास स्कैमर से पैसे वापस लाने का कोई प्लान ऑफ एक्शन नहीं है, तो हम लोग बोल रहे चक इट, हम लोग वेब सीरीज ही बना लेते, हम लोग बनाए जा रहे बैड बॉय बिलियनर, स्कैम 92, हम लोग ने करप्शन को ही जॉनर बना दिया है, सॉरी समवन पीछे किसका आवाज आ रहा है, हाँ जस्ट म्यूट योरसेल्फ, थैंक यू, हम लोग करप्शन को ही जॉनर बना दिया है, हम लोग बनाए जा रहे हैं, और मेरे को ऑनेस्टली बताऊं तो प्रॉब्लम नहीं है स्कैम से, अभी कोई नया स्कैम होता है ना, तो मेरा दोस्त आके मेरे को बोला ब्रो रफा स्कैम में 10,000 करोड़ चले गए कंट्री के, आई एम लाइक वो स्कैम नहीं है, वो प्री प्रोडक्शन है, ठीक है, अगर वो स्कैम नहीं करेंगे तो शो कैसे बनेगा, लाइक एंड आई हैव नो प्रॉब्लम विद अ स्कैम, मेरा प्रॉब्लम पता है किसके साथ है, OTT प्लेटफॉर्म के साथ, क्योंकि मैंने टैक्स के पैसे भरे, उसका स्कैम हो गया, उसके बाद OTT प्लेटफॉर्म भी मेरे से 999 मांग रहे हैं वही शो देखने के लिए, मैं बोल रहा हूँ मैं शो का प्रोड्यूसर हूँ यार, मुझे फ्री में दिखाओ, मैं टैक्स रिटर्न दिखाता हूँ अपना, लाइक मुझे दिखाना चाहिए ना, ओ मैन काफी लोग चले गए यहाँ से सीधा अपना कैमरा बंद करके, गुड टू नो, बट वही है यार, थोड़ा मतलब like I was watching that show, I don't know how many of you all have seen that show Scam 92, the Harshad Mehta one. Yeah, thank you Dheeraj and Agnivesh, if that's the right pronunciation. वही मैं देखा यार वो शो, एंड आई रियलाइज कि हर्षद मेहता काफी घटिया स्कैमर था, बिकॉज स्कैम करके जेल गया यार वो, like I'm sure Vijay Mallya was watching that show in London, on his 4K curved LED TV, being like यार पहले टिकट बुक करनी होती लंदन की, उसके बाद स्कैम करना होता है, and like the show is basically called Scam 92, it's based on a book, the book is called The Scam, बट जब उन्होंने शो बनाया दे लाइक लास्ट में प्लीज 92 डाल देते, वरना पब्लिक कंफ्यूज नहीं हो जाए कि कौन से स्कैम की बात चल रही है, बहुत सारे है ना, कॉमनवेल्थ, बोफोर्स, आई वाज सरप्राइज्ड दे डिडंट कॉल इट स्कैम 92 फर्स्ट फाइनेंशियल क्वार्टर, Dheeraj is my actual Dheeraj right now, I'm just looking at him, his smiley face, and I'm like अच्छा किसी को तो मजा आ रहा है यहाँ पे, and Harshad has a great smiling picture DP, so I'm assuming he's laughing a lot. But yeah man, like I saw that show yaar, I mean the people who saw that show, I want to tell you like Harshad Mehta got caught, why, because वो show में हर dialogue rhyme करने पे ही लगा हुआ था, उसका scam से ज्यादा rhyme scheme बनाने पे था यार, like I think इसके लिए he got caught, मतलब मैं बोल रहा हूँ यार वो शो में हर जगह रिस्क है तो इश्क है, मेहता का राजमा मार्केट मजामा, अगर हर्षद मेहता अभी पैदा होता ना वो गली बॉय में एक्स्ट्रा बनता, like and like हम लोग आजकल ये डायलॉग यूज कर रहे हैं, रिस्क है तो इश्क है, टू लाइक इंस्पायर अ फ्रेंड्स टू डू स्टूपिड स्टफ, कि दोस्त बोलता है ब्रो दारू पी के गाड़ी चला, नो प्रॉब्लम, रिस्क है तो इश्क है, I'm like how can you use this dialogue to inspire, like वो शो का हीरो हर्षद मेहता था नहीं, लास्ट एपिसोड में वो मर जाता है, like वो शो की एक्चुअल हीरो है सुचेता दलाल, who exposed the scandal, the journalist in the show, बट प्रॉब्लम है हम लोग कभी भी अच्छे वाले कैरेक्टर को कोई कूल डायलॉग देते ही नहीं है, राइम सिर्फ हर्षद मेहता ही करे जा रहा है, like I was actually waiting in the last episode, she will go up to Harshad with Hathkadi and be like सुन हर्षद embezzlement है तो imprisonment है, just waiting for that. But yeah, having said that, I'll just like talk safe material because it's really important. I live with my parents, guys. I don't know where you, I mean, this is Bombay Spine Association, so I'm assuming आप सब Bombay से हो. Yeah, I live in Bombay and with my parents क्योंकि Bombay में rent कुछ ज़्यादा ही महंगा है. जैसे ही मैंने रेंट का प्राइस देखा मैंने बोला चकिट माँ बाप से ही दोस्ती कर लेता हूँ, वो ज़्यादा सस्ता पड़ेगा. जैसे ही मैजिक ब्रिक्स पे प्राइस देखा मैं बोला यार मेरे माँ बाप दिल के क्या साफ लोग हैं यार, पता ही नहीं था मुझे, उनका सी थ्रू दिल है एकदम. आई लिव विद देम, मेरे घर पे ना थोड़ा ऐसे रिवर्स बागबान वाला सिचुएशन चल रहा है. लाइक मेरे पेरेंट्स को चाहिए मैं घर छोड़ के जाऊं, बट फिर मैं हर रोज उन्हें टाइपराइटर खरीद के दे रहा हूँ. I'm like, नहीं नहीं, आप अपनी किताब लिख लो, नो प्रॉब्लम. Yeah, Bombay has too much of an issue with space. Thank you, Vishal Kunnani, for that applause. I really appreciate that. He's given me one. तुम लोग सब मेरे इस पे spotlight. He's given me a reaction. I can see all of y'all. मैं टेंशन मतलब मैं अपनी शक्ल देख के नहीं परफॉर्म करने वाला हूँ. Like that'll just look weird. बट नहीं यार, मेरे पेरेंट्स के साथ मैं रहता हूँ एंड वही बॉम्बे में स्पेस इज जनरली अ ह्यूज इशू. यू नो, बॉम्बे में इतना प्रॉब्लम है ना स्पेस का कि लेपर्ड भी आईआईटी जाना पड़ता है उसको. लाइक और किधर स्पेस नहीं मिल रहा है, सब जगह चला गया है अपना. एंड लाइक इंडिया में मतलब प्रेशर कितना ज्यादा है यार लेपर्ड पे भी, कि उसको भी साइंस कॉलेज ही जाना पड़ता है. बाजू में विस्लिंग वुड्स है, उधर कभी नहीं जा रहा लेपर्ड. लेपर्ड के माँ बाप बोल रहे हैं नहीं, कॉलेज जाएगा तो इंजीनियरिंग के ही. यू नो, बाकी but that's great to do this joke in a science crowd. I never thought I'll always get a full science crowd in the audience, but yeah, I live with my parents. And क्या हो गया ना, लॉकडाउन हो गया तो मैंने मेरे पेरेंट्स को बैठ के समझाया कि देखो अभी ना आई हैव टू वर्क फ्रॉम होम, तो ये घर पे बैठ के मम्मी पापा बेटा ये सब नॉट अलाउड. ठीक है, अभी हम लोग स्ट्रिक्टली कोवर्कर्स बनेंगे. You know, we are strict co-workers. Like from 9 to 5 we'll be co-workers, and then 5 onwards we'll go back to being a family. तो आजकल मैं 9 से 5 के बीच में माँ बाप के साथ में सुट्टा ब्रेक लेता हूँ, और 5 बजे के बाद वो लोग मेरे पे चिल्लाते तू सिगरेट पीता है क्या. एंड आई एम लाइक डोंट मिक्स पर्सनल एंड प्रोफेशनल लाइफ. या मैं अपने माँ बाप मतलब सीरियसली यार, मैं और मेरी मॉम आजकल पानी के मटके के बाजू में मिल रहे टू बिच अबाउट अदर कोवर्कर्स, व्हिच इज मेनली माय डैड, क्योंकि वो बर्तन साफ नहीं कर रहा. वी लाइक प्लीज कर लो यार, यू नो. Oh yeah, I live with my parents and I like them, but there is this thing that we have, you know, it's called generation gap. क्योंकि क्या है ना, my father he really worked hard in life so that I could afford Netflix. लेकिन उनका देखना रह गया, you know, वो टेस्ट नहीं डेवलप कर पाए. तो मैं एक रूम में बैठ के देख रहा हूँ नार्कोस, दूसरे में वो देख रहे हैं तारक मेहता. लेकिन आवाज सुन के लग रहा है असली ड्रग्स तारक मेहता में चल रहे हैं. यहाँ पे पाब्लो तो सिर्फ बेचारा बेच रहा है, जेठालाल क्यों इतना चिल्ला रहा है. आई एम श्योर उसका डीलर पाब्लो ही होगा इतना ज्यादा. वही है, लाइक आई लिव विद, आई डोंट अंडरस्टैंड, लाइक आई डोंट रिलेट विद द जनरेशन गैप, बिकॉज you know, like it's very weird, you know, like my parents have superstitions, you know, like very weird ones. Like उस दिन दिवाली थी, my dad came up to me, like बेटा आज दिवाली है, मैंने घर पे चिपकली देखी, इसका मतलब जानते हो क्या. I'm like नहीं, कभी बैठ के सोचा नहीं कि चिपकली देखी तो क्या होगा. He's like भगवान पैसे देने वाले. I'm like ये अच्छा लग रहा है यार, काफी सुपरस्टिशन. आएगा पैसा तो थोड़ा इधर भी दे देना, यू नो. मैंने भी आधी चिपकली देखी थी, और मैं सोच रहा हूँ यार अगर चिपकली देखने से पैसा आता है दिवाली पे, तो दिवाली पे मुकेश अंबानी तो पूरे इंडिया का चिपकली छुपाता रहेगा, यू नो. इट विल लाइक किसी को भी चिपकली नहीं दिखना चाहिए, खास करके अनिल को तो एक भी नहीं दिखना चाहिए. ठीक है, मुझे उससे ज्यादा अमीर रहना है. Nice. Kshitij is looking like he's again watching the PPT. Kshitij, you're fine, no? Yes, अच्छा चलो, he's smiling now. It's good. वही यार, बहुत सुपरस्टिशियस है यार. माय पेरेंट्स आर वेरी सुपरस्टिशियस. कुछ भी होता है, बटरफ्लाई आ गया बोलता है बटरफ्लाई इज आवर एंसेस्टर, यू नो. इट्स वेरी गुड. कौवा आता है, कौवा इज आवर एंसेस्टर. मैं बोल रहा हूँ यार, ये दादा दादी घर के आसपास ही काहे को घूम रहे हैं, उड़ सकते हैं ना. बोलो जाओ पेरिस जाओ, यू नो, यहाँ पे ही घूम रहे इधर उधर, क्या प्रॉब्लम. लाइक सीरियसली, मतलब कोई भी जानवर देखो, मेरे पेरेंट्स उसको सुपरस्टिशन बना देते. लाइक उसके बाद मैं गया जिम कॉर्बेट रिसेंटली, उधर मेरा डैड टाइगर देख के भाग गया यार एकदम. एंड आई एम लाइक रुको ना, पीछे से माता जी आ रही है, यू नो. आपने कब से बोला भाई बुलावा नहीं आया है, अभी उन्होंने साक्षात उबर भेजी है. तो बैठ के जाओ वैष्णो देवी और बोलो घर पे चिपकली भेजे जल्दी. धीरज, आई लाइक दैट you're on headphones with your son. Please don't let him listen to anything I'm saying. Okay, जल्दी बड़ा हो जाएगा. You want your child to not be like me and listen to you. So yeah, it's very weird, you know, to like live with your parents. And because yeah, like I don't talk to my dad that much in life, just generally, because क्या होता है, every time me and my dad we start talking, no, my mom, she goes to the room, she comes back dressed as a WWE referee. She's like लफड़ा होने वाला है, let me be the judge, you know. तो मैंने डिसाइड कर दिया, मैं मेरी फैमिली के साथ सिर्फ बैठ के देखता हूँ कौन बनेगा करोड़पति, यू नो. द बेस्ट थिंग टू डू विथ योर फैमिली। तो तुम लोग खाना खा रहे हो और देख रहे हो कि दूसरे लोग अमीर हो रहे हैं, और साथ में आपको रियलाइज हो रहा है कि पूरे परिवार का जीके इतना घटिया है ना कि तुम 50,000 भी नहीं कमा पाओगे शो पे। तो अपना पैशन, अपना जॉब करते रहना पड़ेगा तुम्हें लाइफ में। सो वही यार, आई वॉच दैट शो विथ माय पेरेंट्स एंड आई डोंट गेट दैट शो एनीमोर। व्हेन आई वाज यंग इट यूज्ड टू बी लाइक एकदम मतलब बेस्ड ऑन अ पर्सन्स नॉलेज, कि एक इंसान का कितना नॉलेज है उसको उतनी रिस्पेक्ट मिलती थी। Now even KBC has become poverty porn, like all other reality shows, कि जितना गरीब आदमी उतना ज्यादा TRP बढ़ेगा। एक दिन मैंने एक फार्मर को देखा वो शो पे, मैंने अमिताभ के आंख में देखा TRP आप जाते हुए। वो शो में था और वहां पे बोल रहे कि बताइए आप फार्मर हो, किसान हो, आप अपनी प्रॉब्लम्स बताइए क्या क्या है। एंड फार्मर जेन्युइन गाय, ही हैज इश्यूज, ही सेइंग कि यार मेरे गांव में 2 घंटा लाइट आ रहा है, 2 घंटा पानी आ रहा है, 2 घंटा फैन आ रहा है। देन द कैमरा पैन्स टू अमिताभ's फेस बिकॉज ही इज गिविंग अ मोनोलॉग टीआरपी बढ़ाने की। लाइक देखो दर्शकों, हमारे देश के किसान कितनी मेहनत करते हैं ताकि तुम्हारे और मेरे प्लेट पे अनाज आ सके। तुम्हें नहीं लगता कि हमें हमारे देश के किसानों के लिए कुछ करना चाहिए? मैं टीवी देख के बोल रहा हूँ, आप हमें क्यों बोल रहे हो यार? सर पनामा पेपर में आपका नाम आए, अब फालतू में मेरा गिल्ट काय को बढ़ा रहे हो? आपके पास पनामा के बैंक में टैक्स इवेडेड पैसे है, मेरे पास बॉम्बे के HDFC में नहीं है। आप फालतू में मेरा गिल्ट बढ़ाए जा रहे हो। मैं घर पे पनीर खा रहा हूँ, I'm like shit यार, फार्मर्स के बहुत लग गए हैं, फालतू में मेरा गिल्ट बढ़ाया जा रहा है। I live with my parents, and it's very weird. Just generally मुझे समझ में नहीं आता है लाइक कि मेरा डैड यार, क्योंकि मेरे डैड को बहुत कॉन्फिडेंस है लाइफ में। मेरे को उससे प्रॉब्लम है, मेरे जनरेशन को उतना कॉन्फिडेंस है ही नहीं। आई डोंट नो तुम लोग मेरे जनरेशन से हो कि नहीं, बट थोड़े लोग काफी यंग दिख रहे हैं। तुम लोग समझोगे, हम लोग गूगल में पैदा हुए यार। मेरे लाइफ में कोई भी सवाल आता है मैं गूगल करता हूँ, मेरे में डाउट आ जाता है। नॉट माई डैड। माई डैड थिंक्स जितना नॉलेज उनके पास है दुनिया में भी उतना ही है। लाइक मैं गया था मेरे पेरेंट्स के साथ एक बार लखनऊ, ठीक है, एंड आई आस्क्ड माय डैड अ वेरी वियर्ड क्वेश्चन, आई डोंट नो व्हाई, कि आई एम लाइक एयरपोर्ट से होटल कितना दूर है? इज लाइक बेटा वो तो पता नहीं, लेकिन अगर हम लोग बैंगलोर में होते ना तो कम से कम 1.5 घंटा तो लग जाता। एंड आई एम लाइक क्या करूँ ये इन्फॉर्मेशन के साथ? ठीक है, अगले बार बैंगलोर जाके आपको पूछता हूँ, पता ना इंदौर में क्या हाल चल रहे हैं। No, it's very weird. I don't. And yeah, you guys are from Bombay, so let me tell you, if you ever want to feel rich in life, you should go to Lucknow once. Because Bombay कुछ ज्यादा ही महंगा है। मैं उधर जाके रियलाइज किया, वाह, फाइनेंशियल स्टेबिलिटी नाम की भी कुछ चीज होती है। वहां पे सब कुछ सस्ता था यार। लाइक टियर 2 में इन्फ्लेशन पहुंचा ही नहीं है बॉम्बे वाला। मैं लखनऊ गया यार, मैं पैसे खर्च कर रहा हूँ, खत्म ही नहीं हो रहे। लाइक मैं रिक्शा वाले के पास गया, मैं बोला सर मुझे चौक तक छोड़ना, बोलते हैं 30 रुपया लूंगा। मैं बोला 30 रुपया? सुन बॉस, ना तेरा ना मेरा, मैं कम से कम 100 तो दूंगा, ठीक है? मेरे को अवध का राजा बुलाने लग गया, मेरे पे रोज वाटर फेंकने लग गया। आई फेल्ट रॉयल्टी इन लाइक 100 रुपीज देयर। और मैं वहां पे गया टुंडे कबाब खाने, which is like very famous in Lucknow. And the problem with every famous place is that उसके ऐसे 4-5 डुप्लीकेट जगह बन जाते हैं। तो I went into one of them and I'm like, sir, is this the original टुंडे कबाब? वो बोलते हैं सर यही वाला ओरिजिनल है। हमारा जो ओनर का परदादा था उसने सब मुगल राजा के लिए खाना बनाया, वाजिद अली शाह के लिए, अहमद अली शाह के लिए, अल्ताफ के लिए भी। एंड हम लाइक अल्ताफ कौन सा किंग था? इज लाइक वो ओनर का छोटा भाई है, कुछ काम नहीं करता है, हम भी उसे मुगल राजा ही समझते हैं। अभी उसने सामने अपनी दुकान स्टार्ट की, उधर मत जाना सर, उसका नाम रखा है उसने ओरिजिनल टुंडे कबाब, एकदम नकली है वो सर, हमारा मेन है। एंड आई एम लाइक यार स्कूल में मेरे को ये वाली हिस्ट्री काय को नहीं सिखाई? काय को बता रहे बैटल ऑफ प्लासी में क्या हुआ? बताओ ना, कौन सा भाई बेस्ट टुंडे कबाब बना रहे हैं? और हमने टुंडे कबाब खाए, लाइक कुछ 6-8 प्लेट टुंडे कबाब खाए, बिल आए 200 रुपया। मैंने वेटर को 100 रुपया टिप दिया, उसने जाके अपनी रेस्टोरेंट स्टार्ट कर ली। मैं 25% पार्टनर हूँ। नेक्स्ट टाइम आप लोग कभी जाओगे ना लखनऊ, गो टू माँ कसम, यही है सबसे ओरिजिनल टुंडे कबाब, वो मेरा वाला चेन है, वही ओरिजिनल है, मैं बता रहा हूँ तुम्हें। एक एक करके मेरे को ऐसे लग रहा है ना मैं एक ज़ॉम्बी अपोकलिप्स में परफॉर्म कर रहा हूँ, क्योंकि एक एक करके सबके कैमरा बंद हो रहे हैं यहाँ पे। सो आई डोंट नो, अभी 3-4 लोग बचे हुए और लेट्स सी। ये यार मैं आई डोंट
was the good joke.
Sorry?
That was the good joke.
That was a good joke.
Which all other people I think didn't hear.
Okay. I don't know why that's coming from, Chitij, but
it must be hard playing a comic when you can't hear anybody's reactions.
Yeah, I know. That's why I was looking for faces. But अभी डॉक्टर लोग अभी बोल रहे हैं नहीं करना है, तो मैं आर्ग्यू भी नहीं कर सकता हूँ, you know. I can't even go for second opinion. तुम सबने एक साथ कलेक्टिवली बोला है नहीं करेंगे ऑन. और
आपने फीस थोड़ी कम दी लगता है.
सॉरी,
आपने थोड़ी फीस कम दी लगता है.
मैंने फीस कम दी. हाँ, मैं तो बोल रहा हूँ ना, मैं लॉयल्टी मेंबरशिप ले लिया है मैंने ऑलरेडी. तुम लोग के साथ मैं नहीं कुछ लफड़ा करूंगा. बस
मेंबरशिप एक जन से ली, इसलिए बाकी के सब नाराज है आपसे.
नाराज गाइस, डोंट वरी, मैं आ रहा हूँ सबके पास.
सबसे लॉयल्टी मेंबरशिप लेनी पड़ेगी आप.
सबसे मैं एक L1 L2 L3 सबसे आके एक चेक कराऊंगा. डोंट वरी गाइस. एंड Kshitij, if you can go on mute now. I thought
you needed some
banter.
Yeah.
I mean, see, I have half an hour to perform, and if you talk to me, you just make my job easier. So, like, we can talk for 10 more minutes, and we can make this into a conference again. But so, or else I can continue with my jokes. Yeah. No.
Go ahead.
Yeah. I'm going ahead. Just give me a second to breathe. Like, I was talking about my parents, and I don't know if you guys have been like Indian parents, like really like emotionally blackmail their children for no reason, you know. Like मैं बचपन से जब भी खाना नहीं खा रहा हूँ, you know, my mom and my dad, they tell me please eat your food because there are hungry kids in Africa. And I'm like, तो आप भिंडी क्यों बना रहे हो फिर? You know, आप कुछ बेटर बना दो ना यार. बचपन से मेरे को बोले जा रहे there are hungry kids in Africa. मैं सोच रहा हूँ ये अफ्रीका में सिर्फ बच्चे ही क्यों भूखे हैं यार? कौन है ये खराब अफ्रीकन माँ बाप बच्चों को खाना ही नहीं दे रहे, यू नो. खुद मस्त पिज्जा विज्जा खा रहे और बच्चा बोल रहा है हमें तो बोल रहे पागल तेको देंगे तो इंडिया में सिद्धार्थ कैसे खाना खाएगा? उसके माँ बाप उसको कैसे ब्लैकमेल करेंगे? और मैं यहाँ पे बॉम्बे में टीवी देख रहा था बचपन में, और वहाँ पे अमेरिकन टीवी शो चल रहा था जिसमें बच्चा खाना नहीं खा रहा था, तो उसकी मॉम उसको बोल रही प्लीज ईट बिकॉज देयर आर हंग्री किड्स इन इंडिया. मैं बोल रहा हूँ यार, ये माँ बाप लोग की लॉबी वर्ल्ड हंगर सॉल्व होने नहीं दे रहे. दे लाइक कोई बच्चा भूखा रहना चाहिए ताकि हमारा वाला खाए, यू नो. और अमेरिकन बच्चे खा ही नहीं रहे यार. उन लोगों के सैलेड में ना ब्रेड होता है, चिकन होता है, मेयोनीज होता है. यहाँ पे हम लोग बैठ के गोभी खा रहे. लाइक खा लो यार थोड़ा. लाइक अमेरिकन किड्स शुड ईट some vegetables. You know, the two leading causes of death in America are gun violence and obesity. और वहाँ पे कभी कभी मैकडोनल्ड्स में शूट आउट हो जाता है, तो पब्लिक एकदम कंफ्यूज, यू नो, कि ये डेथ किस में डाले हम लोग. नहीं, आई एम जस्ट सेइंग यार, जो देश में गन लॉज इतने खराब है, कम से कम उधर तो थोड़ा कार्डियो कर लो. नो, वहाँ पे स्कूल में बच्चे गन लेके आ रहे हैं, यहाँ पे अपने को लंबे बाल अलाउ नहीं कर रहे. मेरा गोभी तुम लोग खाओ, मेरे को तुम लोग दे दो तुम्हारा सैलेड. ओके, बट गाइज डोंट वरी, मैं तुम लोगों को एक दो और चीज़ें बताता हूँ. मेरे लाइफ में मैं सिगरेट नहीं पीता हूँ, क्योंकि मैंने बचपन में एक स्टैटिस्टिक पढ़ लिया था कि सिगरेट टेक्स अवे 11 मिनट्स ऑफ योर लाइफ. एंड वो लोग मेरे को कोई चॉइस भी नहीं दे रहे कि ज़िंदगी के कौन से 11 मिनट काटने. यू नो, ऐसा सिगरेट बनाओ मैं अभी चेन स्मोकर बनूं. कि मेरा दोस्त बोल रहा है ब्रो यहाँ से अंधेरी तो 55 मिनट्स दिखा रहा है. I'm like, रुक जा, शॉर्टकट है मेरे पास. यू नो, कभी उबर मालब्रो का नाम सुना है क्या तूने? तो बनाओ ऐसा सिगरेट यार प्लीज, क्योंकि मेरे को लाइफ के सारे डल मोमेंट्स हटाने हैं. लाइक अगर ऐसी सिगरेट बनेगी ना, मैं क्या करूंगा, आईपीएल की मैच चलाऊंगा, 3-3 ट्रैक लेके सारे एड्स खत्म कर दूंगा. क्योंकि आईपीएल के एड में आप देखो ना यार, क्रिकेटर आके मिक्स सिग्नल्स देते हैं यार. मैं एक एड देख रहा था जिसमें धोनी आके बोलता है आई एम प्लेइंग ऑन पोकर स्टार्स, आर यू गोइंग ऑल इन? बोला माही भाई आप 2 वर्ल्ड कप जीता, आपके लिए तो मैं किडनी भी दे दूं, यू नो. फिर अगले एड में आके बोलता है मैंने तो अपने रिटायरमेंट के लिए म्यूचुअल फंड में पहले ही पैसा डाल दिया. एंड हमने ये पहले बोलना था ना यार. मैं ऑल इन चला गया हूँ ऑलरेडी, और पत्ते भी 2 और 7 खुले. बनाओ यार ऐसा सिगरेट बनाओ लाइफ में. मैं बोल रहा हूँ अगर ऐसा सिगरेट आया जिससे मैं मिनट्स काट सकूं, मैं जाऊंगा थिएटर में और सिगरेट पी के डायरेक्टली एंटी स्मोकिंग एड ही हटा दूंगा. क्योंकि मैं नहीं पी रहा हूँ ना सिगरेट. मेरे को काय को दिखा रहे हो मुकेश के फेफड़े? क्योंकि क्या है, मैं पॉपकॉर्न लेके बैठ गया हूँ, मेरे दोस्त जो सिगरेट पीते हैं वो बाहर सिगरेट ही पी रहे. दे लाइक अरे अभी तो ऐड आएगा यार मुकेश वाला, मैं यहाँ पे बैठ के फालतू में ऐड देके जा रहा हूँ कब से. बट और एक और चीज हो रही है मेरे लाइफ में, जिसका अगर तुम लोगों के पास सेकंड ओपिनियन डॉक्टर है तो प्लीज दो। तो वो ये है कि गाइज मैं टकला हो रहा हूँ, आई डोंट नो तुम लोगों को यहाँ से अगर दिख रहा है तो, जा रहे हैं मेरे बाल बेसिकली। मैं गया डॉक्टर के पास, मैंने डॉक्टर को बोला कि इसके लिए क्या करूं मैं बाल के लिए, तो बोलती है मैं गोली दूंगी बट उसके साइड इफेक्ट है। मुझे क्या है साइड इफेक्ट, बोलती है इम्पोर्टेंसी एंड लैक ऑफ सेक्स ड्राइव। बोलो ये साइड इफेक्ट क्या है यार, ये तो काफी पॉजिटिव लग रहे हैं। बाल बाल रहेंगे और बच्चा नहीं होगा। आई थिंक दैट्स व्हाट आई वांट, यू नो, बिकॉज हेयर वे बेटर देन चिल्ड्रन, यू नो। मतलब आप बाल कलर कर सकते हो, आप पर्पल बच्चा लेके नहीं घूम सकते, यू नो। आप बाल काट सकते, बच्चे को मैक्स पीट सकते हो यार, लाइक उसमें भी सोसाइटी लुक्स डाउन अपॉन यू। नहीं नहीं, ये सब नहीं चाहिए मेरे को। और डॉक्टर से मैं पूछा मेरे को हुआ क्या है, बोलती है यू हैव मेल पैटर्न बॉल्डनेस विच इज हेरिडिटरी एंड माय डैड इजंट बॉल्ड। तो मेरे को मेरी मॉम पे शक हो गया। हाँ, लाइक मेरी मॉम क्या करेगी यार, लाइक डॉक्टर लाइक नो नो बाबा, मेल पैटर्न बॉल्डनेस कम्स फ्रॉम द मटर्नल ग्रैंडफादर। तो अगर आपके बाप टकले तो आपका 20% चांस है टकला होने का, बट अगर आपके ग्रैंडफादर लाइक नाना जी टकले तो 80-90% चांस है आप टकले होंगे। मैं बोल रहा हूँ तुम लोग शादी के पहले काय को कुंडली मैच कर रहे थे, ये टकले मैच करते थे ना फादर इन लॉ सन इन लॉ के। तुम्हारे नैरो माइंडेड बिहेवियर की वजह से टकले पोते निकल रहे हैं यहाँ पे। और टकला तो नाना ही होगा ना यार भाई, डाउरी का स्ट्रेस किस पे था, यू नो। मेरा दादा तो अभी भी मोहॉक बना के घूम रहा है, डाउरी के पैसे से उसने खरीदा सेट वेट जेल। 80 साल का फक बॉय है मेरा दादा। Yes, thank you for that clap. Kshitij is gone for the entire set. I have last 2-3 minutes, so I'll tell you guys before leaving. I want to like end on a positive note, guys, which is that don't worry. अगर हम लोग you know COVID से बच गए तो don't worry. Climate change आ रहा है हमें मारने के लिए. That's right. Dheeraj, have you seen any climate change documentary? Just say thumbs up if you have, or if you've not. No, good. वेरी गुड, लाइफ अच्छी चल रही है ना, प्लीज मत देखना, क्योंकि क्लाइमेट चेंज की डॉक्यूमेंट्री ना नेचर का बागबान है, तुम्हें गिल्टी फील करा के ही छोड़ेंगे यार। मैं देख रहा था एक डॉक्यूमेंट्री जिसमें उन्होंने बोल रहे ये पोलार बेयर कितना क्यूट है ना, हम हाँ बहुत क्यूट है, दे लाइक ये मरने वाला है क्योंकि तूने एसी बंद नहीं की, एसी बंद कर। फिर मैं एसी बंद कर रहा हूँ, मेरे पसीने छूट रहे, मैं बोला यार फक इट, अगर मुझे पसीना आएगा पोलार बेयर को भी आने दो, एसी वापस चला दी मैंने। मैं क्या करूँ यार, मेरी एम्पैथी आती है 21 डिग्रीज में, उसके ऊपर मैं बहुत घटिया आदमी हूँ। वही मैं देख रहा हूँ ये क्लाइमेट चेंज की डॉक्यूमेंट्री, और मैं रियलाइज किया कि क्लाइमेट चेंज की वजह से सारे क्यूट क्यूट जानवर ही मर रहे हैं, यू नो, पोलार बेयर, पेंगुइन, डॉल्फिन, कोई कॉकरोच नहीं मर रहा है, कोई स्कॉर्पियन नहीं मर रहा है, वो लोग न्यूक्लियर हॉलोकॉस्ट सर्वाइव कर रहे हैं क्योंकि उन लोगों को पता है कि भाई अपने लिए कोई आने नहीं वाला, बिच्छू बचाओ आंदोलन करने के लिए अपने को इवॉल्व करना पड़ेगा थोड़ा। और मैं देख रहा हूँ वो डॉक्यूमेंट्री, उसमें मैं रियलाइज कर रहा हूँ सबसे ज्यादा मेरे को खराब सी टर्टल के लिए लग रहा है, एकदम सैड लगा यार वो पूरा टाइम। सी टर्टल इज ऑलवेज सैड, उसकी शक्ल देख के लग रहा है वो बैठ के क्लाइमेट चेंज की डॉक्यूमेंट्री देख रहा है पूरा टाइम। एंड आई नो यार उसकी लाइफ में प्रॉब्लम चल रहा है, आसपास में प्लास्टिक वास्टिक है, बट थोड़ा तो स्माइल कर दे यार, इतना आए लोग दूर से शूटिंग करने, तू ऑस्ट्रेलिया में स्विमिंग कर रहा है, मैंने बच्चों को माइन खाड़ी में जंप मारते हुए देखा है, इतना स्माइल करते हुए, हमने कितने हम्बल बच्चे हैं, कुछ सीख ले लाइफ में। एंड आई नो आई फील बैड, आई डू फील बैड फॉर सी टर्टल्स, क्योंकि आसपास हम लोग ने ना सारा प्लास्टिक उसको ही दे दिया जाके, प्लास्टिक का कप, प्लास्टिक का फोक, प्लास्टिक स्पून, डाइट कोक का कैन, सब है बेसिकली, जो भी हाउस पार्टी का सामान है वो सब जाके सी टर्टल को ही मिल रहा है। मतलब हर हाउस पार्टी का थीम तो क्लाइमेट चेंज ही है। अभी मैं जा ही नहीं सकता हूँ पार्टी पे, मैं एक दिन पार्टी पे गया, दोस्त ने दिया प्लास्टिक कप में दारू, बोला अबे पढ़े लिखे गवार, तेरे जैसे लोगों की वजह से सी टर्टल मर रहे, उसने दारू वापस लिया और बोला कि अगले बार मत आना पार्टी पे, तो मेरे लिए खुद उबर बुक करके निकाला मेरे को। That's when I realized if you want to be environmental friendly, you stop being friendly. तुम्हारा कोई दोस्त बचता ही नहीं है, इसके लिए एनवायरमेंटलिस्ट जा जाके पेड़ को हक कर रहे हैं, यू नो, उनके पास ऑप्शन नहीं है लाइफ में। वही है, बहुत प्रॉब्लम है यार, मैं बता रहा हूँ तुम लोग को, आई जेन्युइनली वांट टू सेव द एनवायरनमेंट, यू नो। मैं देखता रहता हूँ इंस्टाग्राम पे ऐड आते, यू नो, buy this t-shirt, it's made of sustainable cotton, part of the proceeds go to save the tiger foundation. I was like ठीक है, I'll buy this t-shirt, but t-shirt का प्राइस है 4,500। मैं बोल रहा हूँ मैं टाइगर बचाने के पैसे दे रहा हूँ कि उसके अय्याशी के वे, मुझे टाइगर बचाना है, उसे स्पॉइल नहीं करना। मैं पता चला उसको इतने पैसे दिए वो शिकार करना छोड़ देगा यार। उसके पास हमने डियर आ रहा है, बोल रहे डियर को नाच के दिखा दो रहा, डियर बोल रहे क्या हो गया, शिकार नहीं कर रहे, नहीं नहीं नहीं, पैसे बहुत आ गए मेरे पास। आजकल मैं खुद वीगन बन गया, इनफैक्ट से प्लांट प्रोटीन खा रहा हूँ। बहुत महंगा है यार अर्थ बचाना। मैं देख रहा था, मैंने योगा मैट देखा which was made for wasted nylon cloth, wasted fishing nets. It was for $9,000. And I'm like, I want to save the environment, but not on EMI. वरना अगर मैंने वो EMI डिफॉल्ट कर दिया, मेरे पे कोई डॉक्यूमेंट्री नहीं मिलेगी और मैं लंदन भी नहीं भाग पाऊंगा। मैं दहीसर चेक नाके पे मिलूंगा, बोलेगा सर एक आदमी 9,000 का स्कैम करके भाग रहा है, क्या करना है उसका। पे क्राइम पेट्रोल का एपिसोड भी नहीं आएगा। तो मैं फाइनली वो वाला, थैंक यू फॉर पुटिंग ऑन हर्षद एंड सुधीर। आई रियली वाज लुकिंग फॉरवर्ड टू दैट स्माइली फेस। थैंक यू सुधीर एंड थैंक यू विशाल फॉर गिविंग मी अपलॉज, वर्चुअल अपलॉज। वो बहुत महंगा है यार। फिर मैंने फाइनली ना एक वो 200 रुपए का बैम्बू टूथब्रश देखा, बैम्बू टूथब्रश बोलते हैं, प्लास्टिक के बदले यूज बैम्बू टूथब्रश, 200 रुपीज ओनली। आई वाज लाइक डन, आई एम गोइंग टू बाय दिस बिकॉज मेरे पेरेंट्स ने मुझे बचपन से एक ही चीज सिखाई है कि जितनी लंबी चादर हो उतने ही सी टर्टल बचाओ। तो मैंने खरीद लिया वो वाला और मैं ब्रश कर रहा हूँ, फीलिंग बेटर देन एवरीवन एल्स, आई फील सुपीरियर ह्यूमन बीइंग। फिर मैं मॉल में गया, मॉल के टॉयलेट में मैंने अपने हाथ धोए, मेरे सामने एक आदमी ने आके 11 टिश्यू पेपर निकाले, 11 टिश्यू पेपर निकाले जा रहा है यार वो। मैं बोला यार तू जादूगर है क्या? मैं रुका था लास्ट में, खरगोश कभी निकलेगा। कंटिन्यूसली मैं वहां पे खड़े रह के सोच रहा हूँ ये आदमी निकाल रहा है 11 टिश्यू पेपर, मैं ले रहा हूँ बैम्बू टूथब्रश। कल को मैं और ये सेम सुनामी में क्यों मरे बे? कोई सुनामी ऐसा वाला बनाओ ना जो इंसान को आके देखे कि बोले सुना है सर आप 11 टिश्यू पेपर निकालते, लाइक हाँ, लाइक ठीक है डालो 40 फीट पानी डालो इस पे, पूरा परिवार डुबा दो इसका। मेरे पास है, बोले सर आप बैम्बू टूथब्रश देते हैं? हम लाइक हाँ दे, लाइक ठीक है आपकी गाड़ी का हम धो के जाते हैं आपके लिए। कुछ ऐसे वाला बनाओ। Okay, on one last joke I'll do for you guys because Shita also gave me an applause or a thumbs up, so I am really encouraged, and with others as well. I'll do one last joke, which is that guys, मैं जब भी छोटा था ना, मैं टीवी देखता था और उस पे ना स्टे फ्री की ऐड आती थी, ठीक है, और मेरे को तब पता नहीं था कि पीरियड क्या होते हैं। मतलब ऑनेस्टली बताऊं तो अभी भी कुछ खास नहीं पता है, बट जब मैं तभी देखता था वो ऐड, मैं रियलाइज करता था उसमें लड़की का कॉन्फिडेंस कुछ ज्यादा ही हाई होता था यार। पहाड़ वहाड़ चढ़ रही है, कराटे सीख रही है, बॉस को प्रेजेंटेशन देके बोल रही है आई डोंट लाइक यू, यू आर फायर। उसके बाद कराटे का कपड़ा पहन के पहाड़ चढ़ रही है। एड के एंड में बोल रहे महीनों के उन दिनों के लिए खरीदो स्टे फ्री। मैं टीवी देख के बोल रहा हूँ शिट, मेरे महीने के उन दिन कब आने वाले यार, ये तो काफी मजेदार लग रहे हैं। बताओ पैट के साथ क्या करना है यार, मेरे को भी चाहिए ब्लैक बेल्ट लाइफ में। फिर समर आ गया, समर में उन लोग बोले कि सारे बच्चों को ट्रैक पे लेके जाएंगे। हम लाइक इसके तो काम आ ही जाएगा यार, ये तो एड में ही दिखा है पहाड़ चढ़ने के लिए यूज करे। तो मैं गया दुकान पे, मैं बोला सर एक स्टे फ्री देना, जरा पहाड़ चढ़ना है, और साथ में एक थम्स अप भी देना, क्योंकि पहाड़ से उतरना भी तो था ना यार मेरे को। All right, guys. On that note, I hope you guys have enjoyed this. And if you haven't, then go back to surgery. Nah, I'm just kidding. You guys doing a great job, and I hope by the time in the next decade we find some cure for slip disc and back issues. You guys are my only hope. All right, thank you, and give it up for Dr. Satyan, I guess, or whoever's talking next. Thank you.
Yeah, on that note, I think we should invite Kshitij only to talk and conclude the session.
You need somebody. He craves for attention. Somebody has to speak up.
Yeah, your banter with him was one of the highlights of the
In
show.
real life, somebody would have, like, he would have heard our laughter or some reaction.
Yeah. Yeah. He's not married, I think. We all are married, so we are used to people shouting at us. He's not. So, chalo. So, see you guys. Thank you for being here. I hope you enjoyed this. And we'll see you. Harry, what do you want to say?
No, I just said it was a good event today. Nothing more than that.
Okay, thanks. So I'll see you all tomorrow morning, bright and early. First session is at 8 o'clock because we are associating with Association of Spine Surgeons of Nepal for a meeting on TB spine. And then from after that we have our presidential sessions, which will be which has very esteemed uh, faculty who are going to be presenting. So I'll see you tomorrow morning, bright and early. Good night, everybody.